Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. We're going to start our first session today in the last day of our conference. We're going to start with the topic of headache updates with Dr. Mazen Al-Qasimi. Dr. Mazen, he's a consultant and program director of emergency residency program in King Faisal Specialist Hospital and Research Center, Jeddah. He's also deputy of chairman of emergency department. He did trauma fellowship from McMaster University 2015, and also he has a master of medical education from King Saud University from at 2018. Welcome, Dr. Mazen, and we'll have a great lecture with you, inshallah.
I hope you are awake. I would like to thank the scientific committee for inviting me for the SASM again this year. They gave me a strange topic this time. They gave me headaches, so they usually call me for trauma cases, for trauma presentations, but they gave me headache this time. I hope I will not give you headache at the end of the presentation. Okay. So first, I'm just giving a scenario that is published in Annals of Emergency Medicine. This is a 30-year-old woman who came to the AD with severe left-sided headache. The headache was of gradual onset during 2 hours. There was a mild photophobia, nausea, but no vomiting. She described scintillating scotoma roughly 15 minutes before onset. Had similar headaches before 2 times, seen neurologist, had an imaging before, all are negative, and she was diagnosed to have migraine. She came with the same presentation this time. It's the same thing, no risk factors, not immunosuppressed, and the physical examination is completely normal. Including cerebellar, ocular pressure, everything is completely normal. She was given pain medications, she improved, and she wanted to go home to sleep. This is the scenario that it was a made-up scenario to show that there is outcome bias for the expert witnesses. That's why it's important to be on the standard of care for those cases. So this scenario is made up, then they give it to expert emergency physicians to check if this is appropriate care or not. According to the author of this article, this is outstanding care. When they show it to the expert physicians, they gave this case bad outcome to some of the experts, good outcome to some of the experts, and no outcome for experts, and they asked them to rate the care. And this is what they found. You can see in headache, most of them rated the care as appropriate, but when there is no outcome or bad outcome, you can see the redness started to the redness of poor care came out. So this is a problem. The standard of care for chest pain, as you see at the bottom, because in the scenario of chest pain in the same study, it was poor care. So whatever the outcome, you can see that people know that this is poor care. For headache, the outcome will decide if your care is poor or not. This is a problem. That's why you need to listen very carefully to the next slides. Okay, so first, analgesia is not part of the assessment. So we used to give analgesia for patients, and then if the patient improves, means it's not serious. This study shows that you can see the etiology of headache in the fourth column. All those patients improved with analgesia completely. Some of them, their headache is gone. And then they were discovered to have serious etiology for the headache. So just to know how bad it is you are trying to find a needle in a haystack. It's so difficult to find the reason for secondary headache because it's only 2% of the cases that comes to the emergency are having serious pathology of headache. 98%, they have simple headache, primary headache. And the diagnosis, as you see, is all, if missed, is going to be medical legal cases. Some of them will decide the future of your career if you miss them. So you can see this is the emergent causes of the second. This is the most common emergent secondary causes of headache, and as you see, it just varies. You cannot diagnose it by just doing one thing. Not single biomarker or imaging would diagnose the headache, the reason of headache, if it's secondary. So you need to take a very good history to decide your path. So one of the clues is the age. If the patient is more than 50 years, they are more likely to have secondary cause for headache 5 times more than the younger generation. So 50, and if they are above 75, you need to really walk the patient out because it's 11 times more. So just doing history, good history, will help you in filtering out the patients who need further investigations and thorough examination. If the patient is having associated neurological symptoms, altered level of consciousness, diplopia, weakness, of course, then it's not enough just to treat with analgesia. If there is any, if the age is more than 50, if the headache is chronic more than 6 months and progressive, then this probably tumors. If the patient is having neck pain, if the headache is in occipital location, if it's worsening with lying down or cough or Valsalva, or the worst headache in the morning, then you need to worry about high ICB. And of course, the red flags, if the patient is immunosuppressed, especially HIV, if they have seizure, syncope, focal neurological deficit, if they are anticoagulated, if the maximum intensity happened within 1 minute, if they have previous surgeries, if they are close to labor, and if they have autoimmune disease, then you need to worry. So, who knows the Ottawa headache rule? Ottawa subarachnoid hemorrhage rule? Hands up. Okay. So, this was presented by the authors, by Berry and colleague, as a magic solution. That 100% of the cases, 100%, if they don't have these 6 things, then they don't have serious cause, or they don't have subarachnoid hemorrhage. And mostly does not have serious cause for their headache. But they have selection bias. The 590 patients were not enrolled that could change the results. And they are excluding anyone with papilledema. I don't know who have seen papilledema here. Who are examining for papilledema? I've never seen anyone, any papilla edema. I could not diagnose any papilla edema in my life. So, and I will assume that most of us did not see papilla edema except in the pictures. Did not see it in fundoscopy. So this is a study on photographs that are done by a machine to diagnose papilla edema. And you can see that in fundoscopy, direct fundoscopy, 0 were diagnosed by fundoscopy. 0 of the papilla edema. And 16 out of 35 were diagnosed by the photograph. So we don't do it. In one of the studies, only 14% of the patients who needed fundoscopy had fundoscopy by emergency physician. And out of the 14%, 0 were diagnosed. 0. Nobody diagnosed, no patient was diagnosed to have papilla edema by fundoscopy. So the digital camera is promising. Still, we are not well trained to read the pictures, but it's better than the fundoscopy. Fundoscopy is 0%. We diagnose 0% of the cases, but with digital cameras, we are able to diagnose 59%. What about ultrasound? Ultrasound for papilla edema is done on novice on residents from R1 to R4, and you can see that the papilla edema is done. The fundoscopy was done by ophthalmologist, and then compared to residents, and you can see that there is a lot of false positive, false negative, and this was done on 5 millimeter optic nerve sheath. If they drop it to 4.6, the sensitivity improves, so and specificity improve. But in the meta-analysis, it showed that expert ultrasonographer could reliably diagnose papilla edema. So in one of the studies on the performance of ultrasound, it says that an expert is the one who has done 25 ultrasound for the optic nerve, done very well, and diagnosed 3 patients with papilla edema, will be able to recognize papilla edema by ultrasound. So the training for optic nerve sheath, it will require only 4 minutes in that study. And then in 25 times, if you see in 3 papilla edema, your sensitivity and specificity improve dramatically, and you can see the likelihood ratio improves dramatically. What about the 6-hour rules? Anyone heard about the study? If the patient came in the first 6 hours, CT is negative, off he goes. He doesn't have subarachnoid hemorrhage. Anyone heard that? Of course, everyone. So in this study, also they mentioned papilla edema, and all the CT were read by neuroradiologist or somebody who's reading CT brain frequently, not a resident, consultant. All are attending who are doing this for living. So it's not training. And this cannot be replicated. So if we combine CT, 6-hour rule, and Ottawa, you can see that Ottawa still performed very well. It's the same author, by the way, 100%. And the CT with neuroradiologist repeated in the same centers, you can see the sensitivity decreased to 95.5 in the first 6 hours. So 5 cases were missed of subarachnoid hemorrhage by neuroradiologist. But you can see that this, if you combine both, this improves decrease the number of LB done by almost 50%. And it decreases the hospital admission by around 5%. So what ASIP is telling us is that don't trust them very well. Don't trust the rules very well. So in 2019, in ASIP recommendation for headache, to manage acute headache, non-traumatic headache, they gave Ottawa level P because of selection bias mainly. And they put they put a recommendation in that it might be harmful in some cases. You might miss subarachnoid hemorrhage if you apply Ottawa only. And for the 6-hour rules, the same thing, level P. And you can see that this is a problem of the CT. It diagnoses only subarachnoid hemorrhage. If it's other diagnoses, it will be missed. And you can also miss subarachnoid hemorrhage if you apply the rule. Okay, it's enough. I'm giving you a headache. So I'm giving you the conclusion. So the conclusion is you need to be really worried about patients who are coming with headache. Take a very good history. Make sure that they had images before. Then they have to have full normal neurological examination, no bubble edema by ultrasound, and then you need to pray that they don't have a serious diagnosis. If you decide to do an imaging within the 6 hours, combine it with the Ottawa rule, and you need to consider other serious diagnoses like CVT, meningitis. CVT in particular is going up after the COVID vaccine. I don't know if it's AstraZeneca or others, but in UK they have studied this and they found that the majority of their CVT in 2021, the majority of CVT reported were related to the vaccine. They found antibodies related to the vaccine. So CVT is going up. It used to be rare, 0.4% of all headaches. But we don't have new evidence after the vaccine. I think we need to keep it up like subarachnoid hemorrhage. And it's more aggressive too. All the CVT diagnosed in UK in 2021 were more aggressive. They don't respond well to anticoagulation. Thank you.
Thank you, Dr. Mazin, for this great lecture. Now it's the time for the questions. So, any question for Dr. Mazin?
Good, I'm asking a question then.
Okay. Thank you, Dr. Mazin. Now we'll have second lecture, update in sepsis, gonna be presented by Dr. Ali Sharif. Dr. Ali Sharif, he is a senior consultant and associate professor of emergency and critical care medicine at King Abdulaziz Medical City and King Saud bin Abdulaziz University for Health Sciences at Ministry of National Guard. Dr. Sharif has lectured nationally and internationally. Welcome, Dr. Ali, and I hope to enjoy the lecture with Dr. Ali.
Thank you, Dr. Wael, and Assalamu alaikum wa rahmatullah. Good morning, all. Pleased to be with you this morning, and When I was asked to present this topic, it's a really huge topic, but looking to the agenda for the conference, I've tried to select what is really important for us in talking about update of sepsis. بمناسبة العيد الوطني نبارك القيادة الرشيدة ولجميع المواطنين وللcommunity of emergency medicine. So I'll try in the next 20 minutes, and thank you, by the way, Dr. Mazen, for giving me a few minutes as well. And the next 20 minutes to review the evolving history of the guidelines of sepsis. And all of us knows such guidelines, and we'll talk about it a little bit. And then updated sepsis definition that are also evolving with time. I will try to appraise some of the literature that presented on the most recent guidelines. Most of you are aware about the Surviving Sepsis campaign. Surviving Sepsis campaign that are launched on, the declaration was launched in 2000, early 2000. And the first guidelines was produced in 2004. And subsequently, every almost 4 years, there are multiple guidelines. The last one was on 2021 and has been divided in 2020, pediatric and adult. So today we'll be talking about the adult sepsis guidelines. Over the last 2 years or so, there are multiple talks from different bodies, and we have the American College of Emergency Physicians with other group on 2021 released their own guidelines, and this is excellent. I think this is an excellent start, and I hope that one day our society can join such guidelines with expert opinions. By the way, 2021 of Surviving Sepsis campaign is a huge group of people that get together from different societies and countries, and they produce their guidelines. Today we will try to focus on such guidelines, and we'll try to present the evidence that are related to such guidelines. Hopefully it's kind of updated. And I will introduce some of the, let's say, expert opinion that heard over different conferences. Unfortunately, fortunately, the sepsis are a topic that evolving so quickly. And I've just been given an article a few days ago from my colleague, which I was not aware of. I introduced this article here as well. There is no doubt that guidelines has improved the process of care and improved mortality as well with different evidence, and this is also great. Guidelines are put together to help people to follow, but not necessarily is a must. So you have the right to look at individualized care as well. So in regard to the definition of sepsis, from 1996 to almost 2015, there is no change in such definition. 2016, the third international consensus definition for sepsis has been produced. And they define sepsis as a life-threatening organ dysfunction caused by dysregulated host response to an infection. So we have two, organ dysfunction and infection that require to be there for the definition of sepsis. And clinically, organ dysfunction, we agree or we disagree, that assist by using Q-SOFA for us as an emergency physician, which change of acute level of consciousness, which acute change of Q-SOFA more than or equal to 2 qualify for that definition. I'm not going to go for the Q SOFA, because most of you are aware of this. On the other hand, the theoretical definition of septic shock is a subset of sepsis which underlying circulatory, cellular, and metabolic abnormalities which are profound enough to substantially increase the mortality. And by clinical criteria, serum lactate high, more than 2, hypotension requiring vasopressor, in the absence of hypophilemia. So such definition is being criticized somehow, and I hope that we have an updated definition soon. So I'm going to present quickly 2 cases, and I would like to have your view about these 2 cases. And to be fair, I put this is in different colors. This is black and yellow, and you could recognize Dr. Jamil is here, that's nice. And there are also blue and white. So the black and yellow is 70 years old female, fever, cough for 3 days. She's febrile, confused, lethargic, tachypnic, blood pressure is low for her. And then you get a lactate, which sometimes you might get it early, sometimes you might get it late, based on your institution. Urine microscopy or urine at the bedside was not suggestive infection. So I need raise of hand, how many of you think this is an infection and potentially septic shock? Yes, 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 yes. Wow, good number, huge. So this is straightforward, right? The chest X-ray came to be, you don't even waited for the chest X-ray, but the chest X-ray confirmed your thinking. So this is sepsis, potentially septic shock. And the other person, which I have seen about a month ago, is a 90 years old male. His son said maybe he used medication of hypertension, but not continued on that. Benign prostatic hyperplasia. Presented with acute confusional state for the last 2 days, and he has a recent foot ulcer, small ulcer to be honest, was prescribed an antibiotics. He's afebrile, however is disoriented to place. His respiratory rate is 20, blood pressure somehow low, temperature is normal, blood sugar is okay, lactate is 3, urine, not suggestive infection, chest X-ray, little bit cardiomegaly, no obvious consolidation. How many of you think this is sepsis or potentially septic shock? Good, less, but not as the first one. So what I would like to present here, sepsis has a diagnostic uncertainty. Some of the studies has shown that more than around 33% of we as an emergency physician diagnose them sepsis or septic shock, and they tend to be not septic. So you have to calculate the risk of benefit of initiating some of the medication and intervention related to sepsis. This is the agenda, but looking at the last 2 days of the conference, I think I will just focus on the antibiotics, fluids, and vasopressor. We believe you can take hours to speak about sepsis, but we'll talk about the evidence and guidelines related to such treatment or management of sepsis. Infection, we'll talk about antibiotic timing, and most of us has in his mind sometimes limit to give antibiotics in the emergency department, and whether this is right, whether this is maybe need to be changed. In outcome of immediate versus early antibiotic in severe sepsis and septic shock, a systemic review and meta-analysis of 13 different studies, prospective, retrospective, observational, and cohort. And the results, there is no difference in mortality between patients receiving antibiotics in 0 to 1 hours versus 1 to 3 hours. So it's just give us an idea, is 1 hour is important or not really so. The other study that discussed the association between antibiotic delay, interval, and hospital mortality, that this is a retrospective cohort, 12 EDs in the US, evaluate the association of recognition and antibiotic administration delay on hospital mortality. And the recognition time has been defined as time in hours from triage to antibiotics order, and administration time has been defined as time from order to infusion time. And the results show that recognition and administration delay, both associated with hospital mortality, recognition time from triage to, say, this is sepsis or septic shock, more than 6 hours associated with increased odds of mortality, administration more than 1.4 hours associated with increased odds of hospital mortality. So delay is not bad, is not good. And this is our body that says or suggested that shorter time frame is preferred, strongest support for early antibiotics in septic shock. Current data do not recommend a singular time target that improve outcome for all. How about surviving sepsis campaign? It mentioned that those who are in septic shock and you are aware or it's definite or probable or sepsis, even if the shock is absent, you administer the antibiotics immediately. And to be honest, I like this immediately. So our first case seems to be clear for almost everyone. Then we have to administer antibiotics immediately. 1 hour, 5 minutes, it doesn't matter. If the sepsis is possible, and this is uncertainty of 30% or more based on your institution and your available diagnostic certainty, then you might have more time for recognition, which is within 3 hours. So this is a recommendation by an expert, and I believe this one might be more appropriate for antibiotics timing. Now, before going from antibiotics timing, I just want to tell you about 2 cases that I have seen in the last week. I have been covering ICU, and we have 2 cases that admitted through emergency department, 2 days in ward, then moved to the ICU with septic shock. Admitted with sepsis, pneumonia. However, the antibiotics choices was not really, let's say, appropriate. So choices of antibiotics is quite important based on community prevalence, based on bacteriogram, and based on host immune system, as well as the resistant strains in the community. So all this has to be considered before choosing the antibiotics. And we heard a good lecture yesterday about antibiotics choices. So this is in regard to timing. So we said sepsis, infection, organ dysfunction. Then for organ dysfunction, I will discuss the volume, and I will discuss the vasopressor. We'll see the recommendation about this. Those who remember the early goal-directed therapy article, which was released in 2001 by Emmanuel Refer in a single center study, it's a landmark article on early 2000. So it has decreased mortality. At that time, everybody were happy that we have something that decreased mortality from sepsis, because it's a huge problem. So in their algorithm, which was for patient mainly from emergency department within 6 hours of their arrival, they discuss multiple, can I use a pointer here? Is there any way to use a pointer? They discuss multiple factors, CVB, mean arterial blood pressure, and central venous oxygen saturation to achieve goals of resuscitation and improve such mortality. However, over years, and this, by the way, the Refer study has been incorporated in the sepsis guidelines till about 2016. Over years, we have an evolving evidence to suggest that such guidelines that require invasive CVB, central line, arterial line, and other things that might not necessarily to be true. So we have 3 different studies, Promise, Process, and Arise in different countries, huge, nice, good, excellent studies, and say that early gout-directed therapy or your usual care more or less is the same. So basically going back, so I'll guide you through this algorithm if you don't mind. CVB is not really mandatory because we know now that it's a static hemodynamic measure, and it might not give you really an excellent data, except maybe on the right ventricular failure and others. Now we get to know that we need more dynamic measures of hemodynamic, such as ultrasounds or passively grazing or others. So we have looked at these over the last 2 days. Excellent dynamic measures. Then we could look for our patient if they're needing more fluids and they are fluid responsive, or we can say they are good enough for volume and then we might need something else. So all of us, and immediately, if we get a patient with sepsis or septic shock, we'll give them volume. So your question that comes in your mind, what kind of volume will you give? Will you give colloid? Most likely albumin. This is what we normally use. Or crystalloid. And I'll be talking about the emergency phase of resuscitation. So we have a good study that examine colloid, albumin, and crystalloid, normal saline, and there is no change in mortality. And we know albumin is costly, so probably it's not something that we need to give in the emergency department, okay? Very few indication, but generally for guidance, resuscitation is something that maybe crystalloid is good. Then the second question that can come to your mind is normal saline better or balanced solution, which is more physiological, is better? And to be honest, this is quite difficult because we keep juggling between these two for the last few years. So we agree that colloid, I hope that you agree that colloid for emergency resuscitation of sepsis and septic shock, maybe we can keep it away. SMART study on 2018, they examined the balanced crystalloid versus saline, and to be honest, was found to be excellent one, particularly for major adverse kidney events. In 30 days, it showed a better. Also in subcategory group or secondary analysis, mortality is better. So, but this is not was really for sepsis, for all comers. So this is an excellent study. So we switch our mind, at least at that period, to go with balanced solution. Since the release of the Surviving Sepsis campaign 2021, there are multiple studies examining this question. The last one was the classic trial, and this trial was 2022, and for septic patient, or majority, half of their patient is almost septic and critically ill. No difference in mortality, no difference in adverse outcome. So normal saline, balanced solution, more or less is good. So negative study in that regard. So despite 2000, their recommendation is becoming weak. 2016, it might be bigger, might be more, but 2021 suggests using balanced cholesterol as a weak recommendation, low quality of evidence. I think this emerging evidence last year and maybe sometimes in near future is something that to say you have the choice to use normal saline versus or balanced solution. However, we have one evidence to say balanced solution is better. So I'm more to lean toward balanced solution. So we have chosen crystalloid for fluids. How much fluids? How much do we give? We have a reflex in our mind that give 30 ml per kg. And this can be okay for initial resuscitation. However, we have an improved technology and knowledge to say whether the patient needs less or more. So I don't think this 30 ml per kg for every patient coming to the emergency as an adult patient to go. But how did we come with this 30 ml per kg? You know, after these strong, huge 3 trials of PROMISE, ARISE, and PROCESS, they presented a meta-analysis to examine these 3 trials, and pre-randomization to this trial, which was early, median volume of fluid that's being given about 30 ml per kg. So they said, okay, initial resuscitation 30 ml per kg. We should be careful about this amount. So I don't think there is any specific volume that's been given to each patient. Particularly since we have dynamic measure of fluid responsiveness. Then, an evolving literature to say about fluids is whether an early restrictive versus liberal fluid resuscitation is better. So this is something that been examined recently and was published in 2023, and they look at early on, before patient receive more than 3 liters within 4 hours of their presentation, and they randomize to 2 groups. Those who are met the criteria for sepsis or septic shock to restrictive group and liberal group. And the restrictive fluids group, they prioritize vasopressor initially, and the other group, they are giving fluid unless a criteria met to give a pressure, and the criteria has been listed here. I'll not go in the details of the study. However, this study again did not show any mortality benefits among each one of the groups. So whether you go with the restrictive group or the liberal group, it seems to be okay. But logically, the restrictive group received less volume compared to the liberal group and received earlier vasopressor compared to the other group. So no difference in adverse event or mortality. So you want to go that route, the other route. But again, look at the some of the patient dimorphic and illness in such group. So those who are chronic end-stage renal disease, they benefited from restrictive strategy compared to the liberal strategy, and maybe on the chronic heart failure group as well. So this is a signal that the restrictive group might have in some category of patient better outcome. Our American College of Emergency Physicians stated that administration of fluids to patients with hypotension or evidence of hypoperfusion is important. Many benefits from 30 ml per kg. However, they do not support pre-specified volume or body mass adjusted volume for all patients. So we realized that volume may be a balanced solution. Volume has to be individualized based on your available technology now and skills. And then if the patient with volume that not getting better or volume not responsive anymore, then you want to initiate some vasopressor. So this is my last item about managing with vasopressor. I'll not go to the details of the evidence, but we have very strong evidence and guidelines to suggest epinephrine is your first choice of septic shock patients. Both guidelines suggested this. MAP, again, to utilize MAP of 65 is your resuscitative target for septic shock initially. one slide about using early norepinephrine or vasopressor in someone who is hypoperfused or septic shock. So this is a single center randomized study about 300 patients that they look at early use of norepinephrine versus standard of care. And the median time from ER to norepinephrine about 90 minutes versus 192 minutes. Shock control was achieved earlier within 6 hours, and the early norepinephrine group had a lower cardiogenic edema as well as lower incidence of new arrhythmias. So this is a signal that early norepinephrine, however, they used a small dose for all patients, has not been titrated for almost, if I remember correctly, about 24 hours, so 0.04 microgram per kg per minute, I think. So the recommendation and the guidelines say vasopressor timing may be started with IV administration in severe hypotension or life-threatening hypoperfusion, and do not require fluid threshold to be reached. And I believe this is an excellent statement. And as I said, there are expert opinion coming almost every time I attend or I meet such expert to initiate norepinephrine early on. I come across one recent study to look at the phasal tone of a patient with septic shock and correlate this with the diastolic blood pressure of such patient. If it's less than 40 millimeter of mercury, then you might consider initiating norepinephrine early. We have seen patients that goes to severe shock and they got cardiac arrest, so you don't want to lose patient once they are on bed in front of you. So go ahead and use norepinephrine early with some volume at the same time. We are waiting for such evidence that tell us when exactly to start norepinephrine early on the septic shock. So these two trials are ongoing, ARISE and early vasopressor in sepsis, which are conducted in UK, and hopefully we will hear the results soon and modify our practice based on such evidence. Now, do you give norepinephrine peripherally or centrally? Do you have to wait for central line? No more. So most of the articles that I have mentioned, they have a good number of patients that are given norepinephrine peripherally, however, with conditions. So it has to be a very proximal to antecubital fossa and maybe wide and for a certain period of time. If you look to most of the centers right now and excellent centers, they are using norepinephrine with a limited dose for 24 hours. So this is something that you have to consider, and do worry about this, about giving peripheral norepinephrine. This is the study that's been given by Dr. Sausan a week ago. It's something interesting. Then we have to look at this. This is a herbal Chinese medicine, XPG, and it has been studied in a single Chinese center, a huge number of patients. And they were sick. Their SOFA score were not low, were high. And initiated, I think, within the first 24 hours of their presentation. They look at 28 mortality, they look at different secondary outcome. All of them are favorable. So it seems to be a very promising Chinese herbal medication approved over there, not yet approved in other countries. So we're waiting for this to be available, hopefully, and can treat sepsis and septic shock patient. Well, I have put some few points to maybe take home. I think administering appropriate broad-spectrum antibiotics promptly is quite important in managing sepsis and septic shock. current evidence support about 1 hour of antibiotic administration. Well, time-wise, but I personally believe the time is quite important for quality measures, at least in our community. Administration for confirmed probable septic shock. Current evidence does not support a pre-specified volume for all patients, particularly now we have more dynamic measures. Balanced crystalloid versus normal saline, we don't see any difference in the most recent literature, so you can use either one. Restrictive or liberal fluid resuscitation strategy are acceptable. I think I will go with restrictive. You go with liberal, that's fine. Early use of norepinephrine might be of benefit. I will go with early use of norepinephrine in particular patient. And norepinephrine can be used with a proximal peripheral IV safely. We have no problem with that. And this XPG is a promising antisepsis treatment. With that, I would like to thank you.
Thank you, Dr. Ali, for this great lecture. You covered most of the topic of sepsis in 20 minutes, mashallah. So it's time for the questions. Any question for Dr. Ali? Dr. Jamil have the question here.
Thank you, Dr. Ali. Wonderful presentation. And I think I needed such an update, and I've been away a bit, and you really summarized the whole thing from the get-go. 2002, I started residency 2007, and everyone was talking these days about Manny Rivers' paper, and it changed everything. I do believe, my point of view, we suffer from applying all the new updates of sepsis specifically and the emergency departments. So do you advise, or what's your take on having pre-set orders ready in the emergency department, digitalized or even paperwork, and it's overseen by emergency critical care experts just to ensure the compliance? And I think, and I do believe, I'm a person who really learns a lot from reading such preset orders. Even if I'm not going to pick, it guides us through picking the right orders. So do you think having such a tool in the emergency department would increase the compliance and would improve the knowledge of the resident and even physicians who are not keeping up with the continuous updates?
Thank you, Dr. Jamil. Yeah, I totally agree. And I think if you look at the sepsis or different other modality of different condition has shown some improvement in quality measures as well as training. However, it has to be well set and organized. And now we know for a triage sepsis, we started to have some sort of guidelines. As almost a preset order. So those who have QSOFA or SARS, but it's changing. But there is some guidelines to pick them early and to put them in a place that are capable of managing them. So I totally agree about having a preset order and with a chain of commands to advance the care once really needed. So totally agree. Yeah.
Any other questions? Dr. Ali, I have one question, but just the role of steroids still they are controversial. So in the similar case, do you want to start steroid before vasopressin or vasoactive agent, or after that, in case if you think about it?
Yeah. Well, the steroids since long time and different guidelines recommendation is changing. So I guess now in the emergency department, the current guidelines suggest that, or if you start to have pressures with moderate dose for more than 6 hours, yes. So the most recent update about steroids, yes, steroids with mineralocorticoids. So we have to put both, if you think. So this study was done in a huge number of patients, mainly surgical patient, ICU, and showed of mortality benefits.
Okay.
So I would give steroid if I reach, for example, 0.35 microgram per kg per minute for norepinephrine, and at that time I will be using the second dose or the second agent, which is vasopressin, based on that dose. So if I use both, 5-6 hours, I'll go ahead with the steroid.
Okay. Any question? Thank you, Dr. Ali. So may I ask Dr. Mazen and Dr. Ali to come here to the stage to receive their gift. Now we'll have a break.
Assalamu alaikum. Good morning, everyone. While waiting for more to join us, we would like to start to stay on the track. I would like to welcome Dr. Abdul Sayed. He's an emergency assistant consultant at King Abdulaziz Medical City, National Guard. He's Saudi board and Jordanian board of emergency medicine. He's going to talk today about geriatric emergency. Welcome, Dr. Abdul.
Thank you, Dr. Muhammad. It has been a pleasure for me to present in Sasem. I'm considering myself a son of Sasem. This is my home. I'm not that guy. He's away from Sasem. Thank you for your attendance. Thank you for the organizing committee. Thank you for everyone. I'm taking the opportunity to thank everyone in the volunteering committee and every committee. Thank you for them. I'm going to present the geriatric emergency. All there is risk here. Who does not know me? I'm Abdo. I'm defining myself always as Abdo, just Abdo. I'm here because I love to educate, to inspire, and to make a positive change. This is the first time that you're going to see me for this day. It's going to be followed by second and third time. Okay, to let everyone know that I said yes. I said yes for them. When the scientific committee, they approached me to talk about geriatric emergencies, I said to them, yes, this is my interest, this is my topic. And they put me in a big challenge, by the way. How can I make it summarized? How can I give a brief about geriatric emergencies? Like we are talking about, to put the whole track of pediatric emergencies in just single lecture, which is so difficult, but I'm gonna make it. We're gonna talk about some cases today, geriatric emergency, some tips and trips, and again, I'm gonna send a message to those people who's handling that task. Let's start. Okay, sticks and stones. By the way, majority of the geriatric definitions over the world, they define it based on what? Did you know what? What's the score or what's the criteria that they are defining the geriatric age or the cut point? I have been reading a lot of rules and documentations, either locally or internationally. What I found here is just a small piece of rules for the retiring age, which is a 65. For that, majority of the patient or majority of the people above 65 or 65, they are not thinking that they are geriatric. I'm not gonna get my father almost, he's approaching 65. I cannot say to him, you are approaching shaykhuha, or something like that. It's so difficult. And by the definition, anyone above 65, he's going to be considered geriatrics based on their definition, not on our definition. And there is some sort of terms we should modify it in our talk, in our presentation, in our documentation. Best term to call the people that they are above 65 or 65, senior, older adult, or something like that. Acceptable to be geriatric. It's going to be acceptable. But I don't think so it's going to be acceptable, or you're going to say elderly, old, or something like that. I have been saying that for years. By the way, our colleague in the pediatric, you're going to see that I'm against the pediatric section all the way. No, I'm not against them. But I have a little bit of fight. I'm going to consider it. The pediatric people, they are saying for years, the pediatric people, they are not young adult. I'm going to say the same. The geriatric people, they are not old adult only. Let's start by the cases. Case number 1, 75 female with a leg pain. She got it after direct trauma. She's struck by a door. She have a past medical history of congestive heart failure, hypertension, dyslipidemic. She got proximal lateral tenderness. And the tibial X-ray, it was negative. And still having a pain. What's your plan? What are you going to do next? You're going to say CT. Am I right? The X-ray is negative. Everything is negative. Now what? Okay. We proceed with the CT because the tibial fibula or the tibial plateau fractures, it's going to be missed in about 25% or 15% on X-ray. We proceed with CT. CT is going to be normal, neurovascular intact, and there is no compartmental things to be concerned about. And the ligaments appear to be stable on the examination. Okay, plan. Weight bearing as tolerated. Ibuprofen 600 Q8, BRN, raise therapy. Everyone know it. Return instruction if you get compartmental syndrome symptoms, you're going to get back. Guess what's wrong here? I bet on 500 riyals. This is the only thing that I hold it right now. Thank you, Bukarim. Thank you, Bukarim. I'm a big fan for the other agent or the NSAID in general, but NSAID in particular people, you're gonna harm them more than treating them. For that, look for the lab of the patient 1 month back. There's something abnormal? Always, the geriatric people, when they get old, they get more thick and they lose a muscle. And you know the creatine is just an end product of the muscle. And when you get old, your creatine is supposed to be low and low. 1.3, I'm considering it in a geriatric patient, it's a high. Guess what? The creatine clearance as we know it, it's 30, and it should be above 60. And this patient, she wanted a renal failure, and she got a dialysis. And instead of treating small part, which is 2 centimeters on her leg area, you hurt her kidney, and you make it shut it down. And she went up by renal failure. Okay. I'm going to just give you a small aspect about NSAID and how can worsen the geriatric people and going to make their conditions more worse and worse. Renal failure is going to get worse with the age, absolutely. NSAID is going to accelerate this, and also, as I mentioned before, the patient is congestive heart failure. Absolutely, she's going to be an ACE inhibitor, and it's going to make the dilemma more and more, and it's going to make the fluid retention more and more. And instead of that, I'm a big fan of acetaminophen. Acetaminophen is the safest analgesic on the world if it's going to be used in a regular dose within the therapeutic range per day. Not a BRN. Do not wait for the pain to come. Just kill it and take it BRN. Take it as a regular, not a BRN, instead of ibuprofen. And by evidence-based, there's a lot of researchers, there is a lot of RCT that they are comparing head-to-head ibuprofen or NSAID with acetaminophen, and it's not inferior on the musculoskeletal pain. This is one of the biggest meta-analysis. They did it for 754 RCTs over 350,000 patients. And what they conclude? They conclude that the NSAID increasing the risk of MI, increasing the risk of renal issue, stroke, and heart failure. And it's going to make everything that you want to preserve it, you want to be conservative about it, it's going to be worse and worse. Topical NSAID, I can say there is one of the residents or some of the residents that are attending with me, that I'm doing topical NSAID and making the relative, that making the gel over the muscles, and they are laughing after me. And there's a lot of evidence that supporting topical NSAID over the oral NSAID. And believe me, try it once, and your patient is going to be satisfied. It's going to take a time, 1 hour and a half, but you're going to preserve his kidney, you're going to preserve his lung, you're going to preserve his vessels, you're going to preserve a lot of things. I will not bring a lot of evidence about topical NSAID. Look it up. I'm just raising it. I'm a big fan of topical NSAID. Take-home message. First take-home message. Please avoid NSAID. Oral NSAID, especially in the geriatric people. Let's jump to this case number 2 to catch up with the time. Case number 2, 80 male, 80 years old male with abdominal pain. Pain is diffuse, mild to moderate, no other symptoms, no fever, mild diffuse tenderness, no rebound. Now what? What are we going to do? Just one single exam that you're going to do it. Absolutely everyone here going to do CT. I'm going to cut it short with you. Appendicitis in non-geriatric adult, it's going to be just like the book, like what we have been learning in the medical school. Right lower quadrant, on the McBurney point, there is a rebound tenderness, anorexia. If you're going to give him a burger, he will not eat it. He's febrile, he's a lot of stuff. This is what we have been knowing it about appendicitis in non-geriatrics. Biliary colic also, female, 40, she get harika or acida or whatever, and she get it after that 2 hours. She cannot hold her breath. When you are doing a Murphy, it's gonna be positive. This is in non-geriatrics. The same work for diverticulitis, left lower quadrant tenderness, left lower quadrant abdominal pain, if there is some sort of fever, if there is some sort of vomiting, whatever. And this is epigastric abdominal pain. This is what's going epigastric abdominal pain, radiating to the back. This is what's going with the pancreatitis or non-geriatrics people. But appendicitis and geriatric, it's going to be like this way. How many of us that we have been examining a patient with the right upper quadrant or left upper quadrant abdominal tenderness, and we discovered lately after that he have or she have appendicitis. This is in diverticulitis. And this is also in pancreatitis. It's going to be the same. Due to a lot of innervation issue, a lot of neurovascular compromisation. And this is what? This is an MI. How many times that we found there's some of the geriatric people, they have abdominal pain, and when you examine them, they don't have that much significant tenderness, or their abdomen is not that much hurting them. We discover after that they have an MI. For that, causes of abdominal pain, this is one of studies that did the research of amount of patients. They investigate the causes of abdominal pain that brought them to the emergency. And they found, I just make it collectively, on 61 of bad things that gonna require surgery either on the next day or the next few weeks. You know, the abdominal pain or the abdominal test, it's gonna make you more satisfied more than the ECG, which is it's gonna give you what we are calling it probability or post-probability positive value. A lot of non-so-fun facts about geriatric abdominal pain that they are presenting with abdominal pain. Acute cholecystitis, 60% they does not have a flank or a back pain. 5% is going to be painless. 41 they're going to have a normal WBC. 13% negative fever, WBC, and LFT. Appendicitis, up to 77, febrile. And this is from Rosen, by the way. There's a lot of evidence about not using a fever as a surrogate for acute cholecystitis or appendicitis. Abdominal X-ray is a dumb test. Do not do it. I'm going to convince you after a few seconds to not do it, because it's going to miss a lot of, about 50% of free air. And it's going to miss about 40% of small bowel obstruction. It's a dumb test. And by the way, it will not show a lot of things like malignancy, what we have been knowing it that malignancy is the first cause of intestinal obstruction, large intestinal obstruction in geriatrics. CT abdomen and pelvis changed our management? Yes, this is a study of a prospective observational study for 104 patients. They did it. That how can the CT, pre-CT questionnaire and post-CT, how can the CT make a change in our diagnosis? And guess what they found? They found a lot of, about 45% change on the diagnosis. Like you have pre-CT, you have a diagnosis, and after the CT, you're going to have another diagnosis. Diagnostic certainty. You're going to make sure about it. 40%. Admission is 26. Surgery, 12. And antibiotics, 21. For that, I'm going to convince you more to do CT for the geriatric people that they are presenting with abdominal pain. I'm not saying that everyone, he's going to hit the door with belly pain, you're going to CT him. No. Based on your pre-test probability. We might be too stingy about CT abdomen and pelvis in geriatric patient. This is what we have been visualizing on the social media, the memes, the emergency physician. They are not doing physical exam. They are not doing a history. They are jumping immediately to the CT. Do it in geriatric abdominal pain. I'm going to convince you more. CT findings in this study is diagnostic in 57%. And they did CT for 37 patients and abdominal X-ray for 38 and ultrasound in 9. What they found is the CT is so diagnostic and it's going to give us more diagnostic accuracy. If we are doing the CT and it's going to have a lot of positive findings, did you think that we are doing a lot of CT? I don't think so. If we're going to increase this, the exam, it's going to increase, the sensitivity is going to increase. Take-home message for geriatrics. Number 2, please make the CT default for abdominal pain. Based on your judgment, I'm not meaning that for every adult or non-geriatric, for the geriatric. Case number 3. 82, male pedestrian. He was struck by the car while he's crossing the street. His heart rate is 99, blood pressure 106/68, RR 16, and 99 oxygen saturation. There is something wrong. I didn't bring the case to be straight away. Anyone guess? I still have the 500 in my pocket. I'm going to go. Huh? Say it. Okay. I'm going to go so fast because of the time. It's not too bad. Okay? It's right. It's not too bad. I'm going to convince you. This is, I want you to recalibrating your fighter sign, based, especially on the geriatric people, especially on the trauma geriatric population. This is a study that we found above 70 of age, when they get to trauma, it's going to give higher mortality. Absolutely. Pedestrian more than the automobile. The heart rate in geriatric more than 90, it's equal more than 130 in non-geriatrics. Systolic blood pressure less than 110, it's equal less than 95 in non-geriatrics. RR, always not countable, and you can guess on your nurses. And by the way, the most highly predictors for worrisome outcome is RR. Okay? If you're going to recalibrate this for 52 years old, pedestrian, you're going to say this is probably in a third phase of shock, and you're going to activate either massive transfusion or you're going to give him 2 units at least. For that, I want to recalibrate. This is a study that in a registry, trauma registry, they offer 50,000. 27% of geriatrics. Trauma team activation was 14 compared to non-geriatrics, which is 29. They under-triaged them. You know why they under-triaged them? Because, or they didn't activate that much trauma. You know why? Because they didn't show that they are sick like they have been. You know, the under-triaging doubling the mortality, and moreover, it's gonna make the mortality 4 times. C-spine, Canadian C-spine rule excluded above 65, you cannot apply it. Next is gonna work, but if you're gonna make it more than one point, you're gonna go for CT. Take it with you. Do CT for any trauma patient in geriatrics. Anticoagulation in head trauma, they are bleeding in their heads more and they have a symptomatic ICH because they have more space in the skull. 10% of head trauma patients are on warfarin. 15% of asymptomatic head injury patients on warfarin have an ICH. Delayed bleeding on 6%. Like what we have in a vital sign in pediatric, you're going to say the third time that you are mentioning pediatric. We should do the same in geriatrics. Take home message number 3. Recalibrate your vital sign in geriatric, especially with the trauma. Case number 4. 82, wrist pain after trauma. She she lost her balance and she fell down while she was using a walker. This is a high-risk situation. You're gonna say no. Falls in older adult, it's gonna third of our community they are failing. They got to fall every year, and 2/3 of them they're gonna fall again within 6 months. And first cause of death due to injury or due to trauma in geriatrics is a fall. They are not driving, they are not crossing the street due to a fall. How many times? I didn't say that. I'm gonna run. 6-month mortality. This is one of the research that they did. 6-month mortality. You can say, I just highlight the hip fracture. It's 25. It's compared to the sepsis. It's compared to the congestive heart failure, end-stage renal disease on hemodialysis, and it's so high. For that, treat fall as a high risk. And just one of the things, do not let any geriatric fall down, leaving your department without letting them walk. Let them walk, let them talk, look to their eyes. I'm gonna run. Treat falls as a high risk event. Final case. 85, fatigue, altered mental status, not acting herself, tired, her temperature 37.4, 95, oxygen saturation, RR 16, 102 over 62, 99 room air, dyslipidemic hypertensive, hyperthyroid, not eating, not acting, مدوق العيشة. What do you think? Sepsis in geriatric. Dr. Ali, he did a lot of things about sepsis in geriatrics. I'm going to say that a febrile patient up to 50%, and they found in this study that the baseline temperature for non-geriatrics is 36.2. If they show up in 37.5, they are febrile. Take home number 5. Sepsis does not need a real fever. Just a message I want to send it to you. Like what we are doing with the pediatric, sitting to the same level, playing with the gloves, make it a balloon or something like that, bring a sweet or anything, do the same with the geriatrics. Dr. Dania, she's a section, this is the last 2 slides, by the way. Dr. Dania, she's a geriatric section head on ASIP. I have been doing talk before 2 years or something like that, and she said that she have been missing a lot of da'wat or prayers from our culture or from our geriatric people. By the way, why I said yes? Because, you know, the first message that have been delivered to me from Jiddati, you know, everyone know Jiddati, especially the resident and everyone in the hospital know Jiddati. By the way, the definition of Jiddati, إنه هي اللي وصلت للمنتخب كأس العالم. She said to me, take care of those people, you're going to have the luck in your life. This is a message for our SASM board members, like that they have a section or interest group in European or American, we should do the same. Either interest group or a section or to make our researches or our education about geriatrics more and more. Take it with you. Make a CT the default for the abdominal pain. avoiding said, recalibrating your vital sign, especially in the traumatic geriatric patient. Appreciate your geriatrics a bit more. Sepsis does not need a real fever. Treat falls as a high-risk event. Thank you.
Thank you, Abdu, for this presentation. Anyone have question to Abdu?
I'm going to stay. If you're in the second show, if you're third show, whatever you want, I'm going to do.
Right. If there is no other question, we'll move to our next speaker.
Thank you.
Good morning, everyone. Our next speaker is Dr. Safinaz Al-Sheikh. She's an assistant professor and consultant of emergency medicine at King Abdulaziz University Hospital. She will present a thromboembolism. So please, let's welcome Dr. Safinaz.
بالنسبة للسلايدات كيف تتغير؟ أوكي. عرفتي تظبطيها؟ ما عرفتي تظبطيها؟ It's okay. Yeah. اوكي. وهذه كيف تتحرك بس كذا؟ السلام عليكم وصباح الخير. How are you guys? How is everyone? My name is Safinaz Al-Sheikh, and today I'm going to present the risk stratification in patients with acute pulmonary embolism, the current evidence and perspectives. The reason I actually decided to choose this topic is basically that we have seen a lot of patients in our ED who actually present with pulmonary embolism. This is one of the commonest encountered medical emergency. How many times we have times we actually were not really sure if what we are supposed to do with our patient. Our usual plan is let's do a risk stratification. After that, let's call the pulmonary medicine team, or let's call the medicine team and let's admit the patient. This is the main stream of management in the ED throughout the years. So let's just go through what we have been knowing throughout the years. Pulmonary embolism is commonly encountered in the emergency department with an estimated annual incidence of 39 to 115 per 100,000 individual. The historically mortality rate after PE was reported as much as 18% to 30%. However, the recent studies actually showed that the mortality rate is much lower than this. It actually reached 1 to 3% only. In the decades following the introduction of CT pulmonary angio, an increasing incidence of pulmonary embolism has been actually associated with lower case fatality rate, coupled with an increase in the complication due to the use of the anticoagulation. When we look at our patients in the ED, the spectrum of patients who are presenting with pulmonary embolism actually ranges from asymptomatic patient with patients who are presenting with symptoms of shock versus patients who actually present dead already to the ED. Our diagnostic approach for the suspected pulmonary embolism usually consists of pretest probability assessment, plus or minus potentially D-dimer testing, plus or minus radiological imaging. When we talk about the D-dimer by itself is not considered as an inclusion or exclusion criteria by itself. It has to be combined with pretest probability before we actually decide if we are actually going to consider the patient to have a low risk probability for pulmonary embolism. CT pulmonary angiography is the imaging modality of choice for pulmonary embolism. In case of contraindication for CT pulmonary angio, we actually can go for VQ scan. Focus ultrasound actually have shown a 90% sensitivity and 85% specificity in the diagnosis of pulmonary embolism. After using a multi-organ protocol of examining the heart, lung, and the leg all together. For the risk stratification, when we talk about the risk stratification for the pretest probability for the pulmonary embolism, it's well known that there is no specific sign or symptom that can be actually reliable on to rule out or rule in the pulmonary embolism by itself. So there have been multiple ideas throughout the years. One of them is the clinical gestalt for the patient, the clinical gestalt of the physician for the patient, and the other one is the risk stratification protocols and tools. When we talk about the clinical gestalt alone, it might demonstrate actually a poor performance in excluding the need for further testing in potentially pulmonary embolism patients between different clinicians' examination. But when we talk about the risk stratification tools, it actually combines different clinical factors from the patient by itself with the diagnostics, imaging, or the diagnostics to a diagnostic test, which we have done. And it actually can provide us with a validated clinical pretest probability. A meta-analysis of prospective studies found that the sensitivity of the clinical gestalt of the patient, of the clinical gestalt of the physician, actually is comparable for the sensitivity of the risk stratification protocols, although the specificity was much low. For the risk stratification tools, it was 81%, while when we talk about the clinical gestalt, it was 51% only. The risk stratification tools may actually have a value in decreasing the imaging studies. In this schedule, as you can see, we have a multiple options or a multiple pretest probability scoring systems. The most common ones which are used in the ED is the Wells criteria and the PERC criteria. Yours is a newly introduced risk stratification criteria. It was actually established in 2017. The mainstream about yours is specifically, it actually used the adjusted D-dimer instead of going with the regular D-dimer testing. So when we talk about the Wells criteria actually can divide the patient into low probability, intermediate probability, and high probability. If the patient have a high probability of PE, we should go for CT pulmonary angio immediately. While when we have an intermediate probability, the patient should go for testing for D-dimer. The testing for D-dimer is, after testing for D-dimer, the patient should go for a re-risk stratification with yours criteria to define if the patient actually is high risk or low risk, depending on the yours criteria, and if he actually need to go for CT pulmonary angio or not. When we talk about the low probability after Wells criteria, we should go for PERC rule criteria. If the PERC rule criteria for a patient who have a low risk or low probability in Wells criteria is higher than 1, the patient again should go for a retest for D-dimer. And after the D-dimer testing, he have to go again for yours criteria, risk stratification with the yours criteria before we decide if we need to do a pulmonary embolism study or not. Okay, so congratulations, you diagnosed PE. What's next? When we think about our patient in ED, again, as I mentioned earlier, there is different symptoms, different signs which the patient actually present with. So we have patients who are hemodynamically stable, but incidentally, you found a patient who actually have a pulmonary embolism. It happens. While on the other side, there might be a patient who is severely sick, in shock, and his RV dilate and his RV in his right ventricular strain signs are there in the echo. So all of these patients cannot be actually managed in the same way. Each one of them have a different criteria to be managed in different ways. How can we decide that? So when we talk about the management of PE patient, it's actually influenced by the severity of the PE. Although PE was formerly, pulmonary embolism actually was formerly prescribed as massive versus submassive, the rules actually have changed, and nowadays it's actually prescribed as high risk, intermediate risk, and low risk, depending on the severity of the disease and its mortality risk. In this table, actually, you can see a mortality risk stratification score which was published by the European Society of Cardiology in 2019. As you can see, it actually divided the patient into a high-risk patient with a high-risk PE patient versus intermediate to high-risk, intermediate low, and low. All of these are actually divided depending on the hemodynamic instability and the clinical parameter, with the right ventricular dysfunction, which have been seen on the TTE or CT pulmonary angio, or the elevated cardiac troponin levels. For the anticoagulation options, for most patients with pulmonary embolism who are eligible for oral anticoagulation, direct oral anticoagulations like apixaban and rivaroxaban are recommended over the vitamin K if there is no actual contraindication. Patients who have cancer and associated with thrombosis can be treated with low molecular weight heparin or with oral anticoagulation if they do not have a high risk of gastrointestinal or gastrourinary bleeding. Patients who actually present with require parenteral anticoagulation, low molecular weight heparin is preferred on the unfractionated heparin. And for the patient who have a serious renal impairment, unfractionated heparin is mostly applicable. These are some of the doses for some example for the doses and the restriction for the anticoagulant, which are commonly used in the ED. So let's talk about the patient who have a are high risk PE, or previously known as massive. These patients actually are considered with high-risk PE who have either they are risk stratified as high-risk PE or they actually have been deteriorated despite of the anticoagulation. And these patients actually warrant or require a thrombolysis to become much better. So the American College of Chest Physicians and the European Society of Cardiology have recommended that the patient with high-risk PE and absence of risks of bleeding should go under systematic thrombolysis, while the thrombolectomy and catheter-directed treatment should be reserved for patients with contraindication for thrombolysis. And on the other side, when we talk about the intermediate risk PE, usually these patients are the patients who are hemodynamically stable, but they have RV dysfunction in their echo, or they exhibit the signs of RV dysfunction. In this patient, the intermediate to low risk PE should start on oral anticoagulation or on low molecular weight heparin. But when we talk about the patient who have high risk PE or intermediate to high risk PE, they should receive an anticoagulation with low molecular weight heparin, both together in the first 2 to 3 days, which is considered the time frame in which the patient might deteriorate. For the patients who are in intermediate to high risk PE, the use of the adjunct treatment like thrombolectomy or thrombolysis is actually still controversial. Although for the patient who are in intermediate risk, if they actually show the signs of deterioration after the use of systemic anticoagulation, we might consider starting the patients on thrombolysis. In contrast, catheter-directed treatment has been increasingly performed for patients with intermediate risk PE, and they actually might been associated with improvement in surrogate markers. Patient with low risk. So patients with low-risk PE, as I mentioned earlier, are hemodynamically stable patients who might be treated with either low molecular weight heparin versus oral anticoagulant. Multiple guidelines actually have recommended to consider the early discharges in these patients. The European Society of Cardiology in 2019 recommended a consultation or at least a contact by phone at 3 to 4 days following the discharge, then 10 to 14 days following the discharge, 1 month, 3 months following the discharge, just to follow up the patient and how he is doing. Subsegmental PE. So treatment for subsegmental PE are controversial because there are several guidelines actually recommended if the patient have a subsegmental PE but he have no evidence for DVT, just observe the patient, do not start any kind of anticoagulant. The intra-rater reliability of radiologists in the diagnosing of segmental PE is slightly moderate and false positive results are common. That's why they are not really happy about starting those patients on anticoagulant early on. But if these patients actually present with deep vein thrombosis and subsegmental PE, anticoagulation is recommended. Let's talk about the disposition for our patients. So historically, all the patients who present to the ED with pulmonary embolism are actually admitted. But there have been 2 clinical trials, several observational studies, which have found that outpatient management of selected low-risk acute pulmonary patients to be safe and effective. The introduction of direct oral anticoagulation has an increase in the ease of outpatient treatment. As a result, multiple professional society guidelines actually recommended that the patient with low-risk acute PE can be actually managed as outpatients. Several risk stratification tools are validated to identify the patient with low-risk PE who actually can be discharged home and treated as an outpatient. Some of these including pulmonary embolism. Some of these includes pulmonary embolism severity index and simplified pulmonary severity index. So as you can see, both of these actually consist of demographic data, comorbidities, and clinical signs. These clinical guidelines actually were established to predict the mortality, the 30 days mortality in patients who actually present with PE in the ED. But unfortunately, those are good enough to be used for patients who are in low risk, but we cannot use the same scores for the patient who are actually in a higher risk or who actually might need hospitalization. When we look at the data, so the patient who actually presented with class 1 in the pulmonary embolism severity index or in the class 2 pulmonary embolism severity index, and they actually have a standardized, a simplified pulmonary embolism severity index of 0 point, they actually have a lower mortality risk than 1% in 30 days. While in 90 days, it actually proved that they have a mortality risk of 0.8%. So, moving on, HESITA criteria was actually specifically created to identify the patient who can be safely treated as outpatient. And it includes the comorbidities and the psychological and the physiological and the psychosocial factors. All of these criteria all of these criteria should be considered when we are actually choosing our patient to be discharged from the ED and to be managed as an outpatient. If any of these criteria is present, any of them, even if it's one, the patient is not considered as eligible for discharge or for outpatient management, and the patient should be admitted for inpatient management. In this algorithm, this is basically a summary for all whatever I have said up to now. So in conclusion, an acute pulmonary patients present a unique challenge to the emergency medicine clinicians. Fortunately, the creation of risk stratification criteria help with both the diagnostic workup and the potential for pulmonary embolism. When applying this criteria, it allows the emergency clinician to deliver well-supported and evidence-based care across the entire spectrum of acute pulmonary embolism. And these are my references for this topic. Thank you so much.
So thank you, Dr. Safinaz. Any question for Dr. Safinaz? It's a topic with a rich question, so should be there is lots of questions. So, Doctor, yeah, a microphone. Here, front desk, yeah.
Great talk, Dr. Safinaz, and I thank you for that. A lot of efforts has been done in here. There are actually a lot of the criteria to risk stratify. We have the Wells criteria, you have the Burke criteria, you have the years criteria. Now we are working in an emergency department. And do you think who are having a clinical pathway? I know that you've shown that chart that shows these things that you need to follow and do this. But how practical is this thing?
Well, when we talk about it in the ED, usually the places...
Because these points, you know, you have to count the points, you know, the perk, you need to count certain things. And you get a score, and then you get a score here, get a score there.
Okay.
Unless you are really very good in it, you may not be able to...
That's why the mid-calc is there. Honestly, years before, if you ask me the same question, before the cell phones and before all of the technology, I would say the exact same thing. But nowadays, with all the cell phones all around and the mid-calc, it already had made these kind of the squares, the calculation of the scores and everything much, much easier. So I really think it's viable by now, by nowadays. But again, as I mentioned earlier, the clinical gestalt, it actually have a high sensitivity. But the problem with the clinical gestalt is the specificity. It actually might add up and make you do more diagnostic testing if you actually go with the clinical gestalt. But beside that, there have been actually a good validation for the clinical gestalt of the physician by itself. If we are talking about the clinical gestalt and the risk stratification by themselves without including other physicians, it actually have a good stratification protocol. So you can actually use the clinical gestalt in that if you have an issue with the scoring.
We have another question on the second row.
Thank you. You know, one of the very difficult decisions to make when you are investigating pulmonary embolism in a pregnant patient. What will be your flow algorithm in subsegmental or segmental in presence of pregnancy? That's a big challenge, especially if there is contraindication for thrombolytics or whatever. So, to have any different approach for those?
Sure. So there have been multiple scores which have been validated regarding the pulmonary embolism in pregnant patients. Specifically, when we are talking about the pulmonary embolism, we always have to think about the D-dimer and the adjusted quality and the adjusted number for the D-dimer. So usually what we do, or what have been done throughout the literature, is basically that they should consider risk stratification, which actually have like years criteria specifically, because it actually validates the adjusted D-dimer number. Besides that, we can also added thing is the lower limb ultrasound and the D-dimer by itself. So all of these three combined together can actually give you a good risk stratification for the patient with pulmonary embolism in pregnant patient who might need admission, or actually, in fact, who actually have PE versus who do not have PE. Any other questions?
Yeah, another question. We have 2 minutes. Yeah, we have one question here on the backstage. ورا الكاميرا هنا ورا الكاميرا مان.
Thank you so much for the great presentation. My question for the unstable patient with massive PE. If patient is going to arrest or peri-arrest, I will give thrombolysis on only clinical suspicion or something to be done?
Sure. So the patient with massive PE and who are actually arresting or near arrest, one of the things which you actually can do is basically echocardiography. You can just look at the RV dilation or the RV dysfunction and consider if you have a high probability and high risk stratification with that, you actually can start thromboembolism earlier than what you are thinking about. Because the whole scoring system is actually not for patients who are unstable. The scoring system and the risk stratification for the scoring system is the mainstream for it are the patients who are basically a bit hemodynamically stable and not crashing. But if your patient is crashing, just look at the look at the RV dysfunction and look for the IV strain. And if it's there, and you still have a high susceptibility, and your clinical gestalt actually goes with massive PE or high risk PE, go for thrombolysis as soon as possible if your patient is crashing.
All right, so thank you, Dr. Safinaz. This is an
Sure.
endless question topic. So if you have a question, so you can catch up with Dr. Safinaz.
Sure.
She will be around during the conference, right?
Yeah.
Okay, so
Thank you so much.
thank you so much. Thank you.
Now, the one and the only, Dr. Anas Hamam. He likes to be presented in a special way, right? He's going to talk about a new use of an old dog, ketamine and suicidality. Dr. Anas, he is a consultant emergency medicine at King Fahd Armed Force Hospital and Regional Emergency Medicine Joint Resident Program Director, Western Region. Please welcome Dr. Anas.
It's not up yet. It's on. بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. اللهم اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Good morning, ladies and gentlemen. I'm extremely happy to be on the SASM stage once more. SASM is my home. I've been involved with this scientific assembly since its inception in 2015 and its first conference in 2016. And I'm extremely grateful for the scientific committee for extending me their generous invitation to be on this stage once more to talk to you today about the use of ketamine in the suicidal patient. First of all, okay. I don't think this is functioning, so. Okay, so I have nothing to declare, whether it's a financial conflict of interest or intellectual one. The first question we really should ask is how much of a burden is suicide in Saudi Arabia? And the answer to that is found in the MOH report that was published this year. And the answer in that report puts the suicide at about 6.5 suicide cases per 100,000 capita. And it has been going down from 2014 up to about 6 per 100,000 capita in 2020. Now, this may seem a little bit excessive or maybe too much. However, it's actually 30 to 40% of the international rate of suicide that you find in the West. For example, in the US, you have a rate of about 10 to 17 per 100,000 capita. In the European Union, you have the range is about 9 to 14, and of course, this is not age adjusted. Even though it's not really a big of a problem as much as we have it in the West, it still poses a burden on our healthcare. And you've all seen these people. They come into the ER, they have emotional distress, they are begging you for help, they think that ending their life is the answer, and they're asking you to give them something to change those thoughts, that voice that's telling them to end their life. And of course, what do we do, or what have we been doing in the past? Some receive some sedation, some receive some mood-enhancing drugs, and finally, our definitive management consists of picking up the phone, calling the psychiatrist, and admitting these people for in-hospital management. And the idea today is, when did we really think that, sorry. خلاص? Thank you. So when did we think that ketamine had some avenue in the treatment of depression or in the treatment of psychiatric patients? And the first study that actually showed that came out in the year 2000. Now, granted, it wasn't a grand study, it wasn't something big, it came out of Yale University, 9 patients that ended up being 8 patients. And simply what they did was they gave them a placebo infusion and calculated their depression score, and then in a crossover fashion, everybody received ketamine at 0.5 milligram per kg as an IV infusion, and they looked at their scores 3 days later. Now, even though they didn't actually assign an output point or an endpoint for this study, it was kind of small, but it kind of gave us the idea that ketamine may be used in these people. Now, over the last 20 some odd years, studies have been popping up where ketamine has been used for multiple psychiatric patients and multiple psychiatric disorders, but they were kind of small. There were a lot of them, so I didn't include them here for the sake of time. They were kind of dubious. Some of them were methodologically challenged. Some of them didn't have controls. But I sort of scanned the literature and checked which ones did have some good numbers, and I brought them here. And I did include some of the meta-analysis that encompassed some of these smaller studies along the way. So the first study, and the question that we're really asking is, does ketamine actually have some benefit in the treatment of suicidality, at least in the short term? And the first study that actually I want to talk about is something that came out in 2018, single center, came out of Colombia. Here they actually looked at 80 subjects, and this is midazolam versus ketamine head-to-head comparison. So the first group got ketamine infusion at 0.5 per kg at presentation, and the other group, or the control group, got midazolam. And what they did was they calculated the suicidality scale index at 4 hours, and then later at 24 hours. And they did that also every other week for 6 weeks. And lo and behold, the outcome actually was in the favor of ketamine. The ketamine group had a lower suicidal scale than the placebo group by at least 5 points. But the interesting thing is, in the secondary analysis where they actually looked at how much of a reduction that these people had. The ketamine group in 55% had more than half the scale reduced. And they calculated an NNT of 4, a number needed to treat of 4 people. This is just as good as aspirin in ACS. So this is really something. And of course, they concluded that ketamine had an avenue and a benefit in the treatment of acute suicidality. And you can see here in the first couple of points where it's day 1, the ketamine group was way, way better than the midaz group. And that reduction in the suicide scale score continued all the way up to week 6. And the graph in the orange, this is the non-remitters in the midaz group. The midaz group was 40, 34 of them didn't respond to midazolam, and therefore they received an open ketamine infusion, and again, the same effect had gone on, and this has been carried off to 6 weeks. Also, faithful to the first study that was done in the year 2000, the depression score actually went down. Not as much as the suicide scores, but still it went down then presentation and carried over to 6 weeks. Single infusion, really good at 0.5 milligram per kg. This is a meta-analysis also from 2018. It's 10 studies where they looked at ketamine, same infusion, 0.5 milligram per kg, versus either placebo or midazolam. And in every single case, ketamine beat the pants off the control group. So what they found was that in 167 patients pooled, of course, this was the clinician administrated measures. So this is what the physicians thought. The people in the green were the people who received ketamine versus the orange, which was either placebo or midazolam. And even in the self-reported measures, the survey that the patients took, they reported that they were feeling better. This is also seen in the timing. So you can see that by day 1, ketamine was way superior, and it carried over to day 7. Probably if they followed the patients up in those studies up to week 6, probably we would have seen the same thing. However, you can see how this is better. This is the study I'm really excited about because it touches on the ED. This study was done in the BMJ in 2021, and what they did was they took 156 patients. These were all volunteer patients. They came to the ER of their own accord saying that they had suicidal ideation. They didn't include people who had substance abuse. They didn't include people who were suffering from thought disorders, so no schizophrenia, okay? They only included major depressive disorders and bipolar and others, so OCD with suicidal ideation or what have you, and they were randomized to getting 2 infusions, one at presentation and one at 24 hours after presentation. And they checked the suicidal scales at 0 time, 2 hours, 4 hours, 24 hours, 48 and 72 hours. And their endpoint was a suicidal scale that was less than 3. Not a reduction of half, less than 3. So no suicide for them. And the outcome was fantastic, really. 63% in the ketamine group reached that endpoint versus the placebo, which was 31% with a significant p-value. And you can see here, and this is really what's so exciting. Look at how quick that first infusion worked. Within 2 hours, they've already reached resolvement of their suicidal thoughts, and that carried over all the way to 24 hours. They went from 0 remission all the way up to about 40-45%, and then when they received the next infusion at 24 hours, that went up to about 64%. Really amazing. This stuff works like lightning. It's really quick, and relative to its previous studies, it's still holding the tendency that they received the infusion at presentation and then at 24 hours, and that effect continued all the way to week 6. Now, granted, in that graph, the p-value wasn't significant, but probably if this was done on a bigger sample, it would have reached significance. But you can see how this actually helps us. Maybe later on, when a better study comes along, we can actually give the patient an hour of ketamine infusion, observe them for a couple of hours, and then discharge them. And I don't have to admit these people. And this is what's so great about this study. Intranasal ketamine, or S-ketamine. In 2019, the FDA approved the intranasal use of ketamine for major depressive disorder, and this is the form. Now, mind you, even though it was actually created in a spray form, this is not something that you can get at your local pharmacy. طيب حتروحوا النهدي ما حتلاقوها. You can't get, a pack of 12, go home and just dose up. It's actually only authorized to be in hospitals and clinics and basically medical facilities. The thing is that for those of you who don't know what S-ketamine is, ketamine and every other compound in the world comes in isomers. They are mirror images in enantiomers. So there's a left mirror image and a right mirror image. Now the first one on top of the screen, this is ketamine. And usually the convention is that if you have the left enantiomer, you write an S. And if you have the right enantiomer, you write a D or an R. So on the top, you have ketamine. So the left enantiomer of ketamine is S-ketamine. And on the bottom, just for comparison, I put for you the structure of omeprazole. So here you have S-ketamine, and this is S-omeprazole, Nexium. Nexium is just the left enantiomer of omeprazole. It's exactly the same as omeprazole. The only thing is it costs about 10 times as more. So you can see where this comes from. So in this study that was basically in 2018, this is before the FDA approval. It was being used in the approval. So here, the intranasal ketamine has been used in a research capability where they looked at 66 participants with major depressive disorder and suicide ideas and thoughts, and they gave them basically a schedule of 3 weeks of intranasal ketamine twice weekly, plus the usual psychiatric care, which included mood enhancers and antipsychotic medication. So they were all admitted. And again, the primary outcome, because they were still trying to approve ketamine for major depressive disorder rather than suicidality, the primary endpoint in this study was the depression scale. Did this nasal administration of the initial dose at 4 hours reduce the depression scale? As a secondary outcome, they looked at the suicide ideation. Okay? And what they found was that the score in the depression of these patients went down from 13.4 to 9.1 with a significant p-value in the intranasal ketamine group. So you can see here that the depression actually went down by 4 hours, again, very quick, and again at 24 hours. And as they finished all the scheduled doses, this effect lasted all the way up to day 25. They were admitted, obviously, because this was still under investigation. But you can see here in the first bar graph, the first 2 columns, the red in the first 2 columns, which is about a quarter to a third of each group, the red is the patient saying, I really want to kill myself, I'm thinking of a plan, or I have a plan, and the blue, which is about 69 and 74%, this is where probably I'm better off dead. Maybe I should think of suicide. So you can see that the majority of those people were actually thinking, and a third to a quarter of them had a plan. And after the 25 days, you can see that the majority are actually enjoying life, which is really great, just simply by a few sprays up the nose scheduled over 3 weeks. On the other graph, you can see the necessity for admission. So the red is basically high risk, requires inpatient intervention. Almost all of them, 100% and 97%. And that went down to 9%. 90% of these people still needed inpatient admission. Really good. And it does have potential. After the approval of intranasal ketamine, the ASPIRE trial came up. And of course, the problem with this trial is that all subjects were actually employees in the actual company. Now, I don't know what it says when you have a company that has 226 people with major depression and suicide ideation. I don't know if you want to work for a company that looks like that, but this is what they did. And they gave the intranasal ketamine basically at a similar schedule to the one done in the 2018 study. And again, they showed that their depression scores were actually getting better, even though the secondary measure of suicidality at 24 hours didn't show any benefit. But you can see here that it was trending towards the ketamine side, even though the confidence interval was crossing the line, so it wasn't definitive by any means. And the fact that it was all made of company employees is a kind of big red flag here. But you can see that the trend that we've been seeing throughout these studies is holding. A meta-analysis of the intranasal ketamine and the IV ketamine that was given to patients. This came up in 2021. And you can see here in a pooled patient number of 197, there was some moderate to high heterogeneity, but usually what we can see across the board that the IV ketamine and the intranasal ketamine was favorable to actually reducing the depression symptoms and the suicide ideation of these people. So it's coming up all over the place. Now, a lot of people are thinking, well, what about how good is this? Of course, during 2019, what happened with the approval of the drug popped up the clinics. And as usual, the best way to market is directly to the consumer. So you had all these ads coming up telling people that if you're suffering from PSD, if you're suffering from major depression disorder, OCD, whatever you have, come to us, we'll give you some ketamine infusion, and this is going to enhance your brain communication. It's going to ramp up your immunity. It's going to remove your renal calculi. It's going to remove your PE, your osteoarthritis. And, by the way, residents, it will help you pass your boards. So come and get your infusion, okay? And this was popping up all over the place, to the point where actually this guy, Samuel Coe, he's an MD, he actually wrote an article on how to start your ketamine clinic. And of course, being the very curious guy that I am, I actually emailed him. And I told him that I wanted to start my own clinic. And this is what he emailed me, a startup kit. So this is what you need to do to start. Abu Sara, إذا حتفتح أنا معك. يعني toxicologist, he can get the drugs. Okay? وعبد العزيز is a transport expert. He can, transport the drugs. So all you need is a business plan, create your business name, obtain your area and register and get your staff, And you can really cash out on this. Now, just in closing, so that I don't take up too much time and we are on schedule, the final meta-analysis that I wanted you to see was what happens to those patients that present to the ED in a non-psychiatric hospital. They receive whatever it is that they receive, and then they go out. Do they actually go on to complete their suicide or not? So in a meta-analysis of 115 papers with almost 250,000 subjects, 3,743 suicides were completed. This amounts to about 0.5 to 1% of all these people. So presenting to a non-psychiatric hospital and just receiving ER management has quite a bit of a downside. So in summary, even though we haven't really shown definitive benefits for ketamine, we all have used it. And when you're using it in dissociative doses, 0.2, 0.5 per kg, we know that it's safe. We know that the side effects are nothing really to think about. So if you are working in a hospital with no psychiatric support or no psychiatric inpatient, try to give ketamine. Even though it hasn't been proven conclusively, it's definitely better than what's happening right now, where the patients are actually getting out of the ER and going on to complete their suicide in 1% of cases. Okay, we do really need some good, robust research. So anybody who's thinking of, taking up this study, this is a good avenue for research, whether it's intranasal, or if you want to do it as an infusion, or if you want to take the IV and just use the mass device and sort of atomize it into the nasal cavity, that could work too. So this is some really fertile soil for research, and I hope that you have enjoyed my talk, and I would like to thank you for allowing me this opportunity to talk to you today. وآخر القول الحمد لله رب العالمين. Thank you so much.
Thank you Anas. I think بقول بعد ما اخلي شيء في خاطرك اليوم يعني ازبرازول والشخص هذا اللي يروج كل الاشياء اللي في خاطرك طلعتها اليوم. If you have any question to Dr. Anas, عمار أو موسى.
I should have known.
Actually, thank you for the excellent lecture. It feels like I got a squirt of ketamine after this lecture, which
Great.
is an amazing feeling. And I think your lecture should be classified as controlled because it's like so amazing. Thank you very much.
Thank you so much.
My question is about, did you, because I was high, I wasn't actually focusing, are you talking about suicidality, suicidal ideation, suicidal gesture, or major depression? And is there any rebound depression after the 25 days mark? Are we talking about like a rebound or a significant suicidal ideation or depression after a certain point? Question number one. Number two, is there any increased rate of addiction and use of other substance? For example, if you are going to use ketamine at some point and then you enjoy the feeling of that ketamine, are you at risk for the use of other drugs, cocaine or any other medication that could give you the same high? Thanks.
Thank you for your questions. First of all, the idea of whether or not this is a lasting effect, obviously, one squirt of ketamine into the patient's nose or a 40-minute infusion is not going to cure that patient of their depression. That is still there, or of their bipolar disorder. that is still there. The idea is it's to alleviate the suicidal thoughts, the suicidal ideation. These were people in the studies that had plans. Yes, they were not the people that were using substance abuse. That was in the exclusion criteria, so that still needs to be studied, okay? They were not the people that were brought in by EMS because of agitation or because their family members caught them in the act and they stopped them. So these weren't included in this. And probably, yes, we should be looking at these populations later on to decide whether or not there might be a subset that would fall out of this use of the drug. However, the idea was that since it reduces depression, and it is depression that's causing these people to go all the way to suicidal ideation, and therefore by, you know, hitting two birds with one stone, you improve their depression, and therefore, as a consequence, their suicide thoughts go away because their depression has been at least temporarily put on hold or improved. So that's, you know, they're not suicidal gestures. These are people who you leave them, they will end their life. So they're the real deal. As far as addiction is concerned, there hasn't been a study to look at that. If I give 8 doses of ketamine over 4 weeks, do I get addicted? Unknown, really. The ketamine clinics are sprouting up all over the place. I'm sure there's nothing really to regulate them. So you can make an appointment today and get an infusion today, and probably another appointment tomorrow and get another infusion tomorrow. I don't know if they're actually, you know, limiting this or not. Probably that needs regulation, I'm sure. But the idea is we're trying to solve one issue. Yes, we don't want to spill over to another issue. I don't want to make addicts of these people. But I'm sure that, you know, if it doesn't get regulated, that's probably where we're heading. Like any drug, it could be abused. Okay? But the idea is that at least for the short term of up to 6 weeks, you can be sure that these people are going to be, you know, whatever improvement that they received in the ER, and at 4 hours, that's going to continue at least for 3 weeks, if not 6 weeks, according to what has been seen. Is it definitive? No, we need more studies. Do you need to do it on a bigger scale? Yes. Do you need to do it on a bigger, an even bigger scale to look at the addiction index of these people? Yes. So, you know, it's still, as I said, it's a fertile soil for research. So, who knows? I hope I've answered your question. Any other questions?
Musa Fefi.
Thank you so much, Anas. Really great presentation.
Thank you.
Appreciating a lot, and happy to have new medication for depression and suicidal attempt, because it's one of the problems that we are facing frequently in emergency. So, but talking about the ketamine in easily way, it's not easy actually, because as you mentioned that we don't have so far any data regarding the addiction. Unfortunately, we start to see it. As emergency and toxicology consultant, we start to receive a call that you have one patient, he ingests, they name it, street name is Banj al-Hisan, or horse anesthesia. This is the street name of it. And the patient came within combative and very bad shape. Some of them came naked. So we don't want to repeat ourselves and the mistake of Lyrica, when Lyrica was opened for neuropathic pain, and now is considered the commonest, I can consider from the calls, one of the commonest drug addiction in Saudi Arabia. After, I can name it, it's non-responsible medical use, actually. Still the efficacy, as you mentioned in one study, it's showed there is acute benefit and acute in short term in 24 hours, but the same studies didn't show that there is 6-month benefit with the p-value 0.7. So the suicidal patient by default would need to be admitted and start the management either antipsychotic or SSRIs or whatsoever by psychiatry. I don't know how starting the ketamine from emergency and acute will help to decrease suicidal in long-term run. Adding to that the risk of addiction that still we are not sure about. So I think we can take it, but with the cautious. We should not be in a hurry to implement clinics and start to open it and start to be like drug that's because you know the people now they are looking for hydrocarbons to get high. Hydrocarbons, who think to use hydrocarbons. How come when they're using ketamine, which is known have a euphoric effect that everybody know it? Thank you so much.
I completely agree with you. And I'm not advocating to give this to everybody who has anxiety or OCD. This is what the clinics are doing, which is completely wrong. And I do believe that if they continue this way, whatever you just said is going to absolutely happen. Okay. As far as the ER is concerned, we're talking about the patient who's coming with an idea to end his life, and I don't have psychiatric support. I don't have psychiatric service in my hospital. Okay. And this guy's sitting in a bed in front of me, and all I had to do before was give him some Halodol, maybe some Midaz, if I have some olanzapine, and definitely Dr. Amru had a lecture on the first day talking about using ketamine as an analgesic, and he rightfully put, ketamine is one of these drugs where you can take it anywhere. You can take it orally, rectally, topically, nasally, IM, IV, subcut, whatever it is, it'll have this effect. So yes, it is extremely diverse. We're not saying give them ketamine pills. We're not saying, you know, use it for every time this patient says, oh, I feel a little bit down, or I feel a little bit tired. We're talking about suicidal ideation. And it should remain that way until we do have some numbers on the 6 months addiction, the potential. And again, it's not my job to cure them from their depression. That's the psychiatrist's job. My job is that they don't kill themselves until they see someone. Whether I can do that in my ER if I have services and I can call the psychiatrist and they will come and get them. In my hospital, for example, I don't have psychiatric admission. I have psychiatric service, but that patient has to remain for a good probably 24 hours or 48 hours until he can be moved into a psychiatric hospital. So this is a burden on my ER. If I can get this patient into a place, I'm not saying discharge him because I don't have that yet. It's going there, but till now, I cannot discharge these patients. If something happens, I'm liable, and I don't have the data to back it up. But if research comes out and we can prove that, you know, you take one dose, at least you're safe until they see you a couple of days later in the OPD, or you can check yourself into your psychiatric hospital, which lies probably in the next city or so. That's fine. Maybe that's the avenue. So this is what we're talking about. Of course, I brought the ketamine clinic in as a joke, but this is what's happening in the US. They're cashing in on everything. And of course, they're using it off-label. Nobody said ketamine will work in OCD, but it's there. It's in the advertisement. If you have, post-traumatic stress, if you have OCD, probably if you have, de Quervain syndrome or whatever, it will help. So,
Anas, I hate to stop you with ketamine.
Thank you so much.
Thank you very much. Thank you very much for ما في وقت تعدينا الوقت آسف تقدر تسأل أنس later on. Thank you everyone for the presentation. I think we have another one starting now. If you allow me to give Dr. Safinaz her token with Dr. Anas. We need to take a picture here. And Doctor? and Dr. Abdo.
هذا برضو المايك. السلام عليكم. Just I need your attention. The competition teams, they should show up on the stage. Now, كل teams, coach, they're gonna sit on the front. Their coaches, they're gonna be on the front. يلا, who gonna catch the first class and the business class? Yeah, the coaches, they're gonna be here on the first. 4 coaches. Yeah. Rowan, you're gonna switch with Rowan. Someone. زياد. Teamكم. يلا, let's hurry. Let's be in hurry. Yeah? التيم الرابع. يلا, باقي. Can we have a seat? يلا guys. يلا our volunteers. Let's hurry up عشان to catch the break time. Yeah. واحد هنا. Yeah. الصوت.
احنا ما ندري. تشرح لنا شوية عن
Yeah. We're gonna announce it. عادي, the coaches they're gonna come with one question. يلا, can we have a seat? ايوه. يا الا حط واحد هنا. close the mic. قفل المايك قبل ما نبدا. يلا عبدو for a second time. Ladies and gentlemen, welcome on SASM contest 2023. Just I'm gonna do just a quick introduction about SASM contest to the people, to let the people that they are not aware about SASM contest. It's a lot of fun, a lot of enjoyable moments. I'm gonna clarify just the rules for the audience. majority of the teams, they are aware about the rules. They saw it either last year, or they are aware about it. I just approached them. We have 7 sections, which is like a cardiology, trauma, pediatric, anatomy and gynae, toxicology, a lot of sections. In every section that we have 4 categories, ranging from 200, 400, 600, 800, and 1,000. Depending on what? The ranging depends on what? Depends on difficulty of the cases. If you're gonna jump, I know all of us, we're gonna jump to 1,000 immediately. You're gonna have a trap there. Please do not put yourself in a difficult situation and choose the most easiest questions. There is a timer. There is no judge. I'm not judging anything. For that, I program it to make a judger for us. I'm not biased to Kuwait or Jeddah team or Western area or Riyadh team or whatever team. I'm not calling by the regions. I'm not biased to anyone. There is 4 assistance tool. Ask for help. They can ask their coaches, and they are sitting here just for one time. They can ask them. And there is another assistance tool which is changing the question. If you're gonna change the question, you cannot jump to other questions. You're gonna choose the same category. The third one is doubling the credit. If you're gonna play it like a gambling and you're gonna double it, you're gonna win. And there is the 4th choice, which is delete 2 answers. Okay? And every time you're gonna use KBM. Every time that you're gonna use the assistance tool, the timer is gonna stop. 30 seconds. Yes, 30 seconds. And if you're gonna choose, like an example, 1,000 credit question, every second it's gonna be deleted 60 credit. If you're gonna choose 200 section, every second at least 6 credit. If you maximize the number, you're gonna lose more every second. The timer is gonna be stopped if you are using the assistance tool, but for 1 minute. If they are not, I'm gonna tell the control to submit it, and it's gonna be 0 credit. There's 1 minute if you're gonna use the assistance tool. Okay? Number of questions. It's gonna be just 7 rounds. 7 rounds. For that, choose whatever you're gonna do. Just 7 rounds to catch up with the break. If you want us to play, we can play. The program is gonna continue until night. But just 7 rounds. Okay? Just to declare that, we don't have a sponsor. We just for this competition, we are welcoming the sponsor for the next versions or any time. We just catch some gifts or prizes for the. I fight for them. I make a competition between the companies. I said to them, you have 1 hour. Whatever you're gonna bring, we're gonna announce it as a prize, and they compete. And we have 5 airboats for every team member, 1, and for the coach. And we have also a sponsorship for BOCUS training program for 1 year. Every team member, he's gonna utilize it. Okay? What we have been dealing, the airboats for the first team, the winner team, they're gonna choose the airboats. It's up to them. The second team, they're gonna be 2 of them. They're gonna utilize the BOCUS training sponsorship for 1 year. The third and fourth, I will not forget you guys, 1 seat for BOCUS. Okay? Everything is clear? If you have any question, do not ask me, ask the program. Just one thing I want to thank Dr. Ali Sheri, he supported me. I have been doing this last year for 4 months. This year I work on myself to be 1 month and a half or 2 months. Dr. Ali Shehri, he's emergency consultant. He assists me to risks, to score, and to make this game is easy. Everything is clear? No argument, no negotiation. Your negotiation is going to start it with the time. Yalla Muhammad, let's control, let's compete. Just before the competing, I didn't introduce the teams. Sorry for that. I'm so excited. You have the mic? Borduga team. We're going to start by Borduga team. It's so funny name for me. Let's start by the team leader. Announce just quick your name and your role in the, yeah.
My name is Ghad Al Jabri, ER resident. I'm the team leader.
إراد الغامدي ER. لميس سعداوي.
نضال بخاري.
يلا تحية لبوردقة تيم بليز. حمل اللقب الشباب المشرقية. This is not الشرقية. يلا. سوبر ماريو تيم.
So Super Mario team. I'm Aqil Ibrahim, R4 team leader.
Perfect.
حسن الشقاق emergency medicine resident R1.
Welcome.
عبد الرحمن بحجي R1
بثينة القرني medical intern.
يا سلام تسمعون أحسن تحية للانترنز. This year we just opened the. We want to have more and more. We announced almost 2 months. We didn't catch up with this team unless almost 1 hour before. KBM, you have the mic.
Jinan Salmin, R4 ER resident, team leader.
مآثر الزيد emergency medicine R2.
عبد العزيز زيد emergency medicine assistant.
Welcome.
عبد الرحمن السلمي انتر.
Welcome. Welcome. You have the mic? I just tell them that they can name their teams, adrenaline, ketamine, succinylcholine, chromium, whatever they want, to not make it bias. The moment that we are starting for it, it's gonna be started by Borduga. Borduga.
Can we introduce ourselves, please?
نسيت حقكم عليه. وأيمن موجود بينكم. أنا آسف والله حقكم عليه. يلا.
زياد الحسين R3 adult emergency and team leader.
5 مليون نعم.
علي ريو R2 من العسكري.
Welcome.
أيمن الغزي emergency medicine R1.
Welcome.
سوسن العمري intern.
يا سلام يا سلام يا سلام يا سلام. I run a test for the program every now and then. I didn't run a test today for the Khwana من الكويت. I didn't put them in the program, they just join us. Always when I'm running the program, there's some winner. And always the winner, it will not be the actual winner. I will not say the winner, that in the program, because I'm actually running it just to test the program. Yalla Borduga team, let's start. You can choose the section. عبد الله نحتاجك. واحد بس to mobilize the mic. Borduga team, then Super Mario. You can choose resuscitation, cardiology, tox, pediatric, trauma, procedure, neurology. And then you're going to choose. Be clear. The control, he's going to hear you. I'm going to announce it again to close the loop. This is what we have been doing. Yalla. Mike. Mike. عبد الله خلينا نسرع العملية عشان البريك. يلا. خلوا عندكم لو في شيء تودوا اللي بعدكم. يلا.
Resuscitation.
Resuscitation. We have 5 questions.
1000.
Oh. على بالكبير. 1000 control. Okay. Yalla, I'm gonna read that. There's a gift question, by the way. Do not be surprised. And it's from the program. I'm gonna read the questions. After that, I'm going to play the timer. When using POCUS during CPR, which of the following should be done exclusively during a pulse check and cannot be done while CPR is going on? Checking for AAA, checking for pericardial fluid, checking for RV strain, checking for IVC. Timer. Timer.
RV strain.
RV strain. 3. Are you sure?
Sure.
100%?
200.
There's no getting back. Go control with the number 3. Perfect. Super Mario team. Choose whatever you want. يلا اختار.
Recess 400.
Recess. I'm gonna listen for them team leader, please, ها؟ اللي هو senior, please. عشان to make it clear, عشان ما يصير في احتجاج بعدين.
Recess 800.
Recess 800. Okay. يلا go with the recess. When is the correct time to deliver inotropic medication in pediatric septic shock? If there are no signs of improvement after the first fluid bolus has been administered. Once central line is in place. If there are no signs of improvement within 1 hour of aggressive fluid resuscitation. If there are no signs of improvement after 40 cc per kg of normal saline within the first hour. Timer.
The answer is choice number 1.
1. Sure?
بإذن الله.
Play 1. محمد. Uh-oh. يلا next. KBM. You have the mic. You can choose. هبرة كبيرة 1000. تبغوا 200. It's up to you.
Cardiology 600.
Cardiology 600. By the way, no one using the assistance tool. Okay? 14 years old male was sent to the ED by his family physician after loss of consciousness. Upon receiving an immunization, his mother with him and witnessed the event. She described a brief loss of consciousness, approximately of 20 seconds. He returned to baseline level of alertness within 1 minute. Just prior to the loss of consciousness, he told his mother he felt unwell and looked pale and diaphoretic. In the ED, he had normal neurological and cardiac exam. He has no family history of sudden cardiac death. This is the first episode of syncope, which investigation are appropriate at this time. CBC, chemistry, extended electrolytes, ECG, CBC and chemistry only, ECG only, no investigation are required. Timer. 3. 3. Blade, again, immediately, no getting back, no regret. Fourth team, adrenaline. يلا, والله you bumped a lot of adrenaline on me. Mike. No, Mike, it's not working. أبغى صوتك أعلى.
So we will go for trauma 600.
Trauma 600. No getting back, guys, for the answers and for the section. 28 years old man present after roll-off or motor vehicle collision where he was restrained driver. His Glasgow scale 15 on arrival and fighter sign heart rate 120, blood pressure 140 over 90, 20, RR, SpO2 98 on room air. He appears intoxicated but is speaking in full sentences. The patient complains of significant pain to his left leg. An examination is notable for edema and hematoma to the left knee. These pulses are diminished and X-ray is notable for type 2 lateral displaced tibial plateau fractures and femoral condyle fractures. What is the most appropriate next step in the management of this patient? CT angiography for left lower extremity, duplex ultrasound and ankle brachial index, orthopedic consultation for open reduction, internal fixation. The fourth, vascular surgery consultation. Timer.
So we will go for 2.
2. يلا next. We will not stop. Borduga.
Trauma 1000.
Trauma 1000. مخاطرين انتم والله. مرة مخاطرين. 36 years old patient who is obese arrives in backboard and full spinal immobilization after high-speed motor vehicle collision. She has no neurological function below level of C5. In addition, initial films also show chance fracture of T12. How fast can problematic pressure source develop in a paralyzed patient on backboard as they proceed through their initial workup? 2 hours, 90 minutes, 30 minutes, 1 hour. Timer.
Remove to answer assistant tool.
Assistant tool remove to answer, which is yes. Okay, they have 1 minute. Control, count.
minutes.
30 minutes. Okay. Jump. Next. سوبر ماريو.
كارديولوجي 1000.
يا سلام، العب الكبير من زمان اقول لك.
نبي نلحق
العب ايه. 69 years old woman present with worsening fever and shortness of breath for 3 weeks. She was treated by her regular doctor with azithromycin last week, but reports no relief. On exam, she has bibasilar crackles, S4, and for systolic murmur, jugular venous distension to 6 cm at GFD, and 3 plus pitting pedal edema, labs BMB 1429, sodium 129, WBC 8.3, hematocrit 13%, vital sign 105, pulse, blood pressure 90/65, RR 24, temperature 39.2. The most important consultant to contact is infectious disease, intensive care unit, cardiothoracic surgery, cardiology. Timer.
احذف اجابتين يا
احذف اجابتين.
وقف التايمر. راح علينا 3 seconds.
Timer should be played. Control 1 minute عشان الشباب يلحقوا على البريك حق الغداء.
We'll go with answer number 3.
3 1. يا سلام يا سلام. لعيب. يلا KBM. You can choose.
كارديو 800.
كارديو 800. "37 years old woman present to the ED with 1 week history of pleuritic central chest pain that radiates between scapula. She is now feeling dyspneic with exertion. Which of the following statements describe the role of point of care ultrasound in her management? Presence of B-line is diagnostic for congestive heart failure. Presence of pericardial effusion confirm the diagnosis of pericarditis. Absence of pericardial effusion rule out pericarditis. Large effusion with right atrium or right ventricle collapse suggests cardiac component. Timer.
And we want to double the question.
double the question. No, you're gonna double the question and you're gonna answer. Every time you're gonna use assistance tool, it should be followed by timer. The timer is gonna play, and the assistance tool after that you're gonna choose it. Then you can answer. Yeah. ده عشان بس to clarify for them. 4. يلا بريس محمد. Thank you. Adrenaline. Adrenaline.
So we will go for toxicology 800.
يا سلام يا سلام. Toxicology 800. 24 years old male of 70 kg weight took a large dose of acetaminophen in an intention to commit suicide. He took 80 tablets of 500 milligram tablets of acetaminophen in one-time dose. He was brought to the ED 3 hours post-ingestion and had an altered level of consciousness. His initial blood workup drawn at presentation showed acetaminophen level of 600 micromole. Lactate of 9. How would you manage this patient? Give NAC, arrange for dialysis but avoid charcoal. Give NAC, avoid charcoal or dialysis. Give NAC, charcoal and arrange for dialysis. Give NAC, charcoal but avoid dialysis. Timer.
We'll use erase 2 answers.
يا سلام. Go. يلا. Be quick to enjoy the competition.
لا charcoal.
Timer. You control. 1 minute.
1. So 1. Our answer is 1.
Your answer? 1. Okay. Please, we're going to do the same. بنحيي اللي بي toxicologist. We're going to review it together. Do not ask me. Ask the program. And we're going to review it together. Every time there is a negotiation. This is the wrong answer. This is... All of them is references. Yeah. يلا. بوردقة. لعيبة. أرضهم جمهورهم. يلا.
Resuscitation.
Resuscitation. باقي 3 questions.
600.
600. يا سلام. There's another gift question. قلت لكم. Program he gonna choose. Another gift question. ممكن يكون next question. يلا بعده. سوبر ماريو. جاب الجمهور وجاب الرابطة الشباب. يلا. سوبر ماريو.
باقي تروما 1000 ولا؟
تروما we cannot judge. بس في 3 questions. في procedure، في neurology، في pediatric، وترى أشياء حلوة.
باقي تروما 1000 في ولا؟
ما أتوقع أخذوها الشباب. It's a luck. محمد إيش يقول دكتور عماد؟ Let's test our luck. Test your luck if you want. وعندك pediatric full house, neurology full house, procedure full house.
نبغى تروما يا دكتور عبد.
You're gonna choose. Then what's the empty slot you're gonna choose?
إيه تروما 1000 إذا في تروما 1000 نبغى.
يمكن ما يطلع.
يلا تروما.
ها؟ على حسب حظك يطلع 200.
مو مشكلة.
يلا تروما ونشوف ايش يطلع حظهم.
يلا 800.
800. يا سلام. It's not a knowledge, just to stress on this point. It's a luck. If you're gonna play it, there's no knowledge. يلا يا ادرينالين. والله كانت ودي انه تجيكم جائزة بأي طريقة. KBM. ليش انساكم؟ معلش. هو البروجرام for that do not ask me. البروجرام بيورينا. يلا KBM.
KBM Pediatrics 1000.
يا سلام يا سلام. Pediatric 1000. Okay, a 6-week-old female is brought to the ED by her parents for excessive crying. They also note that with crying, she has flushed face and tense abdomen. Her parents think that her crying is secondary to an intestinal colic. What is the definition of colic? Paroxysm of crying for at least 30 minutes occurring at least 5 times in 24 hours period. Paroxysm of crying for at least 3 hours per day for at least 3 days per week over 3-week period. continuous crying for at least 7 hours per day or for 1 week period, continuous crying
2
for at least 2 days per week or
2
for... Yeah, play timer وthen play so. 2 That's it. يلا. يا سلام يا سلام يا سلام. You can stress on your point, but the timer should be played. خلاص. يا أحب فهد ودكتور ثامر. أحبهم عشان ذا الشيء. We are sharing the same interest. إيه رابطة كلنا رابطة. يلا دناني.
طيب.
أضرب 1000 في طريقة.
بروسيجر 1000.
بروسيجر 1000 ممكن يطلع فيها صورة. ها خلاص الصورة راح تشتغل. فيها صورة. 17 years old male football player received 3 doses of IV morphine while awaiting the reduction of his anterior shoulder dislocation. After 2 unsuccessful reduction attempts, you decide to administer IV propofol in the following capnograph curves. The axis is time second, and the x-axis is time seconds, and y-axis is entitled CO2. Which curve illustrates the most likely respiratory complication in the immediate post-reduction period? حط لي الصورة. لما تقولوا دقيقة بقى control. When you get done with the picture, we're gonna read the answers وبعدها the timer is gonna be played. في B و C و D و E. خذوا وقتكم بس مو وقتكم اللي بزيادة. التايمر هناك بيشتغل والكمبيوتر بيشتغل التايمر. By the way, you can bounce back to the picture again بس من التايمر. خلاص.
So we'll take opinion of our coach.
Opinion for your coach. خلاص. نقرأ الانسرز. محمد قفل. B و D و C و E بلاي تايمر والكوتش and play timer again. والله دي I will not know it. من أول نسيت الكوتش. It's so difficult. Yeah. Timer is 1 minute. Program مو أنا.
C. So we will go for C.
C. C, which is, yeah. Okay, let's go. إذا في روح رياضية فهد نشجع تيم الأدرينالين الحين نعطيهم أكبر تحية. يلا 1,000 وصلحوا. Just to let you know, I just make a decision of Dr. Ahmed Al-Rabghi to control something. عشان ما تقولوا أنا bias. خلاص? I will not let you know what is the decision. Dr. Ahmed ودكتور أمل ودكتور علي they know what is the decision. ما هو في الديتيلز وال.
Pediatric 800.
Pediatric 800. ما خليتني أشرب موية. 2 years old, previously healthy male, present to the ED with 1-day history of fever, bloody diarrhea, his temperature 38.3, heart rate 140, RR 28, blood pressure 90/60. The patient is active, alert, well hydrated, not ill appearing. Which of the following pathogens cultured only from stool would require treatment with antimicrobial in this patient? Campylobacter, Salmonella, E. coli 0157, and Shigella. Timer.
Double the question.
Double the question. دبلوا باقي دبلوا سووا اللي تبغاه. يلا.
شقلة.
شقلة. سوبر ماريو. نشرب مويه. يلا.
طيب صعبوا علينا المنافسة ما شاء الله عليهم.
لا
طيب.
لا اتس فاين.
لا لا
يو هاف ا تايم تو كومبيت.
احنا
يجيك الحين
بنفوز
سؤال
آخر شيء
ب1000.
عموما. طيب ناخذ توكسيكولوجي.
توكسيكولوجي. دقيقة محمد.
400.
ها؟
400.
كم؟ 400. 400 محمد. Which toxidrome below is likely to be caused by bath salt ingestion? Altered liver consciousness without change to vital sign, hypertension, tachycardia, hyperthermia, mydriasis, altered liver consciousness, bradycardia, vomiting, salivation, diarrhea, meiosis, diaphoresis, hypotension, bradypnea, meiosis, dry skin. Timer. يلا
نختار 2.
2. يا سلام يا سلام يا سلام يا سلام. كيف يم؟ كم الحين؟ بوردقة جوالي دق؟ جوالي يعني خليه. بوردقة 2652 كي بي ام 2086 سوبر ماريو 1959 ادري they didn't get the luck yet. يلا كي بي ام.
توكسيكولوجي 1000.
توكسيكولوجي 1000. العب على الكبير يمكن يطلع هدية. لا. 64 years old female is brought to your ED by ambulance after ingestion 5 tablets of diltiazem 240 milligram. How much activated charcoal would you give to this patient? 12 gram give activated charcoal in 10:1 ratio with the medication. 6,000 milligram give activated charcoal in 5:1 ratio with the medication. 50 gram, this is a standard dose for adult. 1,200 milligram give activated charcoal in 1:1 ratio with the medication. Timer. أسمعك.
شيل إجابتين.
دي 2 answers. Okay. Just محمد do not. عندنا 4 answers, 4 assistance tool. Delete 2 answers, double the points, and ask for help and change the answers to repeat it again a third time.
1.
يا لعيب يا لا. فهد المطوع والشباب ما شاء الله تبارك الله لعيبة. يلا يا شباب اللي بعده أدرينالين. يا رب يجيكم سؤال 1000 هدية. أعطوهم المايك وبيجيكم بإذن الله. منصور يوم دعوات الأمهات.
نيورولوجي 800.
يا سلام. نيورولوجي 800. "70 years old woman present with acute onset right side facial drop and extremity weakness. You order emergent non-contrast CT that showed an absence of hemorrhage. She has no contraindication to thrombolysis. We discussed thrombolytic therapy with the patient and her family. Which of the following is the average estimate risk from symptomatic hemorrhage after thrombolysis? 12%, 2, 8, 15. Timer. أسمع.
Double point. We'll double the point.
Double the point. Double محمد. يا سلام. جيبوها يغفر لكم ما تقدم وما تأخر.
So we'll go for 2.
2. Just to stress on this point, it's not knowledge competition, it's enjoyable, yeah, exciting. يلا بردقة. انت وحظك الحين ايش يطلع لك 200 ب 400 ب 600 جوا ما في.
طيب نيورو 1000.
1000. A 25 years old gentleman present to your AD with a seizure for 3 minutes. His glucose is 6 millimole. On arrival, he stops seizing but is still drowsy. As you are establishing IVs, he seizes again. What's your next step after his primary survey? Lorazepam, give lorazepam 2 milligram IV. Wait 5 minutes before giving lorazepam. He is not yet in status epilepticus. Give lorazepam 4 milligram IV. Give midazolam 10 milligram IV. Timer. أسمعك. "12 seconds. بسرعة. Ask for help.
Yes.
باقي 166 credit. Their coach.
Coach.
She give you the answer? She give you the answer?
طيب 2 ملغ لورازيبام 1.
Answer number 1, ها?
فور دقيقة هي قالت 4
I answered. Give 2 milligram lorazepam. سمعته بالمايك. صح, it's not my fault. Go.
يلا.
أعطهم تحية.
ان شاء الله خلاص.
يلا next.
Procedure.
Super Mario.
Procedure. 800.
ألعب يا كبير. When initiating transcutaneous cardiac pacing for conscious but hypotensive patient with a bradycardia, which of the following is true? Sedation is usually necessary to allow the patient to tolerate pacing. After initial capture, the output should be set at 25% above the minimum needed for capture. Output stimulating current should initially be set to maximum. The rate selected should be slightly above the patient's native rates. Timer.
We will ask assistance from the coach.
Ask for assistance. Timer, 1 minute.
We will go with answer number 3.
Answer number 3, Mohammed. Okay. كبيان. لعيبة ما شاء الله.
بيدياتريك 800.
بيدياتريك 800. ما في الا 600 200 400 600. ايش اللي تبغاه؟ اخوه؟ You test your luck. This is your luck. لا خلصنا. 600 يلا 600. A well appearing 22-day-old infant present to the ED with a rectal temperature of 38.2. There is no clear source of fever identified from history or examination. Investigation reveal a negative urine analysis, CRP less than 20, absolute neutrophil count less than 5. What is the most appropriate next step for this patient based on guideline? Discharge home, oral antibiotic, next day follow-up. Admit for observation, await blood cultures, consider LB. Lumbar puncture, empiric antibiotics, and admit. Discharge home if parents are reliable. Close observation, next day follow-up. Timer.
دبل 3.
Double. Just wait, Muhammad. What you want? 3. Answer number 3. Take a picture of the questions, and I'm going to give you the reference. من بعده adrenaline. Just to announce adrenaline. Just to announce عشان السنة الماضية كان في negotiation واحتجاج. After this round, just there is 2 rounds. بس دكتور أحمد الرابغي he just added 2 rounds. سمعوني تحية دكتور أحمد. Just he want us to enjoy the competition. After this, there is 2 rounds only. خلاص control. يلا adrenaline.
So we'll go for trauma.
Trauma. في 200 400 ايش اللي تبغوا اختاروا.
400.
400. 55 years old male who was brought to your ED by EMS after falling down 13 stairs. He's alert, oriented, and is complaining of chest pain. His initial vital sign 37.5 temperature, blood pressure 88/45, heart rate 123, oxygen saturation 95 on non-urethral. His initial portable chest X-ray showed left-sided pneumothorax that is 10% in size. What is your next step? Observe the patient clinically and repeat imaging in 6 hours. Insert chest tube. Need a decompression. CT chest to better measure pneumothorax timer. أسرع.
We'll go for 3.
3. 3. It's fine. سمعنا تحية للأدرينالين. This is the 3rd time that we're gonna announce 2 more rounds. 2 more rounds. This is the first round. There's another round. أرمي 1000 إذا حصلت 1000 أرمي 1000. إذا حصلت 800 باقي أرمي. يلا يا بردقة. تايم عشان الشباب يروحوا يفطروا ويتغدوا. بريك.
طيب procedure 600
بسم الله 32 years old man with a history of hydrocephalus and particular peritoneal shunt placement present to the ED with headache, progressive confusion. CT shows increased hydrocephalus from baseline. A shunt X-ray is serious, is unremarkable. Which of the following is the most accurate regarding the indicated diagnostic and therapeutic procedure? Coagulopathy is an absolute contraindication. Infection over the entry site is an absolute contraindication. Local anesthetic is required. Opening pressure measurement is rarely necessary. Play timer. Timer. 2. يا سلام يا سلام.
اعطينا نيورولوجي.
سوبر ماريو يبغى نيورولوجي ونشوف ايش موجود جوا متخبى لنا. في 200 و400 600. 600. 55 years old male is brought to the ED unresponsive. Vital sign blood pressure 220/130, heart rate 45, temperature 97, RR 12. His left pupil is 6 mm, unreactive. Which of the following is the most probable cause? Temperature is normal. Contralateral pontine lesion, ipsilateral medullary lesion, contralateral midbrain lesion, ipsilateral supratentorial mass. Timer. Timer. أرمي.
بندبل. نختار 4.
Double and 4. Ipsilateral supratentorial mass. يا سلام. محرقين الشباب شوي. يا سلام انا عارف التنس هذا البريشر هذا اللي نبغاه في الكومبيتيشن. يلا ادرينالين. يا رب سؤال هديه ادعو الامهات. يا رب سؤال هديه. كبيام انا من اول ابغى ادرينالين ابغى اجيب اي حاجه. يلا
بروسيجر.
كبيام الحين.
كارديو.
كارديو. باقي 200 و 400.
400.
400. A patient present with a history of hypertension, epigastric chest pain for 3 hours with the negative biomarkers. His ECG is normal. He responds to antacid and feel better. What is your next appropriate response? Admit for cardiac workup, prescription for the BPI, aspirin, nitroglycerin, sublingual BRN, repeat biomarkers, timer. غير السؤال. Change the question, محمد. هذا السؤال الإجابة الصحيحة عشان just to show you. They're gonna choose which of the following ECG carries the highest likelihood ratio for diagnosis of acute heart failure: left axis deviation, new TUF change, atrial fibrillation, complete normal ECG. 1 minute. أشرب موية. Huh? 2. Answer number 2. Okay. أنا أعرف الأسئلة السهلة بتجي للفريق الثاني اللي قدامك، الأسئلة الصعبة بتجيني. أدرينالين. يا الله يا رب بهدية.
Procedure.
ها؟ Procedure؟ إيش يطلع فيها إن شاء الله يطلع فيها شيء. 200 و 400.
400.
يا رب هدية يا رب روح 400. لا والله ما طلع هدية. Which of the following is the most commonly utilized vein for venipuncture? Femoral vein, external jugular vein, basilic vein, axillary vein, timer. Three. يا سلام يا سلام يا سلام يا سلام. This is the final round. This is the final round. Before we should count, Portugal's first place, KBM on the second, Saddam Saddam, Super Mario 2090, Adrenaline 280. Yalla. This is the final round. We should go.
Okay.
Time for break.
Resuscitation.
Resuscitation. There's 2 questions. 200 and 400.
400.
400. How much crystalloid should children receive in the initial management of pediatric septic shock? 30 ml per kg IV or IO bolus. Repeat twice for total of 90 ml per kg. 40 ml per kg IV or IO bolus. Repeat once for total 80 ml per kg. 20 ml per kg IV or IO bolus. Repeat twice for total 60 ml per kg. 20 ml per kg IV or IO bolus. Repeat once for total of 40 ml per kg. Timer.
Change the question.
Change the question. Control 1 minute. أنا you will not read that. تعرف عشان إيش؟ repeated question you will not read it. الفيرست question عشان نمشي بالتايمر. تبغى أقرأ. You're going active resuscitation of BA, cardiac arrest, patient with ongoing chest compression. Entitled SO2 slowly decrease from 14 to 8. The patient is intubated. What is the most appropriate next step in management? Try to improve quality of chest compression. Determine cause.
خلاص 1.
أوقف.
اي 1.
Answer number 1, control. Super Mario.
Toxicology.
Toxicology. There's 200, 600. فهد شباب دقيقة خلينا نركز. We can. يلا.
600.
600. يا سلام يا سلام. يلا. كم سوبر ماريو؟ KBM. This is your time. You can do it.
Trick.
ها؟
Pediatrics.
بيدياتريك ويطلع لنا كم ونشوف؟ بيدياتريك 200 و 400.
100 والاستعانة بصديق.
400. ها؟ طيب 11 years old male broke a mercury containing thermometer in his mouth and swallowed all of the mercury. He's currently asymptomatic. What is the appropriate next step? Preparation for intubation for impending pneumonitis, reassurance and follow up with his pediatrician, admission for IV fluid titrating to maintain the urine output, charcoal administration if the incident occurred within the past hour. Timer and ask for help. Ask for help. كم؟ لا انت اللي تبغوه. الكوتش just to assist you. الديسيجن حقك. 4. Answer number 4. كم دقيقة؟ You cannot change. I'm gonna receive from you. ها؟ كم؟ كم؟ أنا أسمعك هنا.
لحظة شوي ما يخالف. لحظة دكتور علي.
التايمر ها؟ كم باقي معنا؟ ها؟ Final answer قدام الناس.
2.
2.
عادي.
2. يا سلام يا سلام يا سلام. ادرينالين. باقي question في كل مكان الا نيورولوجي 2. نيورولوجي في عندنا 2 question في 200 400. 400. A 39 years old, previously healthy woman present with a progressive traumatic back pain and leg weakness over the last 3 days. There is no history of fever or IV drug use. MRI of her spine reveals enhancement of the cord at T11 and L3 with increased T2 signal. There is no central or canal stenosis, mass lesion or fracture, and the appearance of vertebrae and disc is unremarkable. Which of the following is the most appropriate management strategy? Radiation therapy, operative spinal decompression, corticosteroids, IV antibiotic. Time.
Change the question.
Change the question. Corticosteroids. Change the question. You have your time. 1 minute. What is the proof and treatment for patients suffering from severe post-dural puncture? اللي تبغوا بسوي لكم يا أهل الرياض. حتى غششكم من تحت. حاطين على يدي عشان ما أقول كذا ولا كذا ها؟ صح؟
So, 1.
1. Okay, epidural blood batch. يا سلام يا سلام. As we said, this is the final round. The winner and the competition. And the competition, Bukhari. Bordiga is the first winner. KBM second place. أحسن تحية. Super Mario the third place. أبغى أسمع أكبر تحية للأدرينالين تيم بليز. Just small announcement. أدعو الدكتور جميل عشان يكرم الفايزين. Just small announcement. I have been sending messages for groups حقتكم resident for 2 months, and your RTB know that. I want to be more, the competition in the next year to be more and more. If you like it, I want you to be engaged more. This year we have been involved the intern. Next year inshallah students will بيكون الليفل أحسن. Thank you for everyone. الوينر بس تصور مع دكتور جميل.
السلام عليكم. This has been wonderful. I have a quick announcement. At each year of SASM, on the final day, we announce our next SASM. So it gives me a great honor and pleasure as a representative of SASM board to announce that next year SASM inshallah gonna be in the eastern region. It's gonna be on the month of April, and as usual Eastern SASM has a special taste, so looking forward to see everyone, and inshallah it's gonna be a great successful 9th scientific meeting. Thank you very much.
بس تكرم عشان الفايزين اللي هم بوردقة وشو البقية عشان first team, just to announce the prizes again. Airboats for the first place, they choose it by themselves. I let them choose. A second place, they're gonna take sponsorship for box training from شركة عبد اللطيف جميل. 2 of them. The third place, they're gonna take 1 seat. The fourth place, they're gonna take 1 seat. And by the way, شركة عبد اللطيف جميل, it's a competition. They just announced for us there's a discount for the audience on butterfly ultrasound. يلا بردقة. يلا. Before the break, we're gonna announce the winner for the oral poster, and then we're gonna go for a break. الكوتش الكوتش
الكوتش انا ليس من
يا تعال you can do. Just to دكتور عمار عنده oral دكتور عمار اسماعيل, can you join us just to announce the oral poster winners.
دحين انت رحت
طيب السلام عليكم. طيب السلام عليكم ورحمة الله وبركاته. I will be presenting the names of the winners for the abstracts. So we'll start with the poster and then followed by the oral. But before I announce the names of the winners, I would like to thank all of the people who submitted their abstracts to the committee. Actually, I have read all of them. I have actually enjoyed reading them. It was really difficult to pick and choose which one to accept for presentation. I think everybody did a good job. Each one of them that presented their paper, it was an amazing effort by them. The energy was great. I would like to say that all the posters and the oral presentations that were submitted, we actually made an agreement with Dr. Asad Shuja', who is the editor-in-chief for the Saudi Journal of Emergency Medicine, to be qualified as a publication. So all of the posters or the oral presentation that have been presented, they are eligible and qualified for publication. So we'll give you the instruction on how to submit and arrange the publication with Dr. Asad Shuja'. Of course, we had an amazing judgment team for the poster and the oral presentations. We used a very meticulous rubric system to evaluate all of the studies. And it was actually really difficult to pick and choose, but I have the names right here. Can we go ahead and announce them? Please. Okay. So instead of going backward, third place to first place, I want to go to the first place of the poster. So first place for poster number 1, going to the research title, the level of caregivers awareness in regard to ingestion household consumer products in pediatric age, a cross-sectional study. It was presented by Adoub Nasser Kadasa. Adoub, are you here? Adoub, okay. So we'll go to second place. So second place went to the research titled The Effect of Endotracheal Intubation on Outcome of COVID-19 Infected Patients. And the presenter was Bassam Turkustani. طبعا Bassam, by the way, he actually submitted so many abstracts to us, and he presented 3 posters and 1 oral presentation. We just wanted to give him 1 prize, but he deserved 7. For the third place, the research.
Any special awards for them?
Yes, so the awards for the winners, they will receive a certificate of first and second and third place. Next year, they will get a free registration with SASM. The third place is a research titled Trends that Influence Pursuing Emergency Medicine as a Career Path Among Saudi Medical Graduates in Vision 2030, and the presenter Shahad Qadi. Moving on to the oral presentation. Again, it was full of energy, full of great studies. So we'll go immediately to first place. The first place went to a research titled Characterization of Emergency Department Visits Within First Year Post-Liver Transplant. And the presenter was Jihad Al-Jum'a. Jihad, are you here? Okay. We'll go to second place. Actually, it was a tie. So we have two people in second place. The first research in the second place is going to research titled Using Machine Learning in Managing Emergency Triage Flow, presented by Mubarak Al-Khadir. طيب, so second place مكرر, titled Propofol versus Midazolam as Initial Sedation Strategy for Mechanically Ventilated Patient, a Single Center Experience from Saudi Arabia, presented by Jamil Beljoun. Third place went to a research title Comparison of Stroke Outcomes in Patient Transported by Emergency Medical Services versus Private Cars, a retrospective study presented by Afnan Al-Qahtani. أفنان موجودة؟ طيب.
طيب شاكر لكم جميعا باسمي وباسم جميع المنظمين، نشكر لكم حضوركم. حاب اوجه شكر خاص للدكتور عبدو وجميع الفولنتيرز. بالنيابه عنهم جميعا راح نكرم افضل بيست فولنتير اوف ذا كونفرنس نورة العبد الكريم، لو تجينا على المسرح. Thank you so much, guys. Lunch is waiting for you. We'll see you after lunch, inshallah. شكرا لكم.
Assalamu alaikum. Good afternoon, everyone. So we'll start our session, the afternoon session with toxicology. The first talk will be with Dr. Sheikha Al-Ahtaibi. She will talk about the street drugs in Saudi Arabia. Dr. Sheikha, she's a consultant in emergency medicine, medical toxicologist. She's currently the division head of the medical toxicology unit at King Fahd Hospital at Imam Abdurrahman bin Faisal University Hospital in Al Khabar. So let's welcome Dr. Sheikha.
Assalamu alaikum. Good afternoon, everybody. I hope you're still awake. So I tried my best to prepare a short, focused one, so you will not be bored. So I think most of you are aware about the campaign, the last campaign, اللي تبع مكافحة المخدرات. It was a large campaign, and they are focused on the crystal meth, which is shabu. Okay. This is a lot of news from their website. So the question, do we have it in Saudi Arabia? The answer is yes. And the other question, why all these large campaigns? So we will know that. So today, I will talk about the crystal meth, or the street name is shabu. Before this, let's talk about the hallucinogens. So hallucinogens is a diverse group of xenobiotic that altered and distorted the perception, thought, and mood without clouding the sensorium. One of these groups called phenylethylamine, and we have it as endogenous in our body. Example of it, the dopamine, norepinephrine, and tyrosine. And we have it as exogenous, like the amphetamine and its derivative, the methamphetamine, MDMA, and others. So just a little background. Amphetamine are derived from ephedra, which is a plant native to China and Mongolia. For centuries, many cultures have used the ephedra as a stimulant and for treating congestion and asthma because of its bronchodilator effects. So amphetamine was first synthesized in Germany, 1887. They have drugs like levoamphetamine, dextroamphetamine, and methamphetamine, and are rediscovered in the late 1920s when scientists were searching for ephedra-like drugs that could treat asthma. So its psychostimulant effect was recognized and abuse reported early in 1936. In 1932, amphetamine was marketed for asthmatic, and doctors also prescribed amphetamine for treating depression, night blindness, ADHD in children, obesity, and impotency. So we have synthetic amphetamine, which is purely chemical, like methamphetamine, MDMA, and others. So today's topic about the methamphetamine. So this is just to show you the difference between the amphetamine as a drug, medical drugs, and the medical name is Adderall and methamphetamine. So you can see that both of them are Schedule II controlled substance. Both of them are stimulants, addictive, but the difference is that the Adderall is medically drugs. So you know it's have a side effect, of course, but you know the dosage and the production is controlled. And the other one, the methamphetamine, is illegal. So methamphetamine comes in different forms. One of the forms is crystal forms. They call it ice, crystal meth, or shabu, and this is our topic today. It's usually, they use it as smoking, and it's very, very potent. The other one is called paste. It's like a wax, and people can ingest it or inject it. The potency, medium to high. And the other one is speed, which is the powder form, and patient can swallow it, snort it, or inject it. It's low to medium potency. So this is other pictures for the crystal meth or shabu, and this is the equipment that usually the patient use it. So why people abuse it? Because it have long-lasting euphoric effect. And how they use it, they typically smoke it using a glass pipe, similar to the pipes used when they smoke crack cocaine. And when the people they use it or they smoke it, immediately they will experience intense sensation, followed by high that lasts for 12 hours or more. Oh, no. And I will not tell you how they do it or how they predict it. So The question is why it's dangerous? Because it's very unpredictable drug. The toxic and fatal reaction can occur regardless of the amount used. So if the patient is naive, we use it for the first time, or we use it occasionally or regular using, it's not different. Sometimes from the first use, it have a fatal effect. And it's more addictive, especially in the crystal form. So crystal meth is a powerful, highly addictive, as we said, synthetic, it's purely man-made, and it's a pure form of amphetamine. It's about 90%. It's derived from ephedrine hydrolysis, and it can be made from pseudoephedrine. That's why most of the federal government, they closely regulate the pseudoephedrine in their markets. This is just to complicate things, but from all these cascade, amphetamine will be derived from the ephedrine. This is a picture of methamphetamine lab, and I will not tell you how they do it. So the other important thing that amphetamine is not pure. So in the laboratory, the methamphetamine laboratory, they use the phosphine gas, methylamine gas, chloroform, hydrochloric acid. Therefore, it have a really significant health effect. Lead acetate, which used as a substrate for the reaction, has resulted in epidemic lead poisoning associated with methamphetamine abuse in Oregon. And also there is a documented mercury contamination. So when people use the methamphetamine, what's the sign and symptom? Is briefly or simply, it will cause sympathomimetic toxidrome. So patient will be hypertension, dilated pupils, tachycardic, hyperthermic. He will have rhabdomyolysis, hyperreflexia. But this is just to simplify things. What's other drugs that cause, or other substances that cause sympathomimetic toxidrome? It's amphetamine, methamphetamine, cocaine, MDMA, and ephedrine and pseudoephedrine overdose. So the mechanism of action, it's inhibit the neurotransmitter reuptake and stimulate the release of norepinephrine, serotonin, and dopamine by release of catecholamine, peripheral alpha and beta adrenergic stimulant. So this is just to summarize what they will do. So if there is increase in the norepinephrine, patient will have increased alertness, inotropic effect, and vasoconstriction. And if it stimulates the serotonin, will have hallucinogens and illusions features, and stimulating dopamine causing addictive drug-seeking behavior, stereotypic movement, and psychiatric symptoms. So methamphetamine and amphetamine in general can cause a lot of things, and I just put these things so to remind you that it affects all the systems of the body. So in a chronic use, it can cause aortic mitral regurg, cardiomyopathy, dopamine and serotonergic urine damage, pulmonary hypertension, and vasculitis. So methamphetamine crosses the blood-brain barrier, have a large volume of distribution, which causes dialysable, metabolized by hepatic enzyme, renal elimination. The half-life is different. So in amphetamine, the half-life 8 to 30 hours, while in methamphetamine is 12 to 34 hours. MDMA, the half-life is 5 to 10 hours. So urine drug screen. Most of physicians, they like to do the urine drug screen. I don't know why. Me as a toxicologist, I don't like it because it's not specific, neither sensitive, and it will not impact the patient management and disposition. But if you want to do the urine screen for amphetamine, you need to know the false positive thing. So if patient using pseudoephedrine or ephedrine, it can give false positive for amphetamine. Bupropion, antipsychotic, even labetalol can do false positive. So the most important thing, how we will manage. So mainly the management is supportive. As a GI decontamination, you can use activated charcoal if the patient presents within 1 hour, but be sure there is no contraindication. So if the patient is fully conscious, he can take the activated charcoal without vomiting. There is no risk of aspiration. You can use it. Otherwise, don't use it. For treatment of agitation, delirium, hallucination with abnormal vital signs, benzo is the first line. Benzo even is adequate for the cardiovascular manifestation. You can use like 10 milligrams of diazepam, and even the patient with amphetamine or methamphetamine overdose, they need high dose. So sometimes the accumulative dose reach 100 milligram. For seizure, benzo is the first line, barbiturate and propofol if you need to intubate the patient. Hyperthermia, after fluid, external cooling, control agitation rapidly with benzo. Hypertension is also benzo. So you can see the treatment is benzo, benzo, benzo. We can use, if the hypertension not controlled by benzodiazepine, we can use phentolamine, nitroprusside, nitroglycerin. But the most important thing is to avoid beta blocker because of the possibility of unopposed alpha and induced vasoconstriction. So in severe cases, you might need hemodialysis. So what's the indication? Acute kidney injuries, acidosis, hyperkalemia that's not responding to supportive therapy. Hemodialysis may be beneficial. So this is just to summarize things. So supportive treatment, IV fluid, hydration, and benzo, benzo, benzo. The most important thing is the withdrawal symptoms. I think if you were working in emergency in the last period, you saw a lot of withdrawal because they cut their resources. So withdrawal causing craving, confusion, irritability, exhaustion, sleep problem, and anxiety and depression. And the treatment is symptomatic treatment. And thank you. I think I can take questions.
Yeah, thank you so much, Dr. Sheikha, for this amazing talk. So we'll open the floor now for questions. We'll have 2 to 3 questions. Yeah, تفضل دكتور.
Yes, Dr. Thamer.
Would that be a possible drug of choice to use instead of
There, according to my knowledge, there is no research about it. But if you think it like, I think ketamine will cause more agitation for the patients. There is a research about haloperidol, but they didn't see that it's more effective than diazepam. So I think diazepam will be the first choice. Did I answer your question? Yeah. For my personal experience, a short personal experience, I didn't use it, so I don't know. Any other question?
Yes, Dr. Sheikh, I have a question. Since the methamphetamine is common for in teenagers, what's your opinion for any awareness campaign targeting schools just to decrease the prevalence or the incidence of amphetamine or methamphetamine?
Yeah, I think it's very important to have awareness campaign, especially now with the social media. Even child with 6 or 7 years old, they know crystal meth and they know a lot of things. So I think it would be a great and better things to do. So prevention is most important than treatment.
Thank you, Doctor. Just
Thank you.
one more question, if you don't mind. Regarding the trends of street drugs in Saudi Arabia, it seems like I'm getting the picture that currently the crystal meth is the most popular one. Is that true?
I think it's not that it's most popular, but it's the most dangerous. And we saw a lot of cases now. Even it have a variety of ages. So the youngest one I saw, she's a female and she was 19 years old. So this is a very dangerous.
So we see it more and more often.
Yeah, we see it more frequently this time.
Thank you so much.
You're welcome.
I think there is one more question for Dr. Musa.
Dr. Musa, he should answer in question, not
Just comment about your questions because I have a little bit experience on that. I have good relation with the poison control guys in our region that actually is lab guy, and I get contact with them. With what the government now is doing regarding arresting the people that either taking the amphetamine or that they are using it as drug dealers. And I asked him, what is the commonest, if you can just order it? Because in daily basis, they are receiving like 300 to 400 blood sample and urine sample to test, looking for all the drugs. So he told me that the methamphetamine is the number one, followed with the Lyrica, followed with the benzo and cannabis, was almost the same. Then I asked him specifically, because I asked him because of GAT. You know, GAT is, I believe, is a drug that can be treat sedation, depression, I'm sorry. So he told me no, they didn't get any sample with positive GAT. So yeah, methamphetamine I think is the commonest now based on the sample that's sent to this poison lab to investigate.
Thank you, Dr. Musa. I thought Lyrica is the commonest.
Yeah, I agree with you totally. The most one we are facing is Lyrica, even me in southern region, but interestingly when we asked them, they found that methamphetamine is the commonest, that getting positive sample out of the 300, 400 sample per day.
Yeah, thank you. No other questions? Okay. Thank you very much.
Thank you. Yeah. Yes.
It is my pleasure to welcome our next speaker, Dr. Melissa White. She talk about airways not secure, challenging airways that challenge AM provider. Dr. Melissa White is an associate professor of emergency medicine at Emory University, and she is the past residency program director there. She completed her Master of Public Health in epidemiology and also her MS fellowship at Emory University, and she is the recipient of multiple residency advocate awards. Welcome, Doctora.
Thank you. It's a pleasure to be here, and in true emergency medicine form, they changed the topic at the last minute. I will say it's interesting. I know I have quite a few toxicologists in this room, and so to be giving this lecture is a little bit different than toxicology. I hate that crystal meth, though, is here. And some of the things that we see in the States are truly horrible, and I hate that it's made its way here. There's something called xylazine that has actually made its way into the States, and we've been unfortunately waiting for it. It has hit. It's actually a benzodiazepine called Tranq. I hope that that doesn't make it here. They come in very septic appearing, actually, and every time you try to treat them with pressors and IV fluids, it does not respond. So fingers crossed, it doesn't make it here. But maybe it will be a lecture next year just as an informative session. To that, I'm talking about wellness today and resiliency. And as the program director, they asked me to speak about this. And you're like, well, why does this matter to me, right? And really, it matters to everyone. And to be honest, I actually should probably retitle this ketamine, right, and just be done, especially with this group, because it sounds like ketamine will solve everything. So to tell you just a little bit more about, a little bit more of this talk, I'll tell you some of my journey. And as a leader in emergency medicine and in the department, I think there's a little bit of a wall when you become a leader. I didn't want to talk to the residents. I didn't want to show vulnerability. I didn't necessarily want them to know what I was going through, because that's kind of been what's been passed down through emergency medicine and through our doctorate, if you will, and kind of our hierarchy. And so when I started residency, this is actually in 2002, I was 8 months pregnant in my third year. And these are my colleagues, and we actually did have pictures back then, yes. And they were my tribe. That's who I talked to, who I complained to. I'm sure it's probably a little bit the same. We didn't have emails. We actually had to call each other. But they were my source of wellness. So A little bit more about my history. Before I went to medical school, I was a paramedic. So our system is a little bit different. I worked as a paramedic in Atlanta, a 911 system, and was there for 3 or 4 years, worked in the hospital as well too, and did a public health degree at Emory. Was hoping to save the world by working with the CDC, and then realized I needed an MD or a PhD or nursing degree to do more of the clinical hands-on experience. So that journey was kind of like this, and very interesting and different. And then I went to medical school. After medical school, I did a fellowship in pre-hospital services. And in the States, and I know it's a little bit different here, but the physicians are actually medical directors for the ambulance services. And so I wore this hat as medical director, as a junior faculty member or an attending, so once I finished residency and fellowship. And I ran the 911 system there as medical director. I actually became the flight medical director for a while in one of the Southeast organizations. The university, I ran their medical director. I was their medical director for a while. So I did a lot of directing. And then fell into the residency leadership role, which I loved. I love my trainees. I love medical students. And so I wore these two hats, kind of leadership positions in different ways. And so my talk actually has a little bit to do with pre-hospital services because I think it's a group, and I'm a little biased, it's a group that we don't think about. And for me, as an attending, when my paramedics come through and my flight medics come through, I know their family, I know their children. And so we're very much like a community, if you will. And we do a lot of education, a lot of chart reviews, and we're worried about each other, very much a team, if you will. So they are going to be in a little bit of this talk, but I've geared it also towards more of the resident and the medical student and some of the faculty as well too. So I want us to understand why mental health matters. We talk about it a little bit, but we didn't talk about it a lot. And why it matters to the providers and to you, and why your perspective as a leader and as a physician to those that are coming behind you is so very important. And discuss techniques that can help people very briefly, and I'll hopefully leave you with a toolbox, more that you can pull up online. So this is what the community thinks. How many of you kind of feel this way every single day? You're happy, no problems, you're joyous, you're well rested, everything's clean, no problem. Don't you jump for joy in the ER? Yeah, I bet you do. I think after COVID, things really changed. And actually before COVID, we knew that this was an issue, especially in emergency medicine and pre-hospital services. And really what we found is it's a little bit more like this. I think a lot of times we quietly suffer on our own. We don't realize that we're not alone. So I presented this presentation actually to EMS medical directors in my area. And this study actually came from Saudi. And it looked at EMS burnout and depersonalization as being a very high indicator of EMS burnout. So very high depersonalization. When you're at work, you can't really relate to the patient, right? Emotional exhaustion was high. And then you felt that although you were a paramedic, you were doing great things, overall within what you do, very low accomplishment. And this actually translates also into the emergency department and into residency. So burnout, why? Because this is a great job, right? You're helping people. It's very noble, absolutely, just as being a physician. Well, when you look at some of the data, we're doing a lot of death notifications. We see repetitive trauma that most people don't see. Critical PEDS calls really takes a toll. So for all of our PEM faculty, thank you. Suicides, homicides we see, and we leave them on scene, right? Especially in the pre-hospital setting. And it's something that maybe you don't think about. But the things that I saw as a paramedic, they stick with you. A little bit of PTSD. They see mass casualty incidents and incidents with their peers. So a little bit of sobering data. I'm just going to share with you from my phone because I want to make sure that I get it right. And I didn't want to put it in the presentation because I wasn't sure of the feel of the room, but I do think it's important. So for EMS providers, and we differentiate them into EMS and fire. So SAMHSA, which was kind of our organizing agency, in 2018, EMS and firefighters' suicidal ideation in the general population in the United States was 6.6%, compared to 0.5% in the general population, okay? From 2014 to 2016, there were 374 suicides of active duty firefighters, and this was more than those who died in the line of duty. And first responders' suicidal ideation is 10 times greater than the general public, while firefighters were 12. And listen to this, the risk of suicide attempts is 13 times higher for first responders and 30 times higher for firefighters. The success of their suicide is more than 2.5 times the general public. It's pretty sobering. You think we're doing better? In medicine, a little bit more data. So facts about the physicians in emergency medicine, and this comes from ACEP, actually, if you look on their website. And we actually just had our Suicide Awareness Month in the States. So each year, roughly, in the US, 300 to 400 physicians die by suicide. And in the US, suicide deaths are 250 to 400% higher among female physicians when compared to their female other professionals. So women in other professions, suicides amongst women, 250 to 400 times higher. And in the general population, males complete suicide 4 times more often than females. It's sobering. It's a problem. But you're not in this alone. And this was actually a really hard concept for me to think because I always felt like I had to be moving towards the green. And yes, that's where we want you. But we understand that, right, life just ebbs and flows. So how do we get there and what's going on? I take this kind of more to residency, right? We're taking it back to the stress of residency, a little bit of what I talked about the other day, that cognitive load, right? It's coming at you. It's the see one, do one, teach one. We're doing an ED thoracotomy here, you know. It's something that unfortunately, we see a fair amount, but it's traumatic, right? But you expect to see one, do one, and teach one. And we know in the web of residency training that the stress is really going to push you, yes, from those activities, work hours, the intensity. Now there are work hours. I think you guys have them as well, too. When I started, we didn't have them. And it was difficult. But you have to have some grittiness in residency. You have to learn, you have to make decisions. And as the program director, it's vitally important because I can't pass you and release you from the program unless I think you're ready. So there are all these things that you're dealing with in residency, and oftentimes these residents start falling more into this blue section here. And that's where I get concerned. Because when I was a resident, nobody talked about this, right? So how do you get help? What do you do? And what can I do as the program director, former program director? So we talked a lot about ikigai. It's a Japanese term. This is like the ideal. I don't know if you've seen this before, but you do what you love, what the world needs, what you can get paid for, and what you are good at, and you fall kind of in the middle, and that's perfect. When you find that, let me know. But it's going to fluctuate for each person. But post-COVID, and this is where my leaders didn't really share their experiences, and I realized that there's strength in showing vulnerability and being able to mentor in the moment. And for me, I actually had to step away as program director for a short time, and I felt like this weed that was popping up in the middle of nowhere. This is my backyard, by the way. Nobody understood what I was going through. And then finally, I decided to share it with the residents because I had to step away. And I was going through a divorce, some depression. And I needed to destigmatize that depression, but I needed to take some time out. And then my son became critically ill for 2 weeks in the ICU. He had meningoencephalitis. And I had to step away. I had to take that breath. And what was interesting, though, is when I kind of stood back and I started talking to the residents about this in a very kind of quiet way, because I didn't want it to be super public, but I knew they needed to know. I realized that I wasn't the only little weed, and these are weeds, in my backyard. So kind of stepping back, I was like, wow, people are going through what I'm going through, a little bit different, and that you never know what's going on behind closed doors. Remember that. Like, and when you're taking care of patients or colleagues and something bad is going on, everybody has something, right? Everybody has something. I showed this picture to my son, and I said, you know, everybody's perspective is different. When I stepped away, it was shown as a sign of weakness, and it made me feel even more unwell, right? When they didn't know what was going on, and even their perspective was different, right? So you see a cow, an elephant, a giraffe, but if you flip it over, do you see different animals? So that perspective has changed. Or you look at something very quickly because you've learned it and you said, oh, I have stepped away, or this person has stepped away and they're not performing well. Well, it has to be this because I have learned this. You think it's an elephant that has 4 legs, but does it? Does it? Right? So your perspective, and when you share your experiences, can help so many people. And I didn't realize that. Also, destigmatizing mental health, especially in my program, but this is a really big push in residency and in our faculty to destigmatize it. We understand there are times in your life where you have to step away or you come with a predisposing condition that needs to be cared for, plus or minus the ketamine. For real, you have to seek care and take care of yourself. So, you think you're the weed. What can you do? So self-care, wellness, and resiliency. We're going to talk about these very, very quickly, and some very quick strategies for self-care. And these can be lectures in and of themselves. I did kind of laugh when they said sleep at least 6 hours, because any emergency medicine attending and resident knows that this probably doesn't happen too often, but you probably should sleep even more than 6 hours. The exercise and nutrition. Again, destigmatizing mental health. I cannot stress this enough. This has helped me the most as the program director and stepping out in a new director role within the department. And an example of this is one of my residents came in, and he gave me permission to tell you this story. And he came in as from the military, and he was the sole survivor in a military helicopter crash. And it was just a training exercise, the only survivor. And he decided to leave the military after that, and he went to medical school. And he came in, and he started struggling a little bit. And we started getting reports of maybe deficiencies in several different areas. And he was getting that feedback. And then all of a sudden, we asked him, is everything okay? Are you okay? And I'll tell you, this is a trick. And it works in relationships too. It works really well with kids because they don't know kind of what's going on, kind of that tweens, if you will, almost teenagers. You double ask, are you okay? Are you okay? Right? There's a difference. And almost universally, you'll get a true response with that second ask. Sometimes you have to do it in private though, but asking that second time is important. Interestingly, and this goes back to destigmatizing mental health, because there are some ramifications if your program director finds out that you've taken leave for something, such as like suicidal ideation. One of my worst fears as program director was that one of my residents would complete something like that, or I wouldn't know about it in order to help them. So to destigmatize this was so important. And actually one day he came to work, and in the middle of work he said, I have to leave. Absolutely, immediately we did what we needed to do. And he sent me a letter, an email letter, when he came back. I was getting ready to come back, and he thanked me so much. He said, you know, in all of my career, it was always expected to be X, Y, and Z, and to show that happy face, and then continue to move and do the next thing. And I realized that I was spinning my wheels and not sleeping, and my education was going down, and my patient care was so bad. and he was wanting to hurt himself. And he said, thank you so much for making it okay and appropriate and important for me to leave, because my goal is for you to get out as an attending and to be well and to know when you might need to stop and step away. One of the other big things that is pushed is debriefing. And this can be, honestly, it can be over dinner. So like I said the other night when I went to dinner with my alumni, we were sharing stories and debriefing. But these critical cases, you should talk to someone about them. Usually your colleagues, because we're pretty morbid sometimes. And then seek professional help. And then religious as well, a very big component too. So kind of moving back, I know my backyard was still a little bit of a mess, but wellness in general is like a big theme, aspects of wellness. And these are the 8, and they'll be in my slide set as well. We'll make sure to put them in. When you look at the literature, you have to have all 8. In different forms, the circles can be smaller or bigger, but really you need all 8 when you're talking about wellness and you're looking at a wellness curriculum, whether it's in your residency program, whether it's in your EMS system, whether it's within your faculty, right? And we know this, that it's no surprise that we do have trouble with this, because we have what's called like a secondary trauma that we see in providers, and that goes back to the debriefing. We see this in the patient, we take it upon ourselves, and that's just who we are. That's why we're physicians. So resiliency. So this is my backyard actually completed. It's a little bit better than before. The weed is still there, it's okay. But I realized that this is the bigger picture, right? This is where you want to be. You go above and beyond, you finally get to a state where you're not just surviving, you're thriving, right? And so resiliency is thriving. I got there. You go like this, right? And that's life. So how do you develop resiliency? I know I have just a few minutes. I'll leave you with some resources. That's my dog. He is the most resilient thing I've ever seen. He's 10 years old. He's well past his prime for a big Weimaraner. We got him a brother. I'll show you him in a minute, and it made him like 5 years younger. So sometimes change in your life is good. You know? It's good to make maybe those decisions and to know and to think 5 and 10 and 15 years out, and what might be right now, you may have to change in 5 years. You just reassess, right? You need to know your strengths and the people that you're working with, some of their strengths as well too. So sometimes I'll run residents through a disc, and we'll look at different ways that they're managing their stress. There's actually a CMC, and you can take this test online, and we offer this to our residents as well too. And because of time, I won't go into this data. But it's there, and the research is there. So this is his brother, the goofy one, actually the one on the right. We do know, though, that positive emotions, particularly surrounding work, engagement in your work, having meaningful relationships at work, and accomplishment, that feeling at work that you're doing something, all this is important. And it's important in your private life, too. You have 2 different lives. Sometimes they come together. So I'll leave you with this toolbox, again, for the sake of time. And I know this is a little bit of a different lecture, but I do hope that as leaders in emergency medicine, working with your colleagues in the pre-hospital setting, that you have some type of system set up, some type of wellness curriculum, and you understand that mental health, it's here, everybody has it, right? And that to be kind to each other. Okay? So these are my kids. They're the source of my wellness. My last few tips, just be a good human. Understand yourself and understand your why. And you sometimes have to ask yourself that several times, right? And sometimes I'll ask the residents, why did you go into emergency medicine? What is your why, right? Ask and ask again. Again, works in a lot of relationships. Seek counsel when you need to. And again, set up a wellness committee and or curriculum. So I'm open to any questions very quickly. But I do want to show you this. You might recognize a few people here, especially on the top row and on the bottom. And my classes are so well in this picture because they are graduating. So I'm happy to take any questions.
Thank you so much, Dr. Melissa, for this interesting topic about wellness and burnout. We can take questions. I have a question, Dr. Melissa. What is, in your experience, what is an easy or interventions? You mentioned many interventions. Of course, they are all building up together to improve wellness and decrease burnout. What easy interventions, in your opinion, that can be we can start with?
I think it's going to be different for each individual, but when you look at the data out of the ACGME had a presentation on program directors and their interaction with residents. So speaking more so from the standpoint of professional and working experience, that residents feel better or more well when their program director really takes an interest in their well-being and asks, right? And they ask again. So I'm going to put that on Bash, right, when he comes back. But having that feeling that somebody has your back, especially in residency, and having that interaction. Now, if you are a leader who that's not maybe your skill set, and we know that that's the case, then you want to make sure that you have somebody on your team that is their skill set, right? That they can reach out to the residents or whatnot. But I do think that interaction on a personal level is so very important, and one of the things that will continue to make us well, because I think in COVID we see that, right? Like that is part of the reason why so many people were also not well. You could no longer get together and converse and talk about what you're going through, and you think that you're just that weed, right, in the back of my yard, like you're all alone. And when you realize you're not alone, I think that really adds value and understanding to what you're going through.
Any other question? We have one question there.
Yes.
Thank you for your excellent lecture, actually. I think the most important message that we should give it to all our colleagues and our residents, it's okay to be not okay.
Yes.
And you need to choose someone to be your mentor and to speak with and to have a support. This will give you more resilient, and you will be more able to bypass all the difficulty that you have in your life. Thank you again. It was a great lecture.
My pleasure. Thank you.
That's it.
Be well.
So it gives me a great pleasure to present the next speaker, Dr. Mohammed Al-Hilayil, who will talk about household toxins. Dr. Al-Hilayil, he's a consultant in emergency medicine and medical toxicology at King Abdulaziz Medical City in Riyadh. He is assistant professor in emergency medicine at Saud bin Abdulaziz University of Health Sciences in Riyadh. He's a past vice president at SASM, and he's currently a board member at SASM. Dr. Al-Hilayil, he's one of the pioneers in medical toxicology. He's the one, I guess he's maybe the first consultant who invade medical toxicology in the United States. He got his fellowship maybe, although he's still young, more than 15 years ago. So let's welcome Dr. Al-Hilayil.
Thank you very much. I'm so glad that most of the room are ladies, because the second half is about product related to you. So don't leave and ask the other lady to come to join us. So I'm talking today about household poisons. I know that this talk been mentioned previously in SASM, so I thought about bringing a new addition, a new products. It will be very hard to include all the product or chemical at home. I'm not going to talk about any pharmaceutical. I'm going to talk about chemical, something around your house. We'll try to tour inside the house, although I'm mentioning some of the commercial product, but I don't have any relation with any of this product, although some of the product I'm going to grill them very hard. Around the house, there's thousands of products, The good news that most of the products are safe and of low toxicity, but if you take enough of them, if you take enough dose, because we know the dose that make the poison, you might expose yourself to harm. But there are some products that are extremely harmful. And we're going to talk about some of them, and you'll be surprised that you have it around yourself, around your pet, around your kids, and you were not aware about how bad is this product. Also, some people would go and buy product from a professional shop, not from the usual supermarket that we go and buy stuff from. And they will expose themselves to industrial strength, and they will harm themselves as well. Also, when the intent is changed from unintentional or accidental exposure to intentional or suicidal attempt, then the impact will be more. So as you can see, there are too many products. So there are too many products around the house. We're not going to talk about all of them, but we'll try to select a new thing for you. Since we are not going to talk about pharmaceutical, but I'm going to list the top 3 pharmaceutical that we have been seeing frequent in Saudi Arabia in the last 2-3 years, mainly analgesic, antidepressant, and drug of abuse. These are the top 3 pharmaceutical. The rest, the most common exposure are cleaning product, analgesic, and cosmetic. If we will say which of these products are the most concerning, the most dangerous, the most lethal, will be alcoholics, other chemicals, and the automotive product, insecticide, and cleaning product. So this is the most important slide for all of you. You're going to have a product, you will not know what to do with it. You need to know how to deal with the product, and if you want to call for help, you need to understand where to get the active ingredient. So you could refer to a poison index, which is part of Micromedex. You could request a material safety data sheet if it's available. You could call a local poison center, or you could search the internet. Sometimes it's helpful, most of the time not, because some of the product has different ingredients from company to others. Or you can ask the family or the MS to bring the product to you, or ask your favorite toxicologist. Let's tour the house. Let's start with the kitchen. I'm sure all of you have this product at your home if you're cooking. It's a vanilla extract. So this child has drank almost 120 ml, and I can understand why he drank it. It smells nice, tastes nice, and it's vanilla, not strawberry. Is it dangerous or not? And why it's dangerous? What do you think? Yes? No? No? Right. You'll be shocked. So what is in this product? If you turn around the bottle, you will notice that it has ethanol up to 35%. 35% ethanol, it's a dangerous concentration for a child. If we do the calculation to understand or estimate the peak blood alcohol level with all this equation, if this child drink this bottle, his estimated BAL will be 583 milligram per deciliter. So he will be deeply comatose. He might lose his, he will be respiratory depression, he'll be hypoglycemic, hypothermic. The treatment is supportive care, but this product, if you heard or somebody asked, if your friend, my child drank this product, take him to the ER. There is no place for home observation. The other product that we have seen around and is very common is the shama, the candle that we see below the buffet. So this lady has drank the whole bottle of this product. So you think it's dangerous or not? Yes? Who will drink it? If you stop asking this question, you're ready to graduate. Huh? So if you open the poison index and put sterno, you will notice that they mention diethylene glycol, something not familiar. And also it has ethanol, methanol, acetone. These products you're already familiar with. By diethylene glycol, and if you open the MSDS, you'll find 100% diethylene glycol. What is diethylene glycol? We know ethylene glycol. Diethylene glycol is the same or not? So diethylene glycol is 2-ethylene glycol bound with ether bond. It is used in solvent, antifreeze, liquid. The idea is to make it heavier and it will not evaporate easily. It will be used as a fuel. Is it dangerous? Yes, it is very dangerous. How does it work? It's not clear. We thought both the parent compound are toxic, also the toxic metabolite are harmful. The alcohol dehydrogenase and aldehyde dehydrogenase will break it to the 2-hydroxy acetate, plus it will produce lactic acid. What is the clinical presentation? The patient will have severe acidosis, renal failure, pancreatitis, hepatitis, neuropathy, multiple complications. The interesting part, the acidosis will not appear until the patient develops renal failure. How will treat it? Supportive care. You might consider using the antidotes such as fombizole or ethanol, but the main treatment here will be the dialysis because you will not be able to measure even the level. So now let's go to the bathroom. Clorox. Every house has Clorox. So this child has sips of Clorox. Would you think something dangerous will happen to him? Yes, no? كلنا قاعد نشرب كلوركس ها؟ موجود في أماكن كثيرة ها؟ يخطون مع الموية في النظافة. So yes and no. So if you use the Clorox, which is 3 to 5% that's available at our house, I should not call it as a caustic. I will call it as irritant. But if you will go and buy it from laundry, professional store with a percentage more than 10%, now we are moving to a caustic product. Now everyone say, okay, this guy is talking about, we know it's alkaline and the pH is high. Why is not caustic? Because pH is not the main indication for injury. It is the dose, and the dose here is different than the pH. The more percentage, the more dose of the product, then that will control the degree of damage. Now, pH by itself is not the indication. The duration of exposure, route of exposure, the concentration, the physical state is the indication for the degree of damage. Why? I just mentioned example, Clorox has a pH more than 12, and it's just irritant. The lemon juice, the pH is 2.4, and it's delicious. So you don't go scope someone who drank lemon juice, right? So the pH is not the indication, it's the concentration of the dose. Okay. So again, أم محمد قاعدة تنظف الحمام وحاولت تنظف الكرسي. She applied Clorox, still yellow, the bathroom, the chair. So she decided to mix it with this one, Flash. Do you know what's in Flash? Hydrogen chloride. So when you mix bleach with hydrogen chloride, Flash, you will have chlorine. If you mix bleach with ammonia, some other product has ammonia, it will have chloramine. It is an irritant. It's a yellowish-greenish color that will cause the irritation to the mucous membrane. What's the degree of damage? The mild exposure, the shorter duration of exposure, will cause mainly irritation to the mucous membrane. The larger exposure causes edema to the airway, pulmonary edema, and you might have stridor obstruction to the airway. If the percentage is high, the concentration is high, few breaths can lead to death. So what you will do, mainly remove the patient from the exposure, limit the exposure, irrigation to the exposed area, skin, eyes, supportive care, humidified oxygen. You might consider bronchodilator. This is the main treatment. And be careful if there is a long duration and severe symptom and the symptom resolve, the patient might have even delayed onset of pulmonary edema, non-cardiogenic pulmonary edema. بدينا نقرب من شغل البنات. طيب. So this is very common for me when someone called me and say a child came with a cream and they brought the cream with them. When I ask him what is the active ingredient, they say this. Very common. Tell me what is in it. هذا أنا عارف إنه ورط. طيب. What I usually say, just can you take a picture and send it to me? I will read it and I know what's wrong with it. So here, the potassium thioglycolate, calcium hydroxide, potassium hydroxide, these are the corrosive part of the material. So we know it has hydroxide, so it can cause corrosion. So if the child or the human ingests it, it might cause severe GI irritation and caustic. Keep in mind that if you don't have signs in the mouth, or the child doesn't have signs in the mouth or initial symptom, this does not rule out GI corrosion. So the mouth finding or signs does not rule out the corrosion. So this is two information about the hair removal cream. Now let's go. ركزوا معي بنات الحين. هذا الكلام بيني وبينكم. أنا أفهم في الأشياء هذه. طيب. Hair products. There are other hair products that some of them are safe, other are dangerous. So what I just need you to concentrate on the hair shaft and the word cuticle. This is the difference between a permanent hair dye and semi-permanent hair dye. So there is 3 types of hair dye. The permanent, the permanent has an oxidizing agent. Semi-permanent, actually the dye will be only on the cuticle, and you can wash about 5 times or 6 times, and the color will go. And the temporary paint to the hair, usually you don't buy it because it has a rub-off. After 1 wash, it will go away. So our concentration will go to the permanent dye because it has an oxidizing agent. Which one is the oxidizing agent? It's the H2O2, hydrogen peroxidase. This is the oxidizing agent. But oxidizing agent does not work alone. You need an intermediate dye. هنا تبدأ المشاكل. Now, these are the types of dye intermediate. كلكم, all of you, you have heard about black henna. Do you think there is something called black henna? There is nothing natural called black henna. Natural henna are bright red brownish henna. If it is black, it has an intermediate dye, and the more you add of this PPD, the paraphenyldiamine, the more darker is the hair color. And this part is the one that you see in this product that you see in every shop. And this is the product, the intermediate, cause the irritation to the skin, the irritation around the mustache for the men. This is the product that causes renal failure, methemoglobinemia, hemolysis, allergy, and blindness. It is very common. You'll find it in many products, even the safe one, but in a very limited and small dose. Other products can cause different type of toxicity, nephrotoxicity, allergy, but the first one is the most common and widely available. If you see it, it's okay, but with a small concentration. Also, some product for men or others, it might contain heavy metals such as lead. This is a very common presentation they are. She applied black henna, then she developed hypersensitivity or allergy. The treatment, washing with water and soap. If you think it's allergic, you apply antihistamine. If there is an exposure to the eye, you need to do an irrigation. If it is significant exposure, you might need to refer to ophthalmology for assessment. This product, I have too many pictures of it in my mobile. Very common. Everybody call it هذا اللي يستخدم للتشجير، تشجير الحواجب. شلون معكم؟ أفهم؟ طيب. It's hydrogen peroxide. Very common, I think, because of the color of the bottle. When they describe something odd, I ask him, is it the green bottle? After a while, I see the picture coming to my WhatsApp. I have too many pictures of this one. The only question that I ask him is what? What is the percentage of the hydrogen peroxide? Because the percentage can range from 6 to 12%. Most of the alhamdulillah, most of the product that we have in the market and have seen with the children is less than 6 or less %, which is a good thing. More than 6, then you will have the corrosive effect, the severe damage. And if you reach up to 12%, then you might see GI corrosion, and you might develop air emboli associated with that. So the percentage is the goal. So you observe the patient. If they tolerate orally, if there is, especially with the 6 and less, then if they can tolerate orally, they can leave the ER. So there are different products, but this is the most common one in the market. اللي يشقر الحواجب. Now, how to make your hair curly. So to make your hair curly, you have 2 products. The first product, such as thioglycolic acid, sodium sulfite, ammonium sulfite. This is the first product they apply the hair. It dissolves the disulfide compound the hair. Then they put the hair around the curler. Then they apply the neutralizing agent. Neutralizing agents such as hydroperoxide, sodium bromate, and perborate. These products is the one that make the hair bind again after they make it curly. If they aim to make it permanent curly, they will apply the mercury chloride, which is an inorganic mercury, which is very corrosive, very dangerous. If you ingest enough, you can die within 24 hours. So this is how the product works. First, it breaks down the disulfide chain, then they make it around the curler, then they apply the sodium bromate, and they neutralize it. Which of the products are dangerous? The first one is moderately toxic, can cause GI symptom, irritation to the GI and the throat and the mouth. Although some of them are at the pH 7 to 8.5, but still mildly alkaline and cause mucous membrane irritation. But the neutralizing agent is extremely, extremely toxic. 1 to 2 teaspoons is extremely toxic to a child. The lethal dose for adult is 10 grams. So this product is dangerous, if ingested, of course. It can cause GI symptoms, methemoglobinemia, hemolysis, and it can cause cochlear toxicity. It can cause renal failure if missed, if not treated. This is the second part of the neutralizing agent. So how do you treat it? This is interesting. This is new for you. You could consider giving the patient sodium thiosulfate. You know the Lily kit, the one used cyanide. The product sodium thiosulfate is one of the indicated antidote. Also, you might consider doing lavage with sodium bicarb. For external exposure, you might consider irrigating the eye and the skin, depending on the area of the exposure. آخر شيء, hair straightener. So, is it safe? This is the worst one. So the product that it's extremely toxic, it has sodium hydroxide 1 to 3% of pH of 13. Definitely, if you apply to the skin, it will cause irritation to the skin. If you ingest, it cause severe GI symptom. This product, if someone told you, my child has ingested a hair straightener product, take him to the ER. Significant GI symptom. Very likely, if you ingest enough, it will require endoscopy. If it's exposed, if the eye is exposed, then you need significant irrigation. And this product, I think, will need definitely ophthalmology referral. Hairspray, don't worry about it. It has some ethanol and isopropanol alcohol. If there is irritation skin, just wash it out. Shampoo, وش رايكم؟ طيب لا تروشوا خذوا راحتكم. Take a shower. So it has many products, trace element of ethanol. It does not cause toxicity. Some people have some allergic or contact dermatitis, so don't worry about it. It's safe. So not everything is dangerous. So the reason why I'm bringing extremely toxic to my toxic, that there are products at home are not toxic, but if you take enough, in the right route or the wrong route, it will cause additional toxicity. So in conclusion, there are 1,000 products at home around you. The dose that make the difference. So if you take the right dose, then you will develop the systemic toxicity. Always confirm what is the product, check the content, the label, try to bring the active ingredient, the correct one. And be careful from the unknown product. We have some market that they sell unknown product, imported product that you think it's to contain this type of ingredient, and you will sell product that have different type or different concentration that you are unaware about. Be careful from the industrial product and the intention. And if you're stuck, just call your favorite toxicologist. Thank you very much.
Thank you so much, Dr. Mohammed, for this very informative talk. And we'll open the floor for the questions. We'll have 2 to 3 questions. تفضل دكتور.
Assalamu alaikum. Thank you, Dr. Halail, for such a wonderful lecture. I have one question about hydrogen peroxide. Usually we face this like dilemma when we get a call, there's a kid who ingested a product that has hydrogen peroxide. He's doing okay, but the percentage is high, the amount is high. Should we admit, should we observe? Because as you said, they are at risk of air emboli, and this is our most thing we are afraid of. So, in your opinion or in your experience, how do we go by? Do we admit those kids, CT them? Because for me, it's a headache all the time.
I'll make it easy. If you drink hydrogen peroxide, it will not cause air emboli immediately. You need to lose the protective layer between the GI system and then expose the vessels, then you might develop the air emboli. So it's not just drinking hydrogen peroxide cause air emboli. You need to lose this barrier. So it is rarely reported. If there is no GI corrosion, you will not have air emboli. Any other question? الحين كلكم تعرفون شلون تصلحون curly hair. You know how to make curly hair, straighten hair. He doesn't use it. He doesn't need it. Thank you. Yeah, when I talk about this product, I feel like I become vanilla.
So, thank you so much for the informative talk. Quick question, do you think there is a link between the price of the products and the shitty material inside it or not?
Say it again?
Do you think there is a link between the price of the product, brand name A, B, C, D, whatever, specifically for, hair dye and some kind of insecticides? We have variation between 5 riyals up to 20 riyals. And the shitty content inside that actually part.
It's tough to answer this question, but some products with brands, they will keep the price high because they are brand. But if it's cheaper or become more generic, I don't think it's the relation rather than the source. If the source is known, if you know where the product came from, if the product went through the regulation of the country, Saudi Arabia, and by the way, and we are lucky in this country, most of the product go through assessment, they check the safety, and there is, under the Saudi FDA, a committee that review the safety of the product. So if it went through all the regulation steps, it should be safe, even if it is cheap. يعني الرخيص خايس قصدك يعني.
Last question, Dr. Halail, regarding the mixing, household products. I don't know, is it something national or international? Despite all these, conferences, talks, campaigns, still, our, people still they are mixing, flash with the Clorox. What's wrong? Is it we don't have, the right, awareness, for them, or why they are mixing this, stuff?
If I told you that I was that close to do the same thing. So, see, if you go to the bathroom and you see dirty and you try one product, then you think about, okay, I'll bring the real stuff, flash. But when you go back a little bit, oh, if I mix this now, it might cause this reaction. So yes, awareness is the key. So you need to spread the word, put some warning, although we don't read warning. Do you read warning on the product? You don't. I don't. I just read to prepare lectures. But awareness to the public, when you see more cases like the CO poisoning, mixing flash with Clorox, it increases more awareness to the public. But I don't think this is because people are illiterate, because they need. They try one product, they don't think chemist. If I add HCl to sodium hypochlorite, the result is Cl to go to my lying with H2O, become hydrogen chloride again. They don't think the same way.
So what do you think? What's the best way to prevent this? Put a sticker on these products?
I think more awareness, similar to the one that we did for the CO and CO poisoning and other products. It will decrease the number, but it will not reach zero.
Sure. Thank you. So thank you so much, Dr. Halil.
It's my pleasure to present our next speaker, Dr. Musa Al-Fayfi, to speak about herbs in Saudi Arabia. Dr. Musa is emergency and medical toxicology consultant in Armed Forces Hospital in Southern Region. He's the director and founder of Toxicology Service in Armed Forces Hospital. He's also the program director of emergency medicine in the Armed Forces Hospital. He's a member of the scientific committee for the emergency medicine diploma and the founder of the emergency medicine diploma in the Southern Region. He's the founder of the head of medical toxicology in the Asir Central Hospital. Welcome, Dr. Musa, to our talk.
Thank you so much, Dr. Mat'ab. Bismillah ar-Rahman ar-Rahim. It's my pleasure actually to be with you guys here today again and again. I'm so happy to be part of this success again and again. Every year I'm coming to present the snake bite for almost like 3 times now. Really, I miss the snake. Today I need to present something new, which is herbs in Saudi Arabia, which is also a topic that we don't have a lot in our country about it. We have huge deficit in the literature and evidence identifying what we have in our literature. So I will do my best. I'll try to be more clinical oriented, the things that you may face it. I do my best also to take the cases that reported to poison control in Riyadh. Me with my colleagues trying to address all the herbs, because we know it's how difficult to deal with such things, especially if you don't know what is the active ingredient in this substance. So I have no any conflict of interest to declare. But I'd like to thank Dr. Badr Al-Yahya that he should present this lecture. And instead he offered me his lectures, so I do some modification. So I hope he will be with us next year. So I'm going to talk about 3 main objectives, which is how common herbs usage among the public, why we are concerned about some herbs, some of the commonly seen toxic herbs. I'm going to present some examples that we face in our clinical practice. So prevalence of the herbs used in Saudi Arabia, it was published 2010 by National Center for Complementary and Alternative Medicine. They report that up to 40 to 60% of the Saudi population, they are using the herbs. So it's not something unique to our environment. No, it's very common actually. And if you look for the reason and also what is the commonest substance that is used by public, you will find that the zamzam and honey is the commonest. Also, you find the cactus, rashad seed. I know most of you know it. Fenugreek, black seeds, henna, mirra, tar. All of these substances that is used, especially like in this study, which is dermatology study published in Saudi Arabia. It's actually a cross-sectional study. They approached like 1,900 patients with questionnaire, and they found that 50 to 70% of the patient or questionnaire that's back reported that they are using herbs. Interestingly, that up to 83% of them, they decide to use it more and more. They don't have any concern about the using. So why the people is using it? What is the reason behind of that? If you look for the graph, the second bar here, which represents 73%, they prefer the treatment to the natural source. So the people think this is a natural thing. So natural usually is harmless. Is it correct principle? We're gonna talk about it. Also, the other cause, they trying to avoid the effect of chemical drugs. They believe our drugs is chemical and is harmful. And 34% of the patient, because it's chemical drugs, is ineffective. So what we are doing is nothing for them. This is what they believe. Also, and 43% of patients, because of complementary alternative medicine, are accessible. So it's easy to access any dispensary pharmacy with the complementary alternative medicine and to take it without any prescription. So this is previously this study mentioned what is the cause and what is the commonest herbs that we use. So how commonly herbs cause medical problems among other poisons? Where is the herbs between other poisons? This is actually one of the unique studies in Saudi Arabia. It's done by our colleagues, Dr. Nahar and his colleagues. It was 1,035 patients. It's epidemiological aspect of pediatric in Riyadh and 2 emergency department there over 2 years. And they found that herbs and dietary supplement and vitamins represent 4% of the poison, and it's considered order number 7 between the top 10 classes. So it's there actually. However, this study is still a small sample size. We are sure that the number is much higher than that. I hope one day we're gonna talk from the perspective of the poison control in this stage, maybe next year, maybe after 2 years or whatever, and exploring more data about what we are using in our country. So why are we concerned about some herbs? What's the reason? Is it because we are physicians and we do not get taught about that? We don't know a lot about it because we are jealous and we think this is competitive to our practice, maybe. Or we are just exaggerating. So what is the reason? Seems that everything is sleeping now. It's not just the audience. Anyway, so what is the reason why we are talking about that today? Simply because this is question. Is everything is natural? Is really natural? And this is published study in 2001. Actually, is our data, Saudi data, from King Faisal Specialist Hospital and Research Center, Riyadh. They collect like 2,047 samples from the patient that is coming to their clinics, also from the dispensing window there. And they are looking for, and after that they are doing analysis for this substance or for these samples, and they are looking what's the active ingredient there. Unfortunately, there is huge of them is contaminated with heavy metals. Like arsenic, they found an arsenic mainly on the patient that have herbs to treat their leukemia. So the substance or the herbs that they have, it is contaminated with arsenic. Mercury was found in the sample that's mixed with the cream for whitening, while lead is mixing everything. So this is one of the big problems when you have heavy metal contaminated and you couldn't screen for that. So definitely will be underreported problems. The other problem, it's contaminated with medications. So some samples they found is contaminated with benzodiazepine and chlordiazepoxide, which is addiction, induced addiction. Some of them is contaminated tricyclic antidepressant, which is cardiac toxicity. Some of them is contaminated paracetamol, which is associated with liver injury. And another abule, which is considered one of the drugs used for termination of pregnancy, and they found is induced liver and kidney injury. Another problems with these herbs, it's occurrence of toxic or hazardous compound of the natural origin, like beta-acerone, which is carcinogenic, xanthotoxin, it's used to treat vitiligo and severe dermatitis as controlled drugs. That usually should not be used without medical opinion. Also, benzocyanide is associated with cyanide toxicity. And the other cause, it's because it's contaminated with bacteria and other microorganisms. And they found that actually in 14 samples. So it's really big problems when you find that this herb is not really natural. It's contaminated and laced with other things that may affect on the health. So why are we concerned about some herbs? To recap what we said, because contents are not necessarily similar to what is written on the product. Contamination with pesticide and heavy metals is common. Concentration are not possible to confirm. Limited clinical experience regarding toxicity. And efficacy is not established yet. So this is the reason why we are really concerned. Let us move forward and talk a little bit clinic, because I know as emergency physician we are interested in the clinic. So we'll start with the herbs that induce methemoglobinemia. This is one of our patients that he is 3-month-old Saudi boy, arrived to emergency cyanotic irritable respiratory rate 90 beats per minute, saturation was 76, with 10 liters of oxygen and breathing mask. Chest X-ray show normal, pH show severe acidosis with bicarb 10 and pH 7.1. Methemoglobinemia was 66%. Mother revealed that she gave him gum of resin of ferriola azavitide, which is locally known as Hiltit. All of you heard about Hiltit as a treatment for infantile colic. Actually, they use it, and you know that the infantile colic starts from 3 months, so most of the patients present in this age. So this is actually reported from by Dr. Ibrahim Hilala and his colleagues. He's one of intensivists in our region there. And this is the only case reported literature to just see how unique literature, the evidence about such very toxic substance. This is Iranian study. It was animal study actually. They looked for using infiltrate in animal and rat, and they found that there is no acute toxicity, but when they use it for 6 weeks, they found a significant elevation of liver enzyme. For us, we found that there is 2 cases from poison control show elevation of transaminases. One of them was elevated ammonia, but actually it's not pure Hiltit. It was mixed with the anzarut and khawajawa. There's another herbs that very common found in the market. Moving forward, talking about the herbs induced liver injury. And this is one of our patients. She is 63 female, and just Montaline to treat osteoarthritis. We have a couple of cases like this in southern region. After she used it for 1 week, she came with right upper quadrant pain, and we found she had transaminitis with high LFT. When we look back and trying to elaborate and explore the structure, we didn't find anything genuine there. So what's going on with this patient? So when we back to internet and look for Montaline, we found that there is a Saudi FDA warning that Montaline, it's one of the herbal products that contain medicinal substance. Actually, this medicinal substance is paracetamol. And this is the reason why this patient had acute liver injury, because have paracetamol toxicity. Anzarut, astragalus, sarcocolla, I hope I pronounce it well. This is also the only case reported in literature talking about Anzarut, which is associated with hepatitis and hepatic encephalopathy in children. This was a 9-month-old child who developed hepatic encephalopathy after drinking Anzarut for 3 days only. You just imagine that, 9-month-old, he drank Anzarut by his mom for 3 days, and after that he came with hepatic encephalopathy, coagulopathy, acute liver injury. He recovered from that, but unfortunately he followed with the seizure, and unfortunately he ended with seizure and delaying on speech. The other guy, who was 9 years old, another case report, the same report that is mentioned, is 9 years old, who admitted to the hospital with acute hepatitis, but hopefully he recovered after treated with anastasis. We know that the active ingredient of Anzarut is triterpenes, monoterpenes. So based on how many phenols groups there, it's classified, and which is considered one of the hepatotoxic substances. Other herbs that induce liver injury, al-haza or dicorosia, al-mirra, which is Camphoria mirra. Al-haza, there is different name for it. It's called also شجرة الحمل, القشعة, جرجيح مسيكة, قرن الغزال, البعوض. Actually, it's used by ladies for termination of pregnancy. We have one lady, she's 32 years old, that present with severe acute liver injury with AST and ALT more than 1,000 with coagulopathy. Hopefully, she recovered after a good course of anastasis after 5 days. Regarding the mirra, which is one of the commonest actually that we use it here, and there is a lot of publications show that how helpful is considered antifungal, antibacterial. It's helped a lot in flu and many things. However, there is no study talking about how harmful it is. We have one guy, he's 50 years old male. He used inhalation for 2 weeks, and after these 2 weeks, he's coming with severe acute liver injury. Animal studies show that with prolonged use of mirra, it's associated with acute liver injury. So, as Dr. Muhammad mentioned, usually the dose is the cause of poison or the make of poison. So the people that use it less than 3, and in this animal study, if they use it less than 3 days, hopefully no consequences of that, but if it's used more than that, it can induce acute liver injury. All of you know that, which is herbal-induced protein synthesis inhibition. We start with castor bean or ricin, which is al-kharwa'. You know that it's one of the biological weapons that is used, and that guy, he is George Markov. By 1978, he was murdered through stabbed by umbrella, and which is tipped in with the bullet. And this bullet, actually, there is 2 holes there, which is filled with the ricin. He actually died after 48 hours, after 24 hours, actually. The ricin is it's one of the toxic albumins, which is inhibited synthesis of ribosome, usually associated with shortness of breath, cough, fever, nausea, vomiting, and if it's dermal applicant, is associated with some irritation. Most of the cases that we face them that use it once, when seeds of the castor bean, most of them, they recovered very well with the good hydration and resuscitation. Hab al-muluk, very common. I face like 5 or 6 cases, is more strong than ricin even. Both of them is working as toxoalbumin or protein synthesis inhibition. It's very irritant seeds. If you look to it there, it's smaller than ricin or al-kharwa', but it's more irritant actually. It's the ricin is more darker than comparing to the croton tiglium. So the active substance is crotin. Same manifestation to the ricin. We have 2 cases reported to poison control. They have severe abdominal pain and diarrhea, and both of them recovered very well. I remember I received one patient in Al Habib Hospital. She used it, actually they use it to induce vomiting, especially if they think that there is sharm done for them, مسحورين. So they're trying to get rid of that, so they eat it to induce vomiting. So it can present with very bad complication, maybe end with end organ damage, multi-organ failure. That patient, I remember her, she's like 50 years old and she came with severe pancreatitis. I'm sure every one of my colleagues in toxicology have his own experience in the herbs. We hope one day we can gather together and write that and guidance for our colleagues in emergency and other department. Abras Bricoturus Ain al-Ifrit. This report came from India. It's also one of the toxyalbumin. It's induced diarrhea, hematochezia, and death in 5% of the patient. I don't know if one of you see this tree. We see it actually in our village there in Faifa. They are using it, and the old generation, they are using it like a necklace, like what you are seeing here. And very attractive for kids, actually. So the toxicity is expected in pediatric patient. The herbs that induce cardiac toxicity, I have 3 cases actually that have similar presentation. The first one, all of them came from sheikh. They went to this sheikh, he incited Quran on them. Then after he finished, he said, okay, I'm gonna give you this powder. Upon arrival for your home, just take it once. It's only 1 shot. You will start to have vomiting with abdominal pain. You'll be resisting vomiting as a whole. Go to the emergency. You will be sick a little bit. Take fluids, and after 12 hours, you'll be okay. Go back to your home. The journey is out now. What he said is typically what's happening. But most of the patients came with severe bradycardia and severe hypotension. So they are coming after 12 hours after aggressive resuscitation by emergency physician. And it's not only one patient, actually there are 3 patients. So this is one of them. Actually that guy, he's pharmacist. He's 27 years old, have anxiety disorder. After he ingests this powder, he came with perioral numbness and whole body numbness and general weakness with excessive vomiting. Upon arrival to ER, his heart rate is 44, blood pressure is hypotensive, drowsy, sweating, and look sick. We send analysis from his blood and we send the substance itself. We found a high amount of aconite, very toxic substance, which is sodium channel openers that delay repolarization and induce excitation with bradycardia. Is one of the cardiac toxic that, and one of the literature mentioned that the bidirectional fetag happen in 2 toxins. One of them is digoxin, the other one is aconite. So this is MCQ's question for toxicologists. If you ask what's the other differential for bidirectional fetag, it's aconite. And actually the presentation is typical to digoxin toxicity, and it's very difficult to differentiate between both. Upon patient arrived to emergency, we stated we was thinking to give Digifab, but we don't have it actually in our emergency. So when the result is back, we report it to MOH. We report 3 cases, but unfortunately there is no action was taken. We report this case, actually is published in the clinical medicine case report. Usually the symptoms started from 5 minutes to 4 hours after ingestion. With aggressive resuscitation, the patient will find. If the patient have arrhythmia, like FETAC or VF, you can use sodium channel blocker, which is either 1A or 1B, 1C, whatever, or amiodarone even, because the mechanism depends on sodium channel opener. Ad-dafla, oleander. I'm sure all of you receive such cases that baby or girls or baby boys that present after he ingested dafla. Actually, it's one of the cardiac glycoside that present with digitalis toxicity. And actually, this is common in all the world, not just in our region. In our region, what we have is specific, it's al-ishar. Calotropis procera. There is like traditional example, if we take like a bow's hair, what they call it, khadrat al-ishar, This means you are smart like al-ishar, but you have bad intention. So don't be like khadrat al-ishar. Okay? So al-ishar or Clotrobis borsira, there is actually two toxins on it. One of them is glycoside, cardiac glycoside. The other one is calcium oxalate. So calcium oxalate induces severe local irritation and severe pain, especially when ingested, or it's induced severe pain when it's deposit, especially the juice on the eye of the patient. It's induced severe pain because of calcium oxalate. And on the other hand, it's induced arrhythmia like the oleander. So usually the management is supportive with digifab in case of patient have cardiac toxicity and analgesia with severe pain. Herbs that induce CNS toxicity is Saykaran, Datura is very common also. I have a lot there in my village actually. It's one of the toxic in children. It's reported a lot from Tabarjal, northern of Saudi Arabia. Both seed and leaf are toxic. It contains hyoscyamine and hyoscine and atropine. It's anticholinergic toxidromes. It's treatment usually with supportive management, benzo, and sometimes you need to use physostigmine in case of patient have seizure. Khawajawa, Serotonia siliqua. When I'm searching on my references, I use like 10 references from different countries, even from Arab cultures here. I didn't find a lot about it. However, I found it in Thailand website, which is called Toxins. It's usually associated, however, it's in our dispensing. This is actually my picture. The one on the left side, this is my picture. I take it from dispensing place. Is exposure associated with minimal or no manifestation? And severe manifestation is associated with CNS stimulation, seizure, CNS depression, and can be seen in severe cases. Dermatitis is possible when plants juice come in contact with the skin. Herbs induce CNS toxicity. This is another one, which is nutmeg. Interestingly, the people start to get high with the nutmeg. This is one of my patients. He's 21 years old. He decided to drive from Tabuk until Asir region. It's like 1,400 kilometers. And to keep alert all over the drive, like 24 hours, he decided to take the nutmeg. Upon arrival to emergency, he arrived and he seized with abnormal movement. Then after he wake up, we asked him and we emphasized about that. He denied any history of sympathomimetic. However, he mentioned that he takes five seeds of nutmeg. What is nutmeg? Nutmeg is myristicine. This is the active ingredient. It's work like monoamino oxidase inhibitors. Actually, there is not a lot of case reported with a death. Only 2 deaths reported in the literature. One of them is 8 years old that arrived with a seizure, and they give him huge amount of anticonvulsant medication, and they claim that the cause of death is anti-epileptic medication. The other patient, he was 55 years old, that have condition with it, flutrizepam, which is benzo. So it's not clear, is it the nutmeg or benzo is the cause of death. Apart from that, is considered one of the things that people start to get high through the monoamino oxidase inhibitor principles. So take-home message, herbs are frequently contaminated with other substances such as heavy metals, pesticide, medication, and microorganism. Infant and small children might be at higher risk. Supportive treatment is the cornerstone of management. Treat accordingly to aberrant toxidromes. Call the poison control 1937 if you have any concern. Thank you so much.
Thank you, Dr. Musa. We'll take questions. Dr. Musa, I have a question, okay? Thank you again for this informative lecture. Since herbs are very commonly used in the kingdom, and it seems like it's very hard to know the toxic dose, okay? How do you approach cases like this with herbal use? How do you determine, yani, is there any efforts to determine toxic dose for these so we can do some public education about them and that sort of thing?
As you see, we have huge deficit on the data and evidence regarding the dose. And most of the publication is related to animal, as you said, in the lecture. And even the human case report is like very unique in the literature. And PubMed, Google Scholar, or the engineer of search, we didn't find a lot actually. But what does that mean? Does that mean we not treating? No, we should treat. So we're gonna treat based on the toxidromes of the patient. We can search more and more if there is something new there. We have a community between us as a toxicology to consult each other. So I advise you, one of the most difficult cases that you may face in emergency is herbs intoxication, because nobody expert on it. Even the toxicologists themselves, they find to seek help from other colleagues and other references to have it. So just call Tox. This is the recap answer.
Thank you, Dr. Musa, for this very amazing talk. My question regarding the source of this herbal, stuff. All of these herbs come from the local shops, like al-Attar.
I couldn't.
Do you hear me? Regarding the source, from these herbs, usually from the local shops, al-Attarin, عادة. So my question: is there any way to control, the source? Because lots of these shops, they are selling hab al-muluk, nutmeg, all these stuff from al-Attarin. Is there any way from the Ministry of Health or the government to control the source for these herbs?
As I know now, there is like a license for each dispensing unit, and this license belongs to the National Center for Complementary and Alternative Medicine, as under control of MOH. I don't know really, and also they have a website actually there on Twitter. You can go and follow up how they're gonna trace such presentation. Actually, on the case that we face them, we have huge difficulty in reporting. We report the case that I mentioned. We reported 3 times. However, I'm so close from stakeholders there, but really, still the guy is still reciting and he's giving the people the same dose, and still we receive the same patient. So. Sometimes you need to escalate it to higher level rather than MOH. So we escalated it up للأمارة. I hope, I didn't see any cases after that. I don't know what's happened to him actually. But really, we have 2 issues. The issue number 1, how effective the control of MOH and these things. I couldn't answer that. But with the time, if we have data in our hand through poison control, I think we can emphasize and project that accelerating such thing. But already we have like national center for that.
Thank you so much, Dr. Musa. And we'd like to, this is the end of our stream. We'd like to invite all speakers of this stream to the podium for a group photo.
عبدو السيد. I think you met him throughout the days, and the last 2 days in different speech. Dr. Abdu Said is one of the star emergency physician that I was honored to work with in many times across the years. He is a Saudi board emergency medicine certified and Jordanian board as well, and he is a fellow of faculty development fellowship. Help me here to welcome Dr. Abdu and wish him the best in his talk.
Assalamu alaikum warahmatullah. Again, Abdu for the third time. Sorry for that. I apologize. By the way, just before starting, Dr. Anas, when I was intern, he was mentoring me. He was reviewing my CV. He was recommending me. The last one, he gave me a recommendation or reference for interview, Dr. Anas. He couldn't remember that because they get used, those type of people, they get used to help people. I hope to be one of them. Okay, this is my talk. I will not say yes. You know that. I'm doing this for 11, 12. Majority of you, they attend for me a brief lecture like this way, either 1 time or 2 times. CV writing, how to stand out. I'm doing this for 4 hours, 6 hours, workshop. But again, there's another challenge from SASM committee to put something summarized 4 hours or 6 hours to be within 25 minutes. 25 minutes, I'm gonna give you just a tips and tips. You're gonna have a standout CV and you're gonna catch what you want. Let's start. Okay, again, I'm here because I love to educate, I love to inspire, I love to make a positive change, and I'm repeating that in every lecture that I have it. Our outline today is how can you write basic element of CV, how can you brand yourself on the CV, how can you write a quick resume within 10 minutes, and common mistakes. I have been reviewing hundreds of CV throughout the last 5-6 years, and I discovered a lot of mistakes. I'm gonna just tell you to make it clear for you. What is a CV? Definition. I have been reading almost 3 or 4 books about the CV writing. Anyone can define the CV? A lot of definitions, a lot of things. I'm gonna bring for you just one definition. I'm a big believer that the CV is a big opportunity to sell yourself and to impress the people. And it's a summary of your career. How can you make it? The rules of writing CV, there is no rules. Just to make it clear for you. Every book's gonna give you a rule to write a CV. Everyone gonna give you his perspective. For me, there's no rule to write the CV. There is no rule that I'm gonna wear a shmag, white shmag or red shmag. There is no rule. There's no rule that I'm gonna talk and standing like this way or walking around. There's no rule. The rules that it's gonna be depends on you, on your picture, on the position that you want it. Basically, to summarize it, CV or resume is a you put on a paper. And who gonna be the drawer, who gonna be the artist is you. We done about this, GPA, majority of you, intense, show of hands. Majority intense. Students, good. For that they make this lecture on the last track for this purpose, to keep you here on the. We will not talk about the GPA, we will not talk about SMLE. Today we're going to talk about CV only. When should I start writing my CV? Like this child. You're going to see it like this way on this lecture. The first step is going to be the most difficult step. But from now, which is the first day that you can write the first sentence, the first certificate that you're going to gain it from SASM, which is 25 of September, you can start your CV. Information to be included in CV. I'm going to give you the basic information that can help you on writing your CV. The first thing that you should do it, personal details, including full name, official email, and official email, and your numbers. including your location or address. Education, you're going to start either by secondary schools, university, postgrad certificates. Practice experience. What's the mean by practice experience? If you are a resident right now and before you have been working as an intern and before that you have been working as a medical student, you cannot. When you are practicing, now I'm a consultant, before I was a resident, before I was a general practitioner, you can put practice experience. This is including a lot of things not specifically designated for medical field only. Researches and scientific writing. One of the things that should be included here, publication, your research, that published or not published, your role on the research. Poster presentation now, the winner of the poster presentation, where is Bassam? He can include in this point. Bassam, I have been presenting posters for many years in SASM. I present 7 of them. I won in 1 place. Achievements and awards. Always, when I'm reviewing CV, I just found the achievement or the awards on the 3rd place or on the bottom of the list. It's not the right place. If you are achieving a lot of things, if you are an achiever or you get an awards or honors, you should put it on the first place to highlight it, to make it, to attract the people mind, to attract the reader minds immediately. Do not put it on the 2nd or the 3rd phase. Okay, next. Presentations, including the professional presentation. This is, I'm going to include it, that I'm presenting officially on SASM. For that, I can include it right now in that area. Teaching appointment. If you are doing a teaching appointment, not mandatory teaching appointment, you can put it here. Extracurricular activities, this is what we have been doing always. For that, volunteering opportunities, volunteering task that you have been doing it, you can include it on this way. And also all the volunteers, you can include your role on the volunteering opportunities that I have been as a leader. I have been doing this and this and this. Try to describe even your ranking. I have been working with SASM since 5 years. Member, leader, blah, 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 blah. Now, what I'm doing right now is just a progression on the volunteering opportunities that I have been achieving it. Conferences, courses like SASM, which is the biggest conference on the area, you can include it in this way. The timing, the years, and the workshop that you attended. Skills and hobbies. Always we are neglecting this point. We are trying to reflect to the people or the reader that we are a machine. Try to reflect that you are a human being, not a machine. We have skills and hobbies. One of your colleagues that I found, she have an interest in event management, and she is so professional. She said, okay, why you put this on the bottom of the list that you have an event management skills, and you are so professional? I found she have an Instagram account, Twitter account, and this blah, blah, blah. She have thousands of followers on Instagram or Twitter. I said, you know, this is a big advantage in the marketing. When there's an added value and everything, they're gonna catch you. Any institution or any institute that gonna recruit someone and he have an opportunity of event manager, they're gonna recruit him immediately. This is skills and hobbies, including personal skills and soft and hard skills, and personal interest. Other than this, recommendation and references. Recommendation, it's totally different from references. References that they know you more. They can make a call for that guy who give you a reference, and he should know you more than the recommendation. Recommendation is a right for everyone that have been working either with the consultant or whatever. He should give you not a recommendation. He have been working with me, or he show a good potential, not to give you that much words or something like that. This is your right. You should ask for it. Sorry, I'm talking in a hurry because 25 minutes. 6 C's, I just summarize it on the CV. 6 C's of CVs. One of them should be consistent, like streaming, like YouTube. It shouldn't be stopped. The second thing, it should be clear. Current should be updated. My last updated CV, it was just 1 month back. if you are not updating, this is one of the things that if you are not updating your CV every 2 months or 3 months, you are not achiever or you are not moving. Concise. Concise, yes, yet comprehensive. It should be concise and it should be comprehensive. Chronological. What you have been doing right now and on before, on the past, and the blah, blah, blah. It refers chronological order. I'm doing this work on the first, and then the second thing, and the previous work, like this way. Complete, it should be complete. It should be covered, a lot of elements. There's a lot of gaps, it shouldn't be missed. Tips for CV writing, again, tailor your CV. What I mean by tailor your CV, خياطة. When I have been applying for a residency program, I did a CV template for King Faisal Research Center. I did another version for King Abdulaziz University. And I did another version for National Guard. You know why? Those on the research centers, they have an interest on the research. I put the research on the first. Those they have an interest on the leaders and blah blah blah. I put the leadership task that I have been doing it on the first. Those that they have an academic program, I put my academic achievement or my academic task that I have been doing it on the first. Tell a story in your CV. What I mean by tell a story? How can I make a story on my CV? Tell a story. I start by a member, then sub-leader, then a leader, then a chair, then whatever. Tell a story on your CV. Show us that you are progressing in your CV. And I have been reading a CV. It's so impressive that from a member to vice president or anything, proofread, get a feedback. Majority of Al Qura people, they know my numbers. There's a season for CV review. They WhatsApp me, please review my CV, Dr. Abdul. Get a proofread, get an expert opinion, anyone, R1, R2, R3, just get a feedback from them. It should be comprehensive. Okay, how to brand yourself on the CV? Anyone, all of us, we know Starbucks. All of us, we know BMW. By the way, how can we pronounce it? If anyone pronounce it, I'm going to give him 500 riyal. باقي في جيبي من الصباح. They said Bayerische Motorenwerke. God for the German people, they make it summarized in BMW. Nike also. Everyone know it. Every brand have their names. And for that, I'm gonna stress on this point, guys. Every one of you have unique character, unique attitude, unique amount of knowledge, unique style. No one can be similar. Even your twins, they will not be like you. This is a rule number one in everything in the life. لو شاء الله هذه فطرة من الله. لو شاء الله لجعلناكم أمة واحدة. الاختلاف فطرة ربانية. We should adapt it. You have been born to be an original. Do not die as a copy. Just first impression. What I mean by first impression, always first impression, they said count the most. Every element in your CV is going to tell something about you, even the prioritization, physical pieces. How can you arrange it? The first stuff. You know, جريدة العكاظ, المدينة, newspaper. I have been reading it. رياضية. The first thing that the most attractive and the most expensive announcement is going to be on the manchette. صح? First line. Am I right? For that, you should act like a journalist. This is what I have been. I'm not bringing any copies for the CV. I'm going to give you an example. This is what I have been doing in my CV. Just a summarized way of me. I'm an educator because I have been doing a lot of education appointment with an evidence. I'm a leader. I have been doing a leadership task for years. I am a volunteer. I'm doing volunteering jobs either here or international, and just summarize myself in 2 areas. Guess what? I know, and this my official email, my number, location, LinkedIn, and X or Twitter account. Guess what? Why I put my Twitter account? They said to me, why you put your Twitter account? I'm betting on 1,000 riyal. After my talk, 5 person at least, they're gonna look after my Twitter account. Okay, I'm gonna give you I'm gonna give the interview the time. Do not waste your time. This is my Twitter. I'm not hiding anything. You can look after me. If you are doing a lot of gossiping or not, there is no target in your social media account, do not put it and hide it, please, because we are looking after you in that area. Personal statement, one of the things should be written by everyone. I think some of the hospitals, they make it mandatory. This is another golden advice. If you didn't have a personal statement, you should write it now. I have been doing, for the last 2 years, I did multiple personal statements for me, personally. Personal statement is just your story, your mission, your interest. And one of the things that, one of the reasons today, she did one thing extra. She heard my talk before 4 years. She's an R4, today she participated with us. She did the personal statement. The first thing that they put her on the rank 1 because she wrote personal statement. Personal statement is an added value. How can we write, Dr. Abd, how can we write personal statement? I cannot help you on that point. I just have 25 minutes. This is 5-point essay, and you have my email. I can help you on that point. Tips for personal statement. Write, then rewrite, and write it again. The first draft is rubbish. Back off cliches. Do not be that I want to be the best physician in the world. No, you are the best physician in your mom eye. But be realistic in the personal statement. Back off cliches. I want to be the best emergency physician or the best surgeon in the world. No. Be realistic and be thoughtful about transition. It's like telling a story. It's like movement of my slides. Be thoughtful. Be smooth on the transition. Stay focused. And find your unique angle. Everyone have a unique angle. Everyone have a difficulties. Everyone, he faced the challenge. He should have it, and he should mention it. Do not overdo it. If you want to stand out from the crowd, just give a people reason not to forget you. This is an opportunity to give a people not to forget you on the personal statement. Quick guide for writing a resume. What's the difference between a resume and CV? Resume is just a small piece, and CV is more longer. 5 Bs, we have 6 Cs for CVs, we have 5 Bs for resumes. It should be painless, مريح العين. It should be perfect, and should be page, صفحة. It should be paper. If you're gonna send it in a hard copy, it should be paper, 1 paper. Not more than 1 paper. It should be tailored to the position. Difference between CV and resume. Resume is just, you can make it to the small positions that you should apply it. If you are applying for a volunteering opportunities like in SASM, you should submit a resume, not a CV. Okay? CV always for academic purpose and official positions. Last but not least, we are running out of time, Dr. Anas. Or yeah, give me more because... We just start late. يسعد قلبك. How can we avoid the common mistakes? I have been reading and reviewing a lot of CV. 100, even for interns, students, resident, consultant. I get known on that area. It's reflect in a perfect way to me. It's have a huge impact. They said to me, you are costing yourself more and more to review a CV. No. If I'm gonna build someone, I'm gonna build his family, I'm gonna build his society, I'm gonna build his country. If there's someone gonna come to you and you have a business and he said to you, I'm gonna give you 1 million, and you will not get it back to me again. You'll forget him? No. Am I right? He gonna give you 1 million, do not get it back. مليون, لا ترجعها طول حياتك. You're gonna forget him? No. This is what I'm doing. I'm preparing a resident, he's gonna catch by minimum in 5-7 years, 1 million. For that, I'm starting with your project and a business. How can you avoid the common mistakes? Please, this is a common mistake that I have been reading it and reviewing it on the CV. One of the thing that we should stress on it, spelling and grammar mistake. If you are failing on spelling or grammar mistake, you didn't consume a big time or you didn't do a big effort in your CV. Using cliches and bold format. I have been reading, I can know. 2 of them, they send the same CV, almost 3 weeks or 1 month away from both. They send it to me in a separate way. I know that this guy, he took it from this guy. And there is a universal cliches. القرى عارفة عندهم cliches. I'm highly achiever guy. I'm highly interested in this, looking to respect my senior, teaching my junior. عارفها. You didn't spend 5 minutes in writing your CV. Gaps in correct information. Do not put incorrect information. Failure to tailor. You should tailor your CV based on what you want. Writing your CV too late. This is what we have been doing. You should be ready. Dr. Anas, if you approach me right now, Abdu, if you can work with me, can you email my CV? I can email my CV, my updated CV, now to him. Anyone, he can do the same. This is not between the lines. So quick. زي لما نتكشخ ونلبس ونحط الحمر معلش this stuff and drawer you have a drawer of thousands of stuff 100 شماغ 100 ثوب and you're gonna be so selective for an event or a meeting for 1 hour. You should be so selective and you should consume a big time for this opportunity or for this paper because this is your passport. Without review, I can see that some of the people they submit a CV without review, it's gonna be obvious. Not true. Some of your colleagues they are mentioning that. Please do not do it. الكذب في كل شيء حرام. في CV you're gonna be discovered. Written by another person. Yes, I can found. I can write your CV on X down. I can write your CV within 10 ريال. I can see that. I can know the quality of 10 ريال. زي الجاليري لما تكون من البلد لما تكون من التحلية. I can discover that. This is a 10 ريال CV. Unofficial email. Still until now. I wasn't believe. Until now. There's no official. Some of them they are sending a CV without official email. This is just a quick. I just write it. You can scan it. A common mistakes that I have been reviewing it. You can scan it. You can have a look. You can have an access to my Twitter account. Give us a solution. You have been talking about mistakes and a lot of things. Give us a solution within 1 minute. Am I right? 1 minute? Okay, Grammarly. Upload it in your iPhone. Upload it in your laptop. Use it. We are not an English speaker by... we are not a native English speaker. We should utilize something to help us on that point. Canva. Photoshop بالغلابة اللي أنا زي وزي كده ما بعرف. Use it. Resume Star, amazing application. I can do CV, bam, within 10 minutes. Okay? This is a quick offer the common website that's gonna help you to design or to write your CV. I have been using 3 of them, and just subscription to added some details on it. It's gonna cost you just a cost of a cup of coffee. This is a quick guide. I have been using it. No, I read it. I think 2015, and it helped me. This is from المؤتمر. Summary. Be unique. Every one of you is unique. I'm a big believer on that point. Get a feedback. We are looking always for a feedback, even for our show, for my lectures, for my presentation now. I have been doing it for hundreds of times, but I should ask for a feedback. Start writing your CV now, not later. Know yourself to brand yourself. You should know yourself before anyone. This is my business card. You can scan it. I'm the most approachable guy, I think, in this area. I can stay with you on further question. I think we are running out of time. Last message. I'm a big believer إن كل واحد فينا مختلف، رسالته مختلفة. لابد أن تبحث عن تفردك. لا تكون نسخة من أحد آخر إلا أردت أن تكون أنت النسخة. شكرا لكم.
Thank you, Dr. Abdu. It was very great to hear this update, to update my CV. Let's have 2 minutes for questions. Then we can have another further question. Abdu is approachable, as he mentioned, so you can take him all the night for more questions. But let's have 2 questions or 3 questions quickly.
Thank you, Dr. Abdu. First question I want to ask about the biography. Biography. Yes. There is, you have said the resume, CV, and there is biography. What is your opinion about the biography?
No, there is a CV and there is a resume and personal statement, which is letter of interest. Yeah. A bio, what I mean by the bio or summary, it's a bio, it's like a cover letter or the bio that you put it on the summary on the first area on your CV. There's 2 things, CV and personal statement or letter of interest.
No, not the personal statement. Biography also, it is a chronological history of the نفس السي في بس in a chronological way and in a story way. Is it right to submit this instead of the CV or not?
Instead of CV, no, I don't think so. For academic purpose or for the official position, you can submit rather than the CV. Resume is just for Zamzam, for an official position or just a small opportunity that you should apply for it. The resume. The CV is more official, more academic, more for the official positions.
If the applicant feels that
دكتور صوتك مو واضح شوي تكرر.
If the applicant feels that the biography, which is his picture and the chronological statements show him better than the CV in the place he wants to apply for.
Good. Go for it. Whatever the opportunity that can help, or whatever the paper that can help, hunt it. Biography, cover letter with the personal interest only, CV or resume, whatever can help, biography or summary about yourself, it's amazing. It can work.
Okay, for yourself, for example, now you have experience, mashallah, and you want to submit a CV.
Yeah.
You have said just now that, for example, Dr. Anas Hamam told you to bring your CV.
No, Dr. Anas Bana.
Or Dr.
Anas Bana, if you want to, if you want me
to. For example, mashallah, if you attended multiple conferences and like that, would you put them in the CV?
No, you're going to choose. Yeah, this is a so fantastic thing. I cannot write that I have been doing this workshop because I'm doing it. Last time I did it, I think 2 weeks back.
For example,
I cannot write it.
For example, 20 or 40 conferences.
Yes. I'm going to say that I have been doing this topic for 12 times or 13 times, or I can have an impact. I said that I have been reviewing a CV. Look for something that
that is starring.
Yes, it's gonna make you shine more and more.
Yeah.
Thank you for this great question. Any other question?
إذا ما في ترى لسه في عندي واحد صغير بس صغير سؤال صغير مرة.
Can we delay to the next?
بس الأوفيشال إيميل لازم يكون حق الأورجنايزيشن ولا لا؟
It can work both, official email or the institutional email.
My advice, your personal. لأنه it's
We are
you
not
never know
here.
when the response will come from the organization.
Yeah.
طيب. Our next, thank you, Dr. Abdu. Our next speaker is Dr. Ahmed Uthman. Dr. Ahmed Uthman is a consultant in pediatric emergency at Prince Mohammed bin Abdulaziz Hospital في المدينة. He is an assistant professor in pediatric emergency joint appointment in College of Applied Medical Science in Riyadh at King Saud bin Abdulaziz University. He will talk today about how to choose a specialty. Please welcome Dr. Ahmed Uthman. شوف هم عبده اللي تأخر عليك يا أحمد ها؟
ما مشكلة. We'll take from جمال دحين. طيب. السلام عليكم. First of all, I will thank the significant scientific committee for the invitation.
الصوت دكتور أحمد شوية أعلى.
قرب
المايك.
Yeah. السلام عليكم. First of all, I would like to thank the scientific committee for the invitation. It was a wonderful journey during this conference, and I hope I can add some information for you to choose your subspecialty. Okay, so we'll start with no disclosure. I have no conflict of interest, but unfortunately, I love my subspecialty and I can't hide it. So we'll start with the fact. Okay, choosing your medical subspecialty is a significant decision that requires consideration. What medical subspecialty you're going to choose is not going to only affect you, it have a major impact on you, in your family, and even in your country. So choose it carefully, take your time for deciding which subspecialty you're going for. Unfortunately, no one can decide for you. It's only you can decide which best interest for you. When should I start thinking? Is it during my medical school? Is it during after my internship, my residency, or after being a consultant? So my message for you is never too late. Okay? So what we're going to do, we're going to give you some tools that help you to reach your subspecialty or your goal in which subspecialty you're going to reach. So we start with what's your passion, what's your strength, how does the work affect your life balance, business. I know it's one of the controversy between physicians, but we need to mention it. You need to do your homework about the subspecialty, look for the mentorship, be open-minded for the changes and the future, and eventually follow your goals and dreams. Okay, so find your passion and interest. What means that all of us, as a medical, we went to medical school looking for one thing. So we're looking for saving of the patient, and after God will, we're going to help in curing them. Well, this is general passion, but look for deeply about what's your true passion. So when should I look for my passion and how I can find it? So as I mentioned, it can start during your medical school, it can be after internship, your residency, and even after a consultant. It will find you, don't worry. Some will say, okay, I didn't find my passion. I'm still a consultant, I can't find my passion. Don't worry. You're already reaching it, but you don't know yet. So things that help you to find your passion, you need to decide which part of medicine you find yourself most fascinating about. Are you guys from the group of physicians that you, as a frontier, they see the patient as beginning, stabilize them, or you are a group of physicians that would like to have collaboration with other subspecialty to reach for definitive diagnosis, for example, or a group of physicians that you're looking for a long-term outcome of these patients. So we go for the cornerstone. So you need to decide what kind of patient you want to engage, and based on your patient, it can affect your passion and even can affect your decision in which subspecialty you want to use. It can be a gynecology, it can be a neonatal period, pediatric, adulthood, or even geriatric. Okay, so choose carefully who's going to be your patient. So consider not only what you are enjoying right now, but what may also continue to challenge you to spark your interest for years to come. And this is very important. Don't have this tunnel vision. Just look for when I be a consultant, and that's all. We never stop learning. We continue to the end of the day, inshallah. So, other part, find your strengths and identify your skills. I would not say that find your weakness. I would say take the opportunity to improve your weaknesses by choosing your right subspecialty for you. So I know, guys, all of you have strengths and skills, but I will show you some of the strengths that you and the skills that you already have in it, and based on it, you can base and build which subspecialty I'm going to use. So handling the stress. Stress is going to come to you. So I'm from medical side or non-medical. So it depends on you how you're going to handle stress. Are you easy with the stress? Are you going to have problem with the simple stress? Okay, so this is very important strengths that you may have. Adaptive. Are you easy to be adapt to a fixed routine, or you are not willing for a fixed routine? You want to go for something that you control the work, not the otherwise. Environment. You need to see yourself, I'm willing to adapt for a change of environment. You may work in a city one day, and you may work in a village the next day. So look for yourself. What's the specialty that I will stay in the city for a long time? Is it okay for me to go for a distal part where I can do my practice? Communication skill. So all of you guys, you have a good communication skill. Look to the conference itself, that outstanding in communication. So all of us guys, we have a communication. But it depends. Some specialty, you don't need that much of communication. Some specialty, you need to be communicate with everyone, like we do in emergency. We communicate with everyone, from the hospital, from administration, to community, to patient. So different from subspecialty to subspecialty. So look which subspecialty that's going to corner your communication, and you build from it. By the way, emergency, they have good communication. We're not fighting with everyone. We are just looking for the best of the patient interest. Look for your procedure. You are from the people that want to do a procedure, or you don't want to be engaged with any procedure? A simple procedure may take a few minutes, and a long procedure may take like a few hours from your time. So look for that one. And again, we go to the patient, how long you want to be in contact or engage with the patient. Is it for short period? Is it for long period? So determine your work-life balance that you want. From day one we went to medical school, they already teach us that look for the patient health, look for the best of the patient. But I think it came right now the time that you look for yourself. So your health came first. You need to sit with yourself. A healthy person is a healthy life. So you need to look for yourself, okay? How does my subspecialty going to affect my stress situation? How it's going to affect my daily routine? How to affect my quality time? Okay? And I think this is one very important thing that should I consider it by myself, or should I discuss it with the family? Should I discuss it with my parents? Should I ask my wife? Should I ask my husband about my subspecialty? I think you have to. Because discussion with them, listen to their outcome, explain why you choose this subspecialty, it helps you a lot. And believe it or not, your loved one will support you to the end. Okay, look for social gathering. Are you going to eventually be a consultant, going to do home on call or in-house on call? What about Eid holiday, Hajj holiday? So you need to consider these things while you're applying for subspecialty. Look for the number of years that you're going to be trained. Is it going to be a few years for residency, like 4 years of residency, like adult emergency, pediatric, or it's like going to be 7 years, like a plastic or neurosurgery? Okay, you finish your residency. How long for my fellowship? Is it 1 to 2 years? It may take 3 years. You finish a consultant. I'm doing a master. How long did my master need? 1 year, 2 years? I'm looking for a working hour. So working will take a lot from your time, but certain subspecialty will take a longer hour. Unfortunately, this longer hour most of the time is unpaid. You're going to pay it from your own time, and unfortunately from your family time. So prepare yourself for that one. We come to something that it's a controversy between physician and other people. Should we put the money on the table? Should we discuss money or not? I think looking to the future, money should be on the table. You need to discuss it. It's not only for you. It can also for your family. You need to look for them. Okay? Be careful. Money should not be the only factor. So once you learn a subspecialty, most likely you're going to learn a procedure or skills. See how you can utilize these skills in your time or a business. Can I provide my subspecialty as a secondary income for my salary? So looking for invasive versus non-invasive procedure, looking for about off working hours. So after you finish, you already have your most likely subspecialty in your mind. You need to do your research. So do your homework. Sit with yourself. Bring a cup of coffee. Sit with yourself. You need to to understand this is a crucial step. Okay? So don't think that everything is come to you. You need to do your part. Okay? So prepare your question, look for it as a long term. Gather information. So how I can gather information, I will do research about my subspecialty. Start with asking. Look for your senior consultant, look for your colleague. Start asking, is it beneficial for me or not? Okay? If not, go to the website. Okay? The Saudi Commission right now providing a manual for all subspecialty in Saudi Arabia. You can look for it. It have and all the information you need, and you can even ask if you have a question to be asked. So which training center? I think this is one of the obstacles right now. Which should I do locally? Should I do internationally? Which center should I do my rotation on it? Two things you need to balance it. It depends about exposure and education. So you don't want to go to the hospital with high rate of exposure, but unfortunately no one is supervising you or monitoring you. And at the same time, you don't want to go to the hospital where someone just giving you a lecture with no patient. Okay? So the Saudi Commission right now is helping in this part, providing an extended rotation, so don't worry. Even in the hospital there is no patient, they will ask you to do an extended rotation. So don't corner yourself to one specialty yet. Put your mind that may I have 3 to 4 subspecialty in my mind, okay? And with the time, you're going to find the most likely true path for it. Okay? So explore your wide range of subspecialty. So explore your mentor and explore your option and your mentorship. One of the important things after you decide you want to be an emergency, you want to be a pediatric, gynecology, you look for the mentorship. Look for someone who can direct you, who can give you insight about subspecialty, who can direct you in the future, what is the good for you or not. Okay? If you ask me personally which kind of pediatric emergency mentor you will recommend, I will recommend, for example, Dr. Mohammed al-Muttari, Dr. Amal Yusuf, Dr. Osama Kintab. They are pioneer. You will love the subspecialty from the day one. Okay? But be careful. Don't look for one mentor. Start to look for other mentor. Maybe one day you will join the rotation with me, you will love it. The next day you will hate it. So try different mentor because every mentor have his own way to adapt to life. Okay? Which may implement it for you and may not. Ask for shadowing. I think this is usually applied during internship, during residency. You're doing a shadowing with your service and see how it's going to affect you. Is it easy? Is it what you want for it to be or not? So be open for different possibility. You're more often going to be changing your mind several times before you find it to one subspecialty. You're going to have different way. Don't worry. It's okay. We all went to that place. Just stay open-minded through all the process of your journey. Use your exploration during this process. Use your opportunity which was open, challenging, that will help you to direct you to the appropriate path for your subspecialty. So being open to all subspecialty can help you to figure out your true passion and which area in medicine will bring you to the most fulfillment. Now, you already decided what kind of subspecialty you want. You want to go to pediatric, you want to go to emergency, you want to go to gynecology. Set your plan, okay? Astakhir, tawakkal ala Allah. So just do it, okay? Sit with yourself. Just plan it right now. Khalas, I decided to go for this specialty. I already asked, I done my homework, I'm planning for it. Just do it. Only 2 things we emphasize on it. It's a time management. So you need to have a time frame for it, okay? You need to see if it's going to be suitable or not. And once it's going to be suitable for you, you need to have a commitment. Don't listen to negative people. Believe it or not, people will come to you. Why you choose emergency? Why you choose gynecology? Why you choose forensic medicine? Don't listen to them, okay? They still tunnel vision. Look for it as what is your passion and just follow it. Be ready. Things was in my day wasn't available and right now open up, and things was open in my day right now is not available. So be ready for change. I think this is the beauty of human being. We adapt to changes immediately. So in conclusion, choosing a medical subspecialty is a personal decision, and it is important to find a field that aligns with your interests, passions, skills, and long-term goals. Take your time, gather information, seek an advice, and trust your instinct to make the best choice for your future career. This is my reference. This is an excellent textbook. It's available in the market, and it's providing a quick survey. You can go through the website itself. You can register. They're going to give you a few questions. You're going to answer it. At the end, it's going to give you not only one specialty, he will give you all the specialty in ranking. So he's not closing the door for you. He's opening it and just prioritizing which is based on your answer. Thank you.
Dr. Ahmed. Thank you, Dr. Ahmed. And it was very well organized. Speak to the point. That it will not help me a lot, but I hope it will help the others to find their way through the specialties. Any questions?
Yeah, it seems they already find their specialty.
Yeah, it is very nice organized, wallahi, speech. We appreciate the speech and thank you, Dr. Ahmed.
الله يعطيك العافية دكتور.
Our next speaker is Dr. Raed Jamal. He is a pediatric emergency medicine and acute care consultant with a point of care ultrasound subspecialty. He is working in Uhud Hospital in MOH in Al Medina. Please welcome Dr. Raed to give us a speech about transition to practice. Thank you.
Assalamu alaikum wa rahmatullah. Things looks different from this stage. Kind of like looking back at your career, like either retrospective or forward. Something like going through that transition into practice. Transition into practice, something can be either from medical school to residency or even to fellowship or even to being a consultant and attending. So this can be applied for both, like postgraduate, but also for those that we can call as advanced practice providers. So I have no financial disclosure. I made it because of this topic is so long and you're going to see a lot of references and website for this one. I made it like tips. So it's a top 10 tips for TIP, which is an acronym for transition into practice. And fun fact here is that not only that transition into practice is a program that is done in different hospitals around the globe, but I even found like there is some programs that is going through 6 months and some is 3 months. And there is with the American Academy of Pediatrics, they have a fellowship which is transition into practice for a 1 year. So starting with tip number 10, create a presence. What I mean with create the presence, it means that feel the presence, be the presence, and also create a presence. The presence should be starting with how would you dress? How would you talk? How would you be your personality with your colleagues, with your patient? This, yes, is coming with time, is like developing your skills, but it has to be a unique, something that you be on a highest standard, not something that you make it a secondary thing. No, this should be a priority for you because it will leave the impression that others will remember you with. Tip number 9, balance your autonomy versus asking questions. So this balance is a delicate one because usually autonomy, that means that you have the freedom to do what you think that this is the best for your patient. But rather sometimes there's your ego speaking inside of you that I don't have to ask someone. This is my specialty. This is my field. I should be the one who decide in this area. But this will be a trap. Always when you have your ego talking, that's when things go bad. Asking questions, not only for you when you're being a resident or even a fellow, but all the time, even when you're a consultant. I talk to my colleague, Dr. Ahmed, from time to time, and I'm a consultant and he is a consultant. Just take an opinion, ask questions. Not always it's just about knowing what's right and wrong. Sometimes it's just having another opinion or what we call an eye-opener. Tip number 8. As you go forward with your career, it will get, unfortunately, higher workload and responsibility. Things will not get easier with time. You'll have more responsibility, more things to do, more things even to study and to discover, to review. You'll have people to monitor, you have people to exam, but this is life. And with time, that's what I can consolidate you with. Is with time, hopefully it will get easier. But there are also some soft skills that can teach you how to get easy with this. Tip number 7, being a professional. Something is really essential, yet people still, like the most of the time, the understanding and the concept for that is not really acted on, I would say. If you ask someone how to be professional, he will say it's to be committed to the highest standard in excellence, in practice and in ethics. But while this is a definition that we all know, in reality sometimes we're lacking this one. Being a professional means you have to stick with the highest standards of ethics. You have to be a reliable doctor. You have to be an honest one. You have to be a hard worker. All these features and others is being a professional, not only when someone or your senior is watching you. This has to be a characteristic in yourself, in what you believe, in what you do all the time, whether someone is observing you or you are the observer after a while. You'll be a consultant, you'll be attending. This never goes away, professionalism. Tip number 6, build your curriculum for your own career. Always what we are value is and deliver in our future and our career is the one and the self-development that we do in ourselves, in your career. This is never late, and also this is pre-training and post-training. Even where you finish your fellowship or you're being a consultant, you have to build also your curriculum. Where you're going now, are you going to be a researcher? Are you going to be an instructor? Are you going to be an educator? Are you going to build something like an institution or a program? This needs a plan, so it's always a process that needs to be done. Tip number 5, making mistakes. This is one of the tips that I just love to emphasize. It's okay not to know everything, and it's okay to know that you are going to make mistakes. I did mistakes. I believe everyone will make mistakes. It's okay. But the big question is, how would you learn from this mistake? How would you learn from this trivial happening event? Because you're going to see it in your life and in your career where you're going. Some of your colleagues might have a trap or this black hole. They will get stuck in this mistake and they will develop, some of them, a phobia for this event or this procedure or this disease. And others, they might even change their career or change their practice based on one mistake, whether it's a big one or a small one. So making mistake and how to deal with it, how to handle the mistakes, how to learn from mistakes is something I can't really teach it right now or to discuss it with you immediately. It needs time, it needs mentors, it needs sometimes help. That's okay. There are programs for that. There are people that can help you, and especially the mentors. But it's okay, and everyone, this is the important lesson here, going to be making mistakes. So the lesson here is how to learn from these mistakes and to keep going forward. Tip number 4, build and protect your reputation. This is, for me, I think it's very, very important point. Building your reputation takes years. You wouldn't be able to build a good reputation and people will know your name and that this name renounced in a very nice and good and elegant way unless you get really hard and sweaty in building your own reputation. You can't have a good reputation if you're just being all the time in your field or in your work, you're just throwing jokes here and there. People will not get and make a serious relationship with you unless you're being serious about your work and your relations with your colleagues. And that's also can have an input with being a professional. So protecting your reputation is something very essential. You will know the value for that. If this is something can be a currency, this is how much you are valued in people's eyes. You need to know that sometimes if you did something out of being I don't know, I am bored, I just want to do something funny, or I want to try something new, you might really lose something very valuable, which is your reputation. Tip number 3, learn to say no. That's usually what you hear in different YouTube's video or even lectures. So they will tell you that, or even books, learn to say no. I would say, learn to say yes. And which one is true? Which one is right? To say no or to say yes? Well, the short answer will be, it depends upon your personality. If your personality is a one who always being defensive, you don't want to try anything new, you just want to be in a safe zone, then I would recommend for you to say yes. Try new area, try to participate in new things. Admin, research, community, whatever you want, whatever you have a feeling for it, just go for it. And if your personality is always saying yes, 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 then you will get burned out and you need to learn how to say no. So it depends purely on your personality. Tip number 2, find the right, not mentor, mentors. That means sometimes in knowledge and medical, you might need one mentor, but you might need more than one in different fields. So having a mentor that can guide you, even when you're becoming a senior or a consultant, having a mentor that can just thinking out loud with you, reviewing or giving you feedback about an idea or initiative or whatever you want is really, really important. This is emphasized even in different specialties, in different fields, not even in medical field, no, in different fields. Mentors always having like it's an outside brain for you. And tip number 1, give back to the community. Your mom, your father, your wife or your husband, your children is waiting for you. They waited all these years for you to graduate, for you to be a doctor. And in return, all this time, they're praying for you, they're advising you, they're guiding you, they're helping you. They're waiting something in return. That's not their goal, never was, never will be. But they deserve more than this appreciation. They deserve to be helped, to heard, to have time for them. Not only your family, your community, your city is waiting for you. So after all this time, you're having residency and maybe fellowship, or maybe farther, you study something more. And then you'll just cornered in one hospital and you'll not being any active in any field. This is unfair for your community. Give back to your community, give them help. And when we're saying give back to the community, this is for free, not something that you'll do it for money, for return, for a certificate that they will give you at the end of that day. No, it's something you do it for free. And as of my colleague said, this is a reward. This will have your burnout go away. This will give you happiness. This will give you a bliss in your life. And that's why I want to thank يعني أنا ما كان لي وجود في هذه الدنيا ولا في هذا المكان لو ما كانت ستي وأمي اللي ربوني. أنا يعني في الأخير حسنة من حسناتهم. I would like to thank my father, my wife, and my children, and these are my resources. Thank you.
يعني what a closure Dr. Raid for the day. يعني it is the best closure with يعني حتى الكاونت داون يعني مرتب لكم هو 4 3 2 1. It's super excellent. I يعني myself I was enjoying the talk as the previous talks, but it added to me also a good. I was happy to listen to this advice and refresh our memory about how important to give back to the teams. Any question for Dr. Raid? Please, Dr. Ahmed, to join us on the stage. No questions? طب comment? ها تفضلي.
Firstly, thank you, Doctor, for your lecture. I've been quiet the entire day, but I really enjoyed your lecture. I think the lecture that resonates with most people here on how to like apply yourself and how to get well and work well with a community and a team. I especially liked you thanking your wife and children at the end of the lecture. I really resonates with the last slide of how you cannot work without a community. And so thank you.
Thank you all. Thank you. You have time if you want to say anything يعني للquestion أو الcomment هذا. يعني to be honest يعني it is very opening closure to the day that open our يعني even mentally to move forward and motivate us to do more in the future and remember our beloved people that we are doing our best to retain some of their favor.
أنا ما عندي إلا أقول يعني أسأل الله أن يوفقكم، يفتح عليكم، ينفع بيكم، يسدد طريقكم، لكن I don't have anything else to add. ودكتور أحمد من الناس اللي دائما استشيرهم، والدكتور همام فضلوا على الكل، الله يجزاكم خير. Thank you for your attendance, thanks for the committee, and الله يوفقكم.
Thank you. We want to, Dr. Ahmed, if you can join us, then we will take a group picture. وانت رائد قالوا لك انت استلمت هذا، فاحمد اللي بابا استلم. اعتبر انك انت بتديني، قالوا هذا لي. عبدو انت المفروض ما تجي، نحن we called all the speaker and you didn't تعال. جمع كل البرايزز حقتها. تعال يا شيخ. يعطيكم العافية وشكرا لك وشكرا للجميع. يعني wish you all a happy rest of the day and wish you the best in your future. Thank you. يعطيك العافية.